by Dr. Eugene Tardy called Rhinoplasty, the Art and the Science. You should definitely go through this book because I think the first volume is almost dedicated to anatomy and assessment. And it's a wonderful way to start your rhinoplasty journey, I think. So let's talk about the topography and the landmarks. We'll go from above downwards. The glabella, which is the most prominent part on your mid-sagittal, on the frontal bone between the eyebrows. As we come down, now there are three terms which are used quite interchangeably: nasion, celion, and radix. Now the nasion and the celion are bony landmarks, whereas the radix is what is actually the soft tissue landmark, which we also refer to as the root of the nose. So the nasion is actually the midpoint on the nasofrontal suture line, and as you can see on the diagram, and is often confusingly referred to as the deepest point. It's not the deepest point on the nasal root. It's actually the celion, which is the deepest point on the nasal root or on the nasofrontal angle. Again, to give you a slight idea of how the suture is where your nasion is, and the celion is a little below that, a little caudal to it. This is the deepest point of the nasal root on the bone. Now, when we talk about what corresponds to the celion on the skin, this is what is the radix, and again is used interchangeably. And so this is the deepest point on the nasal root on the skin, and on the bone is the celion. So as you can see, the celion is on the bone and the radix is on the soft tissue. But again, when we are practically using these terms, we can use them interchangeably. So the nasion, the celion, and the radix. Now, let's talk about the nasofrontal angle. I'm going from above downwards now. So it's the angle which is between two planes. One plane which passes from the glabella to the celion, and another plane which passes from the celion to the nasal tip. It's actually an obtuse angle. These numbers are really not very specific, but I think when you start assessing patients, you come to know that more or less it's an obtuse angle, and you will come to know when it's too deep or it's too shallow. So just to kind of give you an idea how the nasofrontal angle looks on a male and a female, applied anatomy for it is that if the nasofrontal angle is too deep, the nose only apparently looks to be short and has an increased projection. The red line is when we are trying to tell you that the nasofrontal angle is very deep, or the radix projection is a little low. So the nose will actually start to look short. It will also look as if it has an increased projection. Similarly, if the nasofrontal angle or the radix is shallow, then what happens is that the nose looks that as if it's very long. It also is the part where it looks like there's a pseudo hump or something. As you can see in this diagram is again from Eugene Tardy's book, where you can see a deep nasofrontal angle or a deep radix and a shallow one. Now, when we're talking about the nose, we divide it into certain aesthetic subunits. The nasal dorsum, of course, the nasal tip, the soft triangle, and the alar lobules. So the nasal dorsum, of course, is the upper 2/3 of the nose. It's also known as the nasal bridge because it bridges the face to the tip of the nose. It's formed by, the shape is due to the bony cartilaginous framework which lies beneath it. The upper half being formed by the nasal bones and the lower half by the upper lateral cartilages. Now, when you talk about the nasal dorsum on the frontal view, there are dorsal aesthetic lines, very important. Views are changing about it now, but still I think conventionally a lot of us are following dorsal aesthetic lines. This is a key to a very pleasing looking nose. Now these are two concave diverging lines which connect the eyebrows to the tip defining points. They are graceful, they are concave, and they are smooth. Now due to any reason, if there's an interruption or there's a poor position of these lines, the nose starts to look unaesthetic, which can also happen in a crooked nose. When we're talking about the nasal dorsum from a profile view, again, it's a smooth continuous line which extends from the forehead to the tip. Again, this continuity or the smoothness can be interrupted by either a hump, it can be interrupted by a saddle, or a very under-projected nasal dorsum. Now, rhinion, again, is a soft tissue landmark. This is the junction of the nasal bone with the upper lateral cartilages on the nasal dorsum. Now, these landmarks or topographies are more or less used also for assessment. I think the second lecture is for assessment, because you have to have some kind of terminology for every part. So when you talk about the nasal lobule, it's the entire lobule on our nose. So This area includes the supratip break, the nasal tip, the anterior half of the lateral alar wall, and the upper edge of the nostrils. So this entire area on our nose is the lobule. Further subdivided into the supratip lobule, the tip lobule, as well as the infratip lobule. So this is the lobule. In general, if someone refers to the nasal lobule. Now coming down, further down, we're still on the topography. The nasal tip topography actually consists of 4 important points. So the nasal tip shape, of course, is due to the lower lateral cartilages. We're going to talk about them further down when we're talking about anatomy of the cartilages. But landmark-wise, there's a supratip break. The supratip break is a slight depression which is just cephalic to the nasal tip. It's called the dip before the tip. Not very important from the Indian point of view because Caucasians have thin skin. They really like that dip before their tip. Not very easy to achieve in a thick Indian skin, but again, this is something that you should be aware of. Now, tip defining points. These are 2 symmetric points which are formed by the dome of the lower lateral cartilage. This is also the most projecting area of the tip, and it is revealed by the incident light which reflects from each side. Not a lot of women in the hall. Otherwise, makeup routines nowadays are focusing on highlighting and contouring. And one of the points that you highlight with your makeup is actually the tip defining points. Pronasal is the most protruded point on the apex of the nose or the most anterior midpoint on the nose. The infratip lobule lies just below the tip lobule and is bounded cephalically by the tip defining points and caudally by the columella. So that is the infratip lobule. Applied anatomy wise, the tip, 2 things we need to be aware of again is the projection and the rotation of the tip. I don't think again that numbers have a lot of value on assessment, on practical assessment. You can make out when a tip is upwardly rotated or downwardly rotated. We try to figure it out with the nasolabial angle, which we'll be talking about. Again, projection, a tip can be over projected or under projected. Now, very important from rhinoplasty point of view, also for people who are starting off with rhinoplasty is the soft triangle. I put this diagram to show you that, of course, the soft triangle is formed by the faucet, which is at the caudal edge of your lower lateral cartilage. Now, there's nothing there. There's no cartilage in that area. There's just fibroareolar tissue as well as their skin. So the skin which is covering the nose and the vestibular lining inside. There is no cartilage, only thick skin in this region. So this is the soft triangle. Now, why it's important is that when we start to do rhinoplasty and any kind of tip work we are doing, we are repositioning the lower lateral cartilage. Maybe we've not completely closed our marginal sutures. It can lead to soft triangle notching, and that's really difficult to treat because then that becomes a whole different lecture. But very important to keep in mind that you have to be very careful when you're doing any kind of dissection in the soft triangle. Alar lobule is again your lobule which is formed by the lateral crura of the lower lateral cartilage and the overlying muscles and skin. You have the vertical alar groove, the supraalar groove, and the facial alar groove. The nasal base is the caudal 1/3 of your nose. And this is actually seen when the patient tilts his or her head backwards. And that's the view we see. That is the nasal base. It's formed from, if we go clockwise, from the alar base to the alar lateral wall, to the soft triangle, to the infratip lobule, to our columellar pillars, to the columellar base, and the nostril sill. So this is the nasal base. When you're talking about nasal base, this is what defines it. Again, nasal base is only a soft tissue component. There is no cartilage or bone in this region also. It's all the skin and the tissue that is covering your lower lateral cartilage, the cephalic end of it. Again, depending on the fibrofatty tissue, also the shape of your lower lateral cartilages, you could have different configurations of tips, which you need to be aware of. Now the columella, we all know what the columella is. I just wanted to tell you a little bit that the columella shape is not only defined by the columella. There are 2 other things which actually, when you're assessing the columella are important. One of them is the caudal edge of the septum, and the other is the soft tissue, which is at the base of the columella. Becomes very important in cases like the Binder's syndrome, also in cases of cleft. This becomes important. This is when you get a hanging columella. It's not only due to the columella, it could be due to that excess tissue. Now, nasal sill is the lower or the inferior rim of the nostrils. This again becomes important from the Indian point of view, because a lot of alar flaring is corrected by alar resection, alar-based resection. Now, in Indian skin, that can lead to scarring and hyperpigmentation because we are prone to it. So a lot of times, to correct that, if the flaring is not too much, we can sometimes get away with just doing a bit of nasal sill resection to actually try and decrease the alar flare. Now, nasolabial angle, this is the plane which is defined by the nasal base as well as the upper lip. Again, like we've discussed before, it is used as a proxy for tip rotation. Nasofacial angle is again interchangeably used with your nasofrontal angle, and it's actually the angle which is formed between the pronasal and the pognion. Now we are done with the landmarks. Let's talk about the skin and the subcutaneous tissue of the nose. Now there are 5 layers of nasal envelope. There's the skin, there's the superficial fatty layer, there's a fibromuscular layer, a deep layer of fat, as well as the perichondrium and the periosteum. Now, when we're talking about the skin envelope, like we've seen so many cases yesterday, the skin envelope is actually the skin, the fatty tissue, and the fibromuscular layer, which together forms the SMAS, or the superficial musculo-aponeurotic layer. We'll talk about it a little later. Below that is the deep fatty layer, and this becomes our dissection plane. The skin also varies on our nose. It's not the same throughout. There are more or less 3 zones of skin on our nose. On our dorsum, we have very thin mobile skin, which doesn't have a lot of sebaceous tissue and is mobile. There's also thin skin on our columella. This is also thin, smooth, there's no sebaceous tissue, but it's not very mobile. The thickest skin is on our tip or on our supratip region. And particularly in Indian skin, this is the region where we find the thickest skin. And that's why tip refinement becomes a challenge, where we cannot achieve results which are very similar to Caucasian skins. Superficial fatty layer again is thickest at the radix and thinnest at the rhinion. So why is skin and subcutaneous tissue important from rhinoplasty point of view? So a Caucasian, I'm just giving you an example of a Caucasian who may have a very thin skin, has very less subcutaneous tissue. The pros in that kind of a patient is that you'll have very nice visible changes post-operatively. The changes that you've actually done during surgery are quite visible post-operatively. Post-op edema, because subcutaneous tissue is less, there's very less post-op edema, recovery is quicker. However, the cons are that if you've put grafts or if you've done too much work, because of the thin skin envelope, there's an increased risk of graft show or showing of irregularities and asymmetries. Whereas in a thick skin, like an Indian skin, the pros are that that thick skin envelope can help you camouflage all your grafts and all the reconstruction that you've done. The cons being that the results will be very limited, especially with respect to narrowing of the tip or giving very nice definition to the tip. Also, there's a lot of post-op edema, and the recovery is relatively longer than a thin skin patient. So when we're talking about the fibromuscular layer, from above downwards, you have the skin, the superficial fat, and then comes the SMAS. So this consists of the SMAS, the muscles, the fatty layer, as well as the neurovasculature. And this fibromuscular layer is very important for rhinoplasty because it allows the movement of your nasal envelope. It offers blood supply. It maintains the thickness of the skin envelope, encases and interconnects the muscles, and distributes the forces which are exerted by the muscles. So when we're talking about a plane of dissection, the neurovasculature, or all your blood vessels and all your nerves, lie in the supra-SMAS layer. And the rhinoplasty plane of dissection is in the sub-SMAS layer. Some muscles, from the muscular point of view, applied anatomy-wise, I would just want to mention the depressor septi muscle, which if it's overactive can lead to further ptosis of your nasal tip and also inward turning of your upper lip. So sometimes when you're trying to decrease an over-rotated tip, you can try and also resect or divide the depressor septi muscle. Vasculature, the nose is primarily supplied by the internal and the external carotid arteries. And again, this vasculature lies in your Smars layer. These diagrams are to show you that the nose is very vascular. So nowadays, a lot of people are also going in for non-surgical rhinoplasty, and it becomes a challenge again because of the vascularity. Sometimes there are aberrant vessels also, and it really is difficult to achieve a very good result because you may actually go into a vessel when you're going for a non-surgical rhinoplasty. Then there's your deep fatty layer, which is our plane of dissection. From the vasculature point of view, two things that are important, and yesterday we discussed in the case, is the angular artery, which is important while we're doing osteotomies, because we can injure that. And actually, there is a lot of bleeding which can occur due to that. And the columellar artery, which is in our inferior flap when we're trying to raise the skin envelope. These do tend to bleed. The perichondrium and the periosteum. So rhinoplasty plane of dissection is always supraperichondrial and subperiosteal. Now the nose is divided into three vaults, the upper, the middle, and the lower vault. The upper vault is formed by the bones, the frontal process of maxilla, and the dorsal bony, as well as the cartilaginous septum. Again, becomes important when we are doing our osteotomies. During our lateral osteotomy, we need to be careful of the lacrimal system. And during our transverse osteotomy, we need to be very careful about not going too upwards and directing it a little cephalically so that we don't cause a CSF leak. The keystone area is also very important. This is actually the center of support for your nasal roof or your nasal dorsum. And during surgery, we need to be very careful that we don't try and injure it. Because if we injure this, then again, there's going to be mid-vault saddling. So this is the keystone area. And you can see if we damage this area, there is saddling which can occur. The mid-vault is formed by the upper lateral cartilages and the dorsal cartilaginous septum. It begins from the keystone area and goes up to the lower lateral cartilages. The upper lateral cartilage is also important because the caudal edge of your upper lateral cartilage actually forms the boundary of your internal nasal valve. So if there's any kind of nasal valve defect, we try and correct it by putting a spreader graft in between the septum and the upper lateral cartilage. Over resection in the area of the upper lateral cartilage can lead to something which is known as an inverted V deformity. The lower vault consists of the lower lateral cartilages and the dorsal cartilaginous septum. The lower lateral cartilage has three parts. It has a lateral crus, a medial crus, and a middle crus. Middle crus is what forms your domal segment. And coming to the nasal septum, we all already know the anatomy of nasal septum. Just 2 points again that we discussed yesterday, important from rhinoplasty point of view or septoplasty point of view, is L strut preservation, which is the 1 centimeter approx of dorsal as well as the caudal septal cartilage that we need to preserve, even if you're trying to take out a septal cartilage graft. And also important to identify the anterior septal angle when we're trying to dissect the septum, when we're trying to raise the mucoperichondrial flap over the septum. Because when you identify the anterior nasal spine, as you can see in the diagram, it's easier to go into your correct plane. Again, from nasal septum fixation points, these are very important. And yesterday we were trying to actually try and fixate the septum to the anterior nasal spine. And as we've already discussed, the keystone area, the area above is the keystone area, which need not be disturbed. And then we try, if we've done any kind of manipulation below, we try and do a anterior nasal spine fixation. Nasal tip support, there's a major and a minor tip support system. Major tip support is mainly formed by the size, the shape, and the resilience of your lower lateral cartilages. Also, its attachment to the quadrangular cartilage and the attachment of the upper lateral cartilage to the lower lateral cartilage. These are the three major support systems. Other than that, of course, the rest of the structures like your anterior nasal spine, skin, musculature, ligaments, they become very important in your minor support. So there are a lot of nasal ligaments which we do end up dissecting, and it's important that we, after rhinoplasty, we try and close it in a manner that that strength is still maintained. So you have interdermal ligaments, you have intercrural ligaments, you have the scroll ligaments, all of them are dissected during rhinoplasty, and it's important that we try and suture it back so that the strength is maintained. That's it. I think my time is up, but I'm an ENT and I'm actually practicing aesthetics quite exclusively in my practice. This is a small, I think the video is not playing. Video nahi play ho raha hai. It's okay. I'm also wanted to tell you that we're starting a diploma in aesthetic medicine along with the Canadian Board of Aesthetic Medicine. So it's a Canadian board certified program where you will be taught Botox, fillers, lasers, which you can try and incorporate into your surgical practice. And as surgeons, we actually have an upper hand where the learning curve for these procedures is not much, but actually has an added advantage to your practice. So if anyone is interested in that, you can please contact me. Thank you.
Thank you, ma'am. Thank you so much. Or ladies and gentlemen, just heading toward, आइए आगे बढ़ते हैं. Now I would request to Dr. Lokesh Kumar. Ma'am, please आपको रुकना है सिर्फ 2 मिनट के लिए. So now I would like to request Dr. Lokesh Kumar to come upon the stage along with Dr. Pradeep, Dr. Sunil, and Dr. Tarun to felicitate our speakers. Thank you, sir. Thank you, ma'am. All right. So, ladies and gentlemen, now I would like to request our second speaker. Please welcome Dr. Shubham Agarwal, sir, on stage. Thank you.
So good morning, one and all. Just a brief CV of mine has already been mentioned by respected sir. So today I'll be talking about preoperative planning and evaluation. Right. So before taking a patient for surgery, a schematic clinical approach of the patient is a must. Stepwise evaluation is important for a patient before taking the surgery for the patient. So it includes the preoperative consultations, the photographic documentations, and the clinical assessment of the patient, including the quality of the skin and classification of the deformity, most importantly. So we'll be talking about each and every point in detail. Starting with the preoperative consultation. The preoperative consultation, sitting face to face to the patient, gives you an idea regarding the vibes of the patient, how the patients behave, what are the concerns of the patient, and what are the managements, what the needs of the patient. So this plays a very important role in operating a patient, right? So this will guide you regarding whether you want to operate on that patient or not, right? So the patient's demand versus doctor's concern. So from the patient point of view, the patient has to list his 3 specific concerns. What are his requirements in the order? While from the doctor's point, he should have a history of the patient. That is the nasal history, which includes any nasal obstruction is there, any other complaints such as the medical and the surgical complaints, which includes any history of allergies, nasal allergies, any history of trauma is there, or any history of any previous surgery. So these are very important factors which will help you in managing your surgery and evaluating your surgery. Then after the history, you come to the physical examination. The physical examination includes the inspection. That is, in inspection, you see for the skin contour. How is the skin? Is it thick skin, or any skin has got any lesions or dilated veins or anything is there? Or look for any obvious deformity, like a very obvious aesthetic deformity can be visible on the skin on inspection. On palpation, you can talk about any irregularities are there, like can have bony irregularities or any cartilaginous framework, depressions are there on the nose or not. Then coming on to the nasal examination, then you should look for any obvious deviated nasal septum is there, or any turbinate hypertrophy is there. And coming on to the specific test, such as the Cottel's test. This will guide you regarding the obliteration of the internal nasal valve or not. And importantly is the tip recoil test. This will guide you for whether how is the structures underneath, what is the consistency of the cartilage, is there any surgery being done, so the tip support won't be there. So if the nasal septum is missing or the inverted L is missing, then the patient will have a good tip recoil. So this will guide you what is the structures below and how is the consistency of the cartilage underneath. Right. So a detailed examination of the patient is a must before taking the patient for surgery. So once you evaluate the patient, you should know when not to operate. So there are some danger signs which should be borne in mind or kept in mind. This include mainly the minimal disfiguration is there, or the patient has got any psychiatric disorders like delusional disorders or any identity problem, or most importantly, the patient has got any unrealistic expectations. Many a time the patient comes to you that with a photograph of any third person or a model that I want a nose of that shape or size. So that has to be, those sort of patients needs to be avoided because you cannot fulfill the expectations of that patient. Now the second segment after planning comes out to the standardized photography and digital imaging. The standardized photography is mainly done for 6 standard views, which includes the frontal view, the lateral view on both the sides, that is the right and the left side, and the oblique view, and which is also on both the sides, then the basal view. So these are the standard 6 views which are to be taken. And the 7th view is a dynamic view. This view is required in most of the times, such as the smiling view, because many deformities which are not readily available, apparent on the static views are very well visible on a dynamic view, such as already been mentioned the previous, by the previous speaker, the overactivity of the depressor septi muscle. While in a smiling view, you can see that the tip of the nose, there will be a drooping. A drooping is very well visible, right? So these dynamic views are important. So for the photography, the standard distance from the patient should be around 6 feet. The photographer should be there at a distance of 6 feet, and the illumination should be on both the sides at an angle of 45 degrees. So the light illumination should be at a 45 degree from the photographer placed, and this will avoid any distortions on the photography or any reflections in the photography. Now, all these views should be taken in a standardized plane. So there has to be a standard plane in which these views should be taken. So that plane is said to be as a Frankfurt's horizontal plane. So what is a Frankfurt's plane? It's nothing, just a horizontal plane extending laterally from the upper border of the external auditory canal and going medially to the infraorbital margin. So all these views should be taken in this standard Frankfurt's plane. So we'll be talking about all the views. So starting with the frontal view, as everybody know, or it's been mentioned previously, a face has been divided horizontally into equal 1/3, upper 1/3, middle 1/3, and lower 1/3. Similarly, vertically it's been divided into 1/5, right? So in a frontal view, all these equal 1/3 and 1/5 should be visible, and the face should be straight in a Frankfurt's plane. And the dorsal aesthetic lines, that is the brow tip lines, should be visible in this particular frontal view. Next important view comes is the lateral view. Now this view is also called as the profile view and is the most important view of all the views because it will guide you regarding the projection, rotation, and radix angle. So these are the three important parameters which we can calculate on a lateral view. So these parameters will guide you what all elevation you need, what all projections, rotations are required in a post-operative patient. Then comes your oblique view. So it's basically a confluence of a frontal view and a lateral view. So most of the patients, or if a person is being seen, it's mainly in the oblique view. So this is the most common view when you see a patient or when you see a patient, right? So it's oblique view. The picture is taken in a Frankfurt's plane where the nasal tip should confluence with the opposite side of the malar eminence. Then comes your basal view. The basal view, it's being taken when the nasal tip should touch on or confluence of the glabella, right? And the nasal base should form an equilibrium triangle. This is the most important point. For a basal view, your target in a post-operative position should be like it should create an equilibrium triangle. And the alar base width should correspond to the intercanthal distance. Now, if it's more than that, you need to do a alar base resection. So this should coincide. Then moving on to the third segment, that is called as the surgical assessment of rhinoplasty. Right. So we already talked about the planning, then surgical assessment. This will guide you once you have taken the patient for surgery, what all is required in that surgery. So I won't go deep into the anatomy because it's already been talked upon. So the nasal skeleton or the nasal vault is being divided into 1/3. That is the upper compartment, the bony vault, the middle compartment, the upper cartilaginous vault, and the lower compartment called as the lower cartilaginous vault. Right. So what is a vault? A vault is basically a ceiling or the roof which will anchor the nasal skeleton or will support and will contour the nasal skeleton. Then comes your classification. Now this is important. The surgery, what you're taking, what is the purpose of that surgery? Is it only functional? Is it the aesthetic part, or it's both? And what type of deformity does the patient has? Is it a corrective rhinoplasty you're going for, or is the augmentation rhinoplasty? And another important segment is the site of the nasal deformity. So while analyzing the nasal deformity, you should know and look upon every aspect of the nose. That is starting from the tip. Is it a tip deformity? That is, the tip is bulbous, bifid, overprojected, underprojected, or tip ptosis is there. Coming on to the columella, whether it's retracted, deviated, or it's broadened. Then the alar cartilages. Is there any pinching of the alar cartilages, or is there any flaring is there? And the most important is the osteocartilaginous vault deformities. So this is the most frequently being seen. As I already talked upon, the cartilaginous vault is formed by bony cartilage. And so is the deformity including only the nasal bones? Is the upper cartilaginous system or the lower cartilaginous system, or it's including all the three? So depending on the deformity, can be a deviated deformity, a saddle nose, a hump nose, or a tension nose. So evaluation is very important, and that will lie your management. That will guide your management. So first and foremost, at what level the deformity is there? Is it in the osteocartilaginous vault, the alar level, or at the columella? At what level? Is it the tip deformity? And that has to be corrected according to that. So I have got some examples we can just talk about, such as for osteocartilaginous vault deformities, such as a crooked nose. So crooked nose is a classical example for a osteocartilaginous deformity. So here is a patient who has got a crooked nose. As you can see in the diagram, the deformity is normally at the K junction area. So there is a curvature in the nasal bones as well as in the cartilaginous vault. So the surgery should include both correction of the nasal valve as well as the cartilaginous vault. So it includes the osteotomies for the nasal valve. For the cartilage, the deviation is mainly through the upper lateral cartilages as well as the nasal septum. The nasal septum is responsible for deviation of this cartilaginous segment. So these patients, since the deviation is at the level of K junction, which is this, so these require a total extracorporeal or a partial extracorporeal correction of the nasal septum along with spreadographs. So this is the post-op picture of the same patient. The same patient, you can see the deformity in a basal view, partial basal view. There is a crook nose, as you can see, and this is the alar base. And this is the post-op correction of the patient. Another patient of the crook nose deformity is the same deformity. As you can see, it is very well evident at the K junction. There is a hump or a bony prominence. So this is a post-traumatic nose. So in these cases, the protocol remains the same, but you need to drill out this hump, which is there at the K junction. So after the exposure of the nasal bones and the cartilages, the nasal hump need to be drilled out. The bony hump or the bony projection need to be drilled out, and then followed by a septal correction and the osteotomies. So these are the patients in which the osteotomy should be there, including the lateral osteotomies, the external as well as the transverse osteotomies and the paramedian osteotomies. So another example of a crook nose patient. Now this is a good variant of a crook nose patient, a different variant called as the deflected noses or the deviated noses. Here the important point lies, these are the difficult cases. Why difficult? Because here the important point lies the radix and the columella or the philtrum doesn't lie in a same axis. So there is an axis deviation in these noses. So these are the patients where you need to correct the bony deformity. Along with that, the cartilaginous deformity need to be corrected. So in these patients, most of the time, in these cases, the bony prominence or the premaxilla is being deviated. The nasal spine is deflected from the midline. So the cartilage or the inverted L need to be fixed on the opposite side of the nasal spine to bring them in the midline. And unilateral spreadographs are used to create a straight nose to correct the deflection. Another example of these deflected or deviated noses. Coming on to the next segment, that is the hump noses. So these are also very well evident. As you can see in the patient, there is a hump at the junction of bony prominence as well as at the cartilaginous segment. So that is a K area. In that area, there is a hump. Along with that, there is ptosis of the tip. So while operating these patients, you need to drill out the hump at the K junction, both at the nasal valve level, at the nasal bones, as well as in the cartilaginous part. And osteotomies are to be done to correct the deformity later on. That is, while drilling, there will always be an open roof deformity. That will create an open roof deformity. So that need to be corrected. And while lateral osteotomies and the transverse osteotomies. And the tip correction has been done. Since there is a tip ptosis, a tongue in groove technique can be used to correct the tip. Then comes your saddle nose. So till now we have the hump nose, now comes the saddle nose. These are the cases, are mostly the post-traumatic cases or a post-secondary cases, maybe are post-rhinoplasty revision cases or a post-septoplasty cases. So as you can see, here is a person who has got a saddle nose deformity. So in these cases, depending upon the grade of saddle, we have got 5 grades of saddle. So in early grade of saddle, just a dice cartilage is sufficient enough. A DCF is sufficient enough to fill up the gap in a saddle nose. While for 3rd and 4th grade of saddle, dorsal on leg graft is a must. So these are the saddle nose cases. So in these cases, just putting a dorsal on leg graft is not sufficient. So for that, you have to first create an inverted L sort of a septum to support the dorsal on leg graft. And then the graft has to be placed to give a proper shape of the dorsum. Another segment is the for the saddle nose are these cases. A good variant of them is called as the binder syndrome cases. Here there is hypoplasia of the nasal bones. So you need to create first the base in the nasal bone level, and then a dorsal on leg graft is being placed. Now coming on to the binder syndrome. So you have got different grades of binders also. That is the hypoplasia of the premaxilla in these patients. So these patients, they have a low projection of the noses along with saddling. due to the hypoplasia of the premaxilla. So this is a patient with the binder syndrome. This is the lateral view of the same patient. As you can see, there is hypoplasia of the premaxilla plus the projection of the nose is less. So in the post-op, we prefer to maintain the same rotation angle, increasing the projection, as well as augmentation of the premaxilla is to be done. Same example. So same is the binder's case again. Yeah, these are the severe forms of the binder syndrome where you don't have any nasal bones. So a complete reconstruction is to be done in these cases. Then coming on to the thick and the broad noses, the thickness and the broadness can be at various levels, such as at the nasal bones level, at the cartilaginous level, or even the thick skin patients also can have a broad skin. So in this patient, in this gentleman, the thickness is at the level of nasal bones. So extensive drilling of the nasal bones is done, followed by osteotomies and correction, leading to this post-op picture. Yeah, this is an interesting case. The gentleman, as you can see by the face of the patient, appears to be an aged patient of 40 to 45, but the actual age of the patient is just 25. So the facial features are very significant in telling the age of the patient. So his major concern was the nose, the broad nose, that has to be thinned out. Now another case of thick skin patient. So the skin of the patient is so thick, whatever augmentation or reconstruction you do is not very well evident on this patient. So that's the cons of this patient, of this thick skin patients. So here there was a saddling at the dorsum. So a dorsal only graft was placed along with alar contouring, and a tip graft such as a shield graft was placed. Then comes a segment of tip deformities. This is a patient of, you can see there is a tip hypoplasia. So ideally there are 2 tip defining points, but here you can see there are 4 tip defining points. So in this patient, and there is a mild saddling of the dorsum. So in this patient, a tip shield graft was placed to give tip contouring, along with dorsal augmentation was carried out using the septal cartilage and the conical cartilage to give a good post-op appearance. This is a lateral view of the same patient, as you can see. A similar patient with supratip depression. As you can see, the dorsal aesthetic lines are not straight, leading to a formation of a curve. So a dorsal augmentation was done using a dice cartilage, and a tip graft was placed to give a good contouring. Then comes to the cleft lip noses. These are the challenging cases, and these are the cases you need to give results to the patient, because these patients are already been operated for cleft lip. So they are concerned with the nasal appearance of the patient. So these patients, they have a hypoplasia of the premaxilla because of the absence of bone in this particular zone. Plus the alar curvatures are pretty much, they are more concave. And due to this, the lower lateral cartilages are, there is a drooping of the lower lateral cartilages compared to the other side. And the tip has to be created. So these are the problems these patients face. So same thing we have done. Dorsal augmentation has been, premaxillary augmentation has been done. Then alar based resection is carried out along with tip reconstruction and elevation of this tip. That is a lateral crural strut graft was placed. A similar case, you can see there is hypoplasia of the premaxilla. Along with that, the projection of the tip is less. So dorsal only graft was placed along with premaxillary augmentation, and a tip graft was placed. The last segment comes to the revision cases. Now in the revision cases, mostly these are post-septoplasty cases in which the SMR has been done and the whole of the septum has been removed. So these typical patients have got a good nasal bone framework, but there will always be a supratip depression in this particular segment, leading to rotation of the nasal tip. So these patients, a complete reconstruction, inverted L reconstruction is to be done, followed by, depending upon the deformity, whether you need dice cartilage fascia or a dorsal only graft is being placed. This is a similar case of revision. So this is a nice case in which there was a hump in the nasal bones, and post-septoplasty leads to supratip depression. So that was corrected. Another interesting case, this is a case revision. It was done in this patient, due to trauma, there was no bony or cartilaginous framework. So in the early days, he underwent surgery and a iliac crest was placed in the nasal bone area. So as you can see, in the level of the iliac crest in the midline, a good projection is there, but laterally there was a depression. Plus there was an alar base widening was there. So this was corrected using a batten graft and the alar grafts, and alar base resection was carried out along with the cell resection, and tip framework was replaced. So the key point for success is accurate pre-operative systemic nasal analysis is a must, and evaluation of the nasal airway is important for the patient before taking the patient for surgery. Because you might be knowing a lot of techniques, there are a lot of techniques, but what technique is to be applied in what patient for what deformity is very important to understand before taking the patient for surgery. Thank you.
Thank you, Dr. Shubham, for this nice lecture.
Thank you, sir. Thank you so much. And ladies and gentlemen, let's heading to work for another event flow. So now I would like to request Dr. Sanjay Prakash, sir, Senior Consultant, Deen Dayal Hospital, Delhi, along with Dr. Pradeep, Dr. Sunil, and Dr. Tarun to facilitate our speakers. Thank you, sir. All right. So now I would like to request our next speaker on stage. Please welcome Dr. Brijendra Besa sir on stage. एक बार आप सभी की जोरदार वाली तालियों के साथ, please.
Dr. Baser sir, on his talk on septorhinoplasty in children, current status. Sir is a practicing ENT and facial plastic surgeon. He is the director at Akash Hospital in Indore. He is the president Indian Society of Facial Plastic and Reconstructive Surgery. He is the professor and chief of ENT department in Aurobindo Medical College, Indore. Consultant. He is also a consultant rhinoplasty specialist at Jaslok Hospital, Mumbai. I welcome you, sir.
Good morning, everybody. And first of all, let me thank Sunil for inviting me and congratulate him for excellent organization. And I always love to come. Nowadays, I've reduced my frequency of visiting, but here is something I can never miss. Today, we'll be talking on a bit controversial topic, septorhinoplasty in children. There are a lot of fixed ideas in our mind, and it's been rooted from years of teachings, but things are changing. Now, these are my workplaces. This is my own hospital at Indore, where I do majority of the work. And in Mumbai, I Jaslok Hospital and Bhatia Hospital, where I go every week. And this we keep on doing rhinoplasty workshops. And because of COVID, we had a break. And we plan to organize in February, but now the new dates are in October, and those who are interested, please keep in touch with Dr. Pragati. So septorhinoplasty in children, should we or should we not? Traditional wisdom is do not touch the nose till the child goes to 18 years of old. When he can have a drink, vote, and get married, then only you can touch the nose. But many years back, this girl came to me that for her brother's rhinoplasty. And then says, sir, do you remember me? You operated me. I said, I don't remember. Then I brought her photographs. So that was done in 2002, and then 2016, she was grown up in a beautiful young lady. Why this controversy? Adults have more face and less brain. Children have more brains and less face. So higher growth rate of facial skeleton, fear of facial imbalance if surgical intervention is done at an early age. Now, pediatric rhinoplasty we cannot from 1 year to 18 years is a long age group. So we divide into 3 age groups because problems are different at every stage. 1 to 6 years, 6 to 12 years, and 12 to 18 years. My talk will be confined from 6 years to 18 years of age. This is the most common presentation in those of you who are ENT surgeons. This is a clinical presentation, and your patient, his child has a cold and a blocked nose and sleep apneas and things, and you don't know what to do. First thing you do, advise to get adenoids done, the tonsils done, which is the right thing. But there are many who doesn't get cured even after doing tonsils and adenoids. And this is 6 to 12 years. This congenital trauma is the most common etiology. Then there is another group which is growing up, the teenager group, or those who are about to enter the teenage from 12 to 18 years of age. With all the social media and all these things, they have a small, good, gross psychological factor is present. Peer pressure, self-image distortion, and inferiority complex, which affects their studies and social life. Then we have these unfortunate patients who have deformities because of syndromes, congenital cleft, binder syndrome, midline dermoids, and cleft nose, like that. Clinician's dilemma. There are two sides of the coin. One side, surgical procedures on the developing structure can produce some adverse effect on the normal growth of various facial features. On the other hand, early prevention intervention can improve breathing, obstructive sleep apnea, middle ear infections, and take care of severe psychological problems. So we are confused year after year. Now still we are thinking like Joe Biden, thinking whether to attack Russia or not, and we don't have a clear answer what to do. Why this confusion? Because there is no clear guideline. They're all traditional and personal feelings that you should not do it out, but there is no objective studies. So there are no prospective, well-defined studies, incomplete knowledge of genetics and epigenetic influence. Literature on the long-term effects of rhinoplasty in young children is fragmented and often incomplete. I did an extensive search on literature on pediatric septal rhinoplasty, practically in English language, gone through most of the articles published. But what I found that the limitations in the studies, most of them are short studies, few cases, case reports. And obviously, practically, it is not possible to have two groups of were operated, non-operated, and see out how it affects the facial imbalance or these things. And then again, there are other influences like racial predominance, environmental factors, and other things which can affect the facial growth. So whether it is to say whether the surgery helped or not is very difficult in an objective way. Then, as I said, I reviewed the literature, and this is the most common study which I found, which was published in the American Journal of Anatomy. And in this study, they took out on rabbits, so they took out the septum of the rabbits and showed that the mid face growth retardation. And this is right from the first Scott Brown to every book this study has been quoted. But what is not quoted after this is the criticism of the study. In this study, septal cartilage was removed along with the mucopericardium, which we never do in our clinical practice. And functional septal and the differences in facial growth on cephalometric analysis. So this is not the way we do rhinoplasty or septoplasty. So this cannot be compared with the study on rabbits with the human beings. Growth centers in human beings. Clinical observations suggest and then another study which was, sorry, I missed this part. Bernstein published that the submucosal resection of cartilage with preservation of mucopericardium flap in young pups did not result in any growth disturbances. And this study is not as widely quoted as the previous study. Then we go step by step. What are the growth centers in the human nose? Clinical observation suggests that the dorsal zone is between the sphenoid and the nasal dorsum, responsible for the normal increase in the length and height of the nasal dorsum, and sphenospinal zone. So there are two zones, sphenodorsal and sphenospinal zone, which are shown on this diagram. Sphenodorsal and sphenospinal. And this is on the postmortem of a young child, and see the septum on the sphenodorsal and sphenospinal zones. Now we got some data, very reliable and authentic data on primary cleft rhinoplasty. We have follow-up of 10 years, and many studies published with the follow-up of 10 years, 15 years. And it has been demonstrated that infants undergoing primary cleft rhinoplasty you have normal nasal growth after early depositioning of the nasal septum. So these are cleft rhinoplasties. Then I studied some of the large series which are available. There are 4 large series I found: Tuska, Hakim, Jar, and Wecker, and all of them shows that there is no interference of the rhinoplasty or septoplasty on facial growth. In fact, I haven't came across a single case. There are many says that children were not happy when they grew up and they were not happy with the results. They were not happy with the nasal obstruction. They were required revision surgery. But there is not even one case report which said the children has undergone a septorhinoplasty and has a documented facial growth retardation. So this is more of our thinking and a tradition which is going on in our mind rather than objective data. Sunil, I will take a little longer, bear with me. In fact, the International Journal of Pediatric Otolaryngology published, not performing or delayed septoplasty when indicated may adversely affect nasal and facial growth. So this is the other way around. It's not by performing. If you're not performing, you're more harming the child than not doing it up. And then this another theory comes up that in growing patients, air enters the maxillary sinus ostium slowly, and this causes facial expansion and growth of maxillary sinus. So when there is an obstruction, especially if there's a trauma and which produces obstruction in nasal breathing, this in fact may affect the growth of the maxillary sinus, expansion of the maxillary sinus. So children who have respiratory, this is from Ecuador, Professor Ramullah, he publishes, says children who have severe respiratory problem as a result of trauma should have surgery at the age of diagnosis. So you don't need to wait for this 10 years old child and don't have to wait for 18 years to do it out because he'll keep on suffering this thing. Growing number of studies have demonstrated that quality of life improves the outcomes. The age-specific anatomy, the effect of wound healing, and risk of interfering with post-facial growth should always be regarded when doing nail surgery in children. Now, so what are the indications for doing septorhinoplasty in children? There are some where there's no controversy, like when there is a deformity following septal abscess, or then there is a trauma, or severe sleep apnea, and subtle nose deformity, and when there is severe psychological problems which are affecting normal schooling. Now, another thing which comes on with when you taught, and in fact, even I was teaching this thing, that when you're doing septoplasty, be conservative. Now, everybody say be conservative, but there's no definition of what is conservative. You are just saying there is no objective data that do this or this, do not, no clear guidelines. And septum has a memory, and when you do a very conservative, it comes back, and you realize that your surgery has not given any benefit to the child. So how you do it? Firstly, that lifting the flap, uni or bilateral elevation of mucopericardium has no negative effect on further growth. Avoid incision through the growing end supporting zone, that is a sphenodorsal and sphenospinal zone. And again, external rhinoplasty, when the skin doesn't have a growth centers, so you can safely do external rhinoplasties. What is to be avoided is posterior chondrotomy, or separation of septum cartilage from the perpendicular plate of ethmoid. Because that's the reason where it grows. So now it's quite different from the septoplasty you do in adults. That first you dislocate the cartilage from the bony part and do it. Dissection of deviating basal rim of the cartilage septum is not expected to have consequences for the outgrowth of nasal dorsum. The septospinal ligament, most anterior part, should be kept intact. So as I said, you can do an open or closed approach. Mobilize the flaps, preserve the growth centers. I'll show in some diagrams rather than theoretical discussion. And instead of, like yesterday, I showed the fixation with the spine, but in children, instead of fixation with the spine, fix with the periosteum, because we do not want to drill in the spine of a growing child. Then there are other techniques which can help you in getting good results in children. Is a cartilage overlap technique. When there is an excess length of cartilage, you need to adjust it. You like to avoid excising it. So when you overlap it, it takes care of the extra length and helps in maintaining the midline position of the septum. You can do it in a horizontal patient fashion or in a vertical fashion, the overlapping techniques is a good technique to practice in children. Even you can do in adults. And rigid fixation with not making a hole, but near the nasal spine. So this is a young child with the overlap technique. This was pre and post-op. This is a year later. He has picked up hairstyle. And this is another very difficult septum. The child has a severe nasal obstruction, sleep apnea, have difficulty in going and missing schools frequently. And these are the steps. See the difficult septum, cartilage overlap technique, fixation with near the spine. And this is 6 months later. A couple of more examples of overlap technique. 1 year, 6 months, 1 year. Crooked nose corrections. And believe me, this is my indications are not purely cosmetic. When they are suffering from obstruction, having sleep apnea, missing schools, adenoidectomy tried, not helping, and then I take up them for surgery. So it's not that every child coming to my clinic, I advise rhinoplasty for them. So see out the CT scan, the type of deformity, totally blocked nose. That's a year later. Now, older children who are 13 years of age or above, they needed to be treated like adult, because you don't forget conservative technique has a very high recurrence rate and you can have a cartilage curling and obstruction later on. So I treat them adult after the age of 13 years. There are various people see that it should get a puberty in females or some things, but they're all personal feelings rather than scientific facts. So this is like in older children, you do a same technique as results, the cartilage mobilization, expander grafts, fixation to the spine, and these are a year later. And you can see out endoscopic pictures, right and left nostril, both nostrils are adequate. 13 years old with severe functional problem, and follow up at 13, 14, and 15 years, and is growing well and attending school normally. Here is the now one thing which take home message from here is saddle nose in children. That can be because of trauma, infection, and congenital. Now we accept these patients after 7 years age, and why I will tell you in the subsequent slides. 7 years is I pick up because by the time the concha develops, and you can use concha because many parents have objection of using rib cartilage. Now this case was given to me in for operation in Bangladesh. And she was 18 years of age. And I said, there is hardly any skin. How much I can expand? I can expand only as much as the skin permits. And then I asked the professor, and he told me that we were asked to wait till 18 years of age. So if an early intervention would have been done, we would have an adequate pocket. Even the revision need to be done. We got a skin. All of rhinoplasty surgeons sitting here, they will agree with me that you can augment with cartilage, but you cannot produce new skin. You got to work with the limitation of the skin. So, and now on the other hand, see out this case. This case was operated by someone else at the age of 7 years. And they put a silicone implant in her nose, a case of binder syndrome. And you can see totally flat nose. Okay. She came to me for a revision after many years, like at the age of 18 years when she was joining a medical school. We removed the implant and used cartilages for reconstruction. And look, this girl now, she's a doctor, and she came out the significant augmentation we could achieve. Why? Because of that silicone implant, which acted as a filler and which has acted as an expander of the skin growth. So we had adequate skin pocket. So we have a pocket where we could augment it. If you do not it, the flat skin, you can get only a very limited results. Like this. See out the young child before operation and 5 years later. Now, absolutely flat nose like these binder syndrome, we are not waiting till 18 years of age. We are operating them early with rib cartilages or conchal cartilage, whatever the children's permits. And look out this. So there are two advantages of it. First thing that they in the school, they have a good time and they're not teased by their peers. Secondly, I told them in very clear terms that this is a one-stage operation. Second stage you might or might not require at the age when you grow up 17 or 18 years. With a clear understanding of the parents, we all augmentation in children with cerebral nose, most cases we take them for early intervention. Like this. And this is by concha, bilateral concha. Now this case of binders, this is 9 months later. Now when, if I need to revise it, I will get a good adequate skin cover. Even Eugene Tardy in his book showed that the cartilage which is implanted in children, that also grows with the age. And many of them did not require a second operation as we think about. Look at the length of the columella which has been achieved at 9 months. This young girl at 14 years of age, she had a minor injury on the nose, not a fracture nasal bone, but she wanted a nose job to be done, and we did one. So this was septal cartilage wrapped in temporalis fascia. And look at, she's a daughter of a close friend. So 14 years, 15 years, 18 years, and 24 years. And she's growing a fine young lady. No facial deformity or no facial retrusion. And some young girl, I operated early age, 14 years. And she came to see me in Ranchi after, I think, up to 3 years of surgery. And the nose is growing well and she's growing as a normal child. And gross total deformity, because of septal abscess, augmented at 14 years of age, we use 2 layers of concha. As Dr. Hossam Foda is also very fond of concha, and I use a lot of concha. Position of orthogonal graft, and this is young man. And all these are late follow pictures. Anti-projection improved. And this young lady, she is a daughter of a very prominent politician in South. And they came to me at the age of 14 years. And she was ridiculed because of the bifid nose. And then I went for a Tamil Nadu state conference. They came to see me there. At 18 years of age, she was going to US for further studies. And you can see how early intervention helped her in growing as a normal child. And as an adult, she's going for further studies, living a normal life. So there's no point in waiting for these kind of patients. And you should keep in mind the psychological aspect of nasal deformity in children. Now, results, these results have been updated. These are old slides, but our early results, we had a lot of redeviation of the septums. And since then, we have changed our techniques, and the ultra-conservative approach sounds good, but it has a high recurrence rate. And so now the new data we are analyzing, and our results have improved ever since from that time. Conclusion and guidelines. Evidence exists to support that pediatric septoplasty can be performed without affecting most aspect of nose and face growth. Not performing or delaying septoplasty is you are harming the child more than helping him. When indicated, no, don't do it for purely cosmetic purpose. Despite majority advertising time of surgery to be 6 years and older, we need to have more studies. To date, there is no evidence in experimental studies of an advice against the open approach. We do not encourage purely cosmetic procedures like hump reduction or tipplasty in children below 12 years of age. The revision rate may be higher, and a good counseling and discussion with parents is required. So these are our books in rhinoplasty. The first book was published 25 years back and released by Health Minister, this book, and hopefully a new edition will also come. So please don't take away the right to breathe just because I'm a child. Thank you very much.
Thank you, sir, for the nice talk. Thank you. Any questions?
Two.
Touch with Dr. Pragati, those who are interested in coming.
Thank you, sir. Thank you so much. All right, ladies and gentlemen, let's heading toward. And now I would like to request on stage Dr. Kapil Agarwal, sir, KBM Hospital, Senior Plastic Surgeon, Mumbai. Would like to request, sir, आप एक बार प्लीज हमें ज्वाइन करें on stage, अगर मेरी आवाज सुन पा रहे हैं तो. Along with Dr. Pradeep, Dr. Tarun, and Dr. Sunil, sir, would like to request कि एक बार आप भी ज्वाइन करें please on stage. And मैं यहाँ से रिक्वेस्ट करना चाहूँगा to our chairperson Dr. Vishal Mohan ji and Dr. Alok Agarwal sir. Sir, please एक बार आप ज्वाइन करें. And Dr. Kapil sir से रिक्वेस्ट है, सर प्लीज आपका रुकना है 2 मिनट ऑन स्टेज. हमारे चेयरपर्सन हमारे साथ हैं और इसके बाद हम बढ़ेंगे हमारे नेक्स्ट सेशन की ओर. Huge round of applause, ladies and gentlemen, please. Thank you, sir. Thank you so much. And now, ladies and gentlemen, I would like to request to our next chairperson on stage. Please welcome Dr. Vinny Jain, sir, Director, Mahavir ENT Hospital, Kota. For the next, would like to request Mr. Dr. Jareen Thomas, sir, Assistant Professor, ENT, Head and Neck Surgery, NIMS Hospital, Jaipur. Welcome to our next persons. And yes, this time I would like to request on stage to our next speaker. Would like to request Dr. Vishwas Vijaydev sir on stage. Ladies and gentlemen, please use a round of applause for the sir.
A very good morning to all of you, and my pleasure to join you all from Bangalore. Thank you, Naksh Rhinoplasty Center and Durbin Hospital Global Rhinoplasty Association for inviting me over to deliver this talk on augmentation rhinoplasty. My special thanks to my friend, Dr. Sunil Thanwar, Tarun Oja Sahab, and all the people from the association who invited me over here. Excuse me. Yeah. So augmentation rhinoplasty is an exercise in structural rhinoplasty also. The reason being, many times there can't be a 10th floor without a first floor. So we need to understand that we need to start from the base and not just load on the top, because it will collapse in the long term. Obviously, we all know the structures of the nose and how it is formed, but if you have to augment a structure, especially during an augmentation rhinoplasty, and if you're doing a gross augmentation, you better have a L strut which is strong enough to get the load of the augmentation. There are many areas which can be augmented, and also there are various types of nose with various types of skin. So what I'll be doing in the next few minutes is taking you through a lot of scenarios in various combinations, and as to what lessons I got out of them and what I would like to share with you. Now, the ideal implants for an augmentation rhinoplasty, as we are well defined, that it has to have no absorption or disintegration, not become deformed, and it has a long-term survival while maintaining the contour. There are a lot of grafts and materials, but the time-tested ones are our own materials, that's the autograft, septal conchal, and rib grafts. Now, just going on to a few scenarios. Now, in a patient with a thick skin, low dorsum, hardly any premaxilla, and this patient, this is the profile view, totally with a rotated nose, hardly any columella show, no radix, no dorsal augment, means dorsal elevation. So rib graft becomes mandatory along with structural grafting to form an L strut. And then I use a rib graft and then carve it, make it multi-layer. I don't use a single rib graft. And that is multi-layered to make sure that the orientation and the layering is different at different levels. This is just to show that after the rib graft, checking for the leak in the pleura, and I insert an epidural catheter just to give intercostal blockage. Now, a few things with the rib graft. Sometimes I had this habit of putting a rib graft which was excess back, but then I used to see a lot of seroma because of that, so I abandoned that procedure. Okay, thank you. So this is what I could achieve at the end of 1 month. And what is most important here is the pre-maxilla also needs to be augmented to give a good frontal view. Now, if you look at the profile, it becomes obvious. The pre-maxilla was augmented again with the rib cartilage itself, not in any kind of dysphasia or any sandwich roll. And I have not used a solid graft, but used multi-layered graft on the rib. So this is at the end of 6 months. And this is the basal view showing how the elevation has come up. And this is eventually the profile view. And this is the helicopter view. This is the 2-year follow-up of this patient. And you can see that the rib graft has not warped and it has maintained its contour. One thing you can see is there has been some softening of the edges. That is possibly due to settlement of the edema and the cartilages itself. Now, the scenario 2, moderate skin with low dorsum and an absent premaxilla. The reason I put the previous slide is now whatever we put under the skin, it is not, if it has any kind of irregularities, it doesn't show up much. But then if it is having a moderate skin and a low dorsum, you need to be careful while designing the grafts. Now this lady here, obviously, once I went in, she had no cartilage in the septum here, and that the only thing that was visible was the vomerine plate. So as you can see, this is at the completion, and you can see there could have been a little more of augmentation. The reason I stopped short of that is the skin availability. Now, if I try to stretch the skin over the rib graft and over a new cartilaginous septum, what happens is you're fitting it into a tight pocket and there can be a slight compromise, though you can do a extension of your incision downwards. So this is just at the splint removal. And this is at the end of 1 month. And I'll show you a few slides just to show the passage of time as to how the healing happens. Now, I want to show you a point of illusion. Now, this mole here, it is not in the midline for her, and that happens to give a reference to the eye, and it looks as though the rib is tilted to one side. I'll show you the basal view, you will be able to make out. This is at the end of 1 month, the profile view. This is again at the splint removal, and this is at the end of 1 month. Now, this is what I wanted you to notice. This is not in the midline, but the mole is making you feel that the rib graft on the top is shifted to right. So you need to tell the patient, warn the patient well in advance. So this is the 1 year result from the helicopter view, and this is from the basal view, and this is from the frontal view. So what I'm trying to say here is, when you have a moderate or a thin skin, don't try to stretch it too much and augment the layers in such a way that it's a tight pocket that it extrudes. I just want to show this as a scenario 3 where it was done elsewhere. It came to me for revision. I have not yet operated this patient. So this is again the moderate skin. The graft has been placed. It has migrated upwards. It has pulled the skin. And when he had a suture removal, supposedly this got infected and he got nostril asymmetry and rotation as well. So these are some things which we need to learn. It's not just about loading something onto the top of the nose, but the skin also needs to be respected. So the scenario 4 that I want to mention is a thick skin with a mid dorsal height with a tip undefined. Many patients in South India are like this. They have a tip which is undefined and a dorsum which is also not very well defined. Now, if you look at it, there is a radix deficiency, there's a mid dorsal deficiency, there's a tip projection loss, there's hardly any columnar show. Of course, the supratip break and the angulations are all right. Now, I utilized a conchal cartilage because it did not require too much of augmentation. I doubled it and made adequate L cartilages to hoist it in place. The way I put the cartilage grafts of a conchal graft in place is make sure that the periosteum is exposed completely onto the bare bone so that there's no slippage. And at the same time, I fixate it with the PDS taken way through the radix point. Now, this was at the end of 3 months that you can see she had a graft in place. You can very well achieve a good contour with the conchal graft itself, and you don't require to have rib graft all the time or septal cartilage itself all the time. And this was a photo sent by her, and this was again the profile view. Now, this is the basal view. She has not come for follow-up after that, so I just collected something of her digital profile. I'm unfortunately sorry for that, but this is the profile and the frontal view. Now, the scenario 5 is a moderate skin, an undefined broad and bent nose, a low radix, and a mid dorsum as well. Now, of course, when a broad and a bent nose is there, there's going to be underlying cartilaginous deviation and possibly bony deviations that has to be corrected. You have to do structural grafting. After that, you need to load the top, and the loading also need not be too very prominent. Now, because I required a lot of cartilage here, I harvested the rib. And this is from the helicopter view and the basal view. This is the view at the end of 3 months. And after the structural grafting, the dorsal augmentation to get the lines here. Now, these dorsal lines are something that we all need to make sure it is well defined. So it's good to bevel the edges to make sure that they sync along with the frontal process of the maxilla or the osteotomy that we have done to give a good projection and good aesthetic dorsal lines. And this is from the profile view. You can see that the radix and the mid dorsum is well elevated and the tip is also well defined. This is again another profile view, and this is from the basal view. Now, this is the end of 6 months. Thankfully, it is maintained like that without much movement of the rib cartilage. Now, one interesting thing that I had in this patient was because of the prolonged surgery, on the occipital area, he lost a little bit of hair. Obviously, I had to give him injections and topical therapy to heal this, but this was something that I experienced, so I just wanted to share it with you. Now, the scenario 6 is you have a thin skin patient, a mid-dorsal height deficiency, and the tip is also rounded and possibly boxy. Now, these patients come to you for finished rhinoplasty. They are not really worried about augmenting too much. As you can see, this is the preoperative view. This is not, probably it's just a grade 1 requirement. And then as you do the surgery, if you are having enough of septal cartilage inside, you can harvest it, design it accordingly, double it if required for the height, layer it. This is just at the end of splint removal. Again, at the end of 3 months, this is the passage in time. Now, the reason I put up this is many of your patients will come back and ask you, my nose still looks thick, my tip still looks thick. And it is something that I show all my patients this slide, that through time, edema is going to settle down and the cartilages are going to get well defined. You can see the difference from here to here, how the cartilages have got defined with passage of time. This is at the end of 6 months. Now, this is how she is appearing now in the frontal view. This is the profile view. And this is the basal view. This is another profile view. There's a 2 millimeter augmentation only and not much, but it creates a drastic difference to the profile. Now, another scenario is a radix which is low and the dorsal definition is not present because the bones are wide apart, the cartilages are wide apart, and in them also you will require to do a minimal augmentation and also a radix augmentation. So this is the pre-op and this is the post-operative view. Again, this is from the profile. As you can see, there has been a radix augmentation here with tip definition. Again, a radix augmentation with a tip definition that is required for giving a better profile of the nose. Now, of course, this is something that we all experience. We do get patients with a post-septoplasty saddling. Again, the thing here is many conventional surgeons used to put the cartilage back there, but then an open rhinoplasty is the minimum requirement that has to be done to completely expose and remove all the fragile cartilages, place a rib cartilage, get the alignment right, get the fixation to the anterior nasal spine, to the anterior maxillary spine, and then form a structure, and on it you can load the cartilages. So this is from the frontal view. Now, post-saddling, it usually happens over 1 to 5 years of time, and the patient comes to you for surgery. It is best to wait until 2 years after the septoplasty to see what final changes happen, after which you can start the procedure, or rather do your rhinoplasty. Now, another scenario is specific augmentation. Now, many patients come to you for aesthetic correction and say, doctor, I'm happy with my nose, don't change too much. All I need is this area which is hollow here, which needs to be augmented. And this lady here agreed for a surgical rhinoplasty. She didn't want a filler, and I also wouldn't want to consent of a filler because it is closer to the tip and there's a lot of vascularity here. So after undergoing open rhinoplasty, I used a conchal graft and used it on the lateral crura, attached it to the intermediate crura, and gave her a definition which she was happy about. So there are very, very specific asking patients also, and this is something to keep in mind because they are the usual happier lot. And it's not always that you need an open rhinoplasty to augment the nose. You can always do with a closed rhinoplasty approach. And the tip also can be handled by a complete transfixation incision to make sure that you get a good augmentation way from the radix onwards. Now, the conventional teaching is if you're doing a gross augmentation, go and open up the whole structure. But if you are able to pass your instruments and have enough experience in the closed rhinoplasty, then it would be possible to give a good augmentation. Now, this patient had an abscess at the dorsum, had a collapse post the abscess. The entire skin and the bone, everything had collapsed. And on biopsy, it was found that she was suffering from tuberculosis. So once the skin healed with difficulty, this was what the resultant defect came about. So now if I have to augment this, there is paucity of skin, there is paucity of soft tissue there. So I had to use a special technique called as the MISTA, which is microfat infused temporalis fascia, to make sure I get first a dermal augmentation, and then later I can do it in the second stage, the augmentation. So she has just undergone a first stage dermal augmentation now. So what we do is take out the temporalis fascia, you use the nanofilters and the microfat filters to make sure you get the fat and infiltrate it into the temporalis fascia, weigh it to 7 to 10 grams, and then insert it by laying it way across the nasal bones. So this is just the dermal augmentation in the frontal view. The profile will be better for visualization. This is only the first stage. This patient is going to come back to me for augmentation and the tip rotation as well eventually. This is just to show that without the skin envelope there, there's no point in doing a augmentation, because it is anyway going to give away, because it's a completely necro skin that had healed. So this is again after the dermofat placement to heal the skin and soft tissue. This is just an example of a patient which we did recently to show that he had a fracture, a leaf-fold fracture, after which he developed a mid-brow depression along with the radix depression. And this patient wanted the correction of the mid-brow as well as the nose. So I had to use the Turkish roll along with the dice cartilage fascia for the mid-brow augmentation. Now the problem with using solid grafts over the mid-brow is the visibility would be too much, though you contour it well. So the best way to augment that area will be to do a bicoronal flap, open up the whole area, place a solid graft, drill it down, shave it down to the contours of the medial brow points. But the sandwich roll is something that adapts very well, and you can use minimal incisions there to place the Turkish roll. And once you place it inside, you need to adjust the contours adequately. Sorry, the photo is moved up. So this is how it appeared just immediate post-op. This is in follow-up still, because we have just done this patient recently. And this is from the helicopter view, and this is from the profile view. So eventually, I'm sure the edema will settle down and will look much better on the mid-brow augmentation. This is one scenario. I just wanted to show you all that she has undergone an augmentation of the mid-dorsum and the radix point. But if you look at the chin is also retruded. So when you counsel a patient or consent a patient, do counsel them for a chin augmentation, which gives a much more better profile view. And along with the chin augmentation and augmentation of the dorsum, you tell them about the double chin that is there. So you can do a little bit of liposuction also to remove the excess fat. So you can do a chin augmentation with the submental crease incision or intraorally through the oral route, vestibular incisions. So with this short presentation on augmentation rhinoplasty, I thank you all for a very patient listening, and hopefully I've shared some of the insights that I got handling augmentation rhinoplasty patients. What I consider most vital is the balance of the skin and the graft that goes underneath. Now, if we do not understand the skin and we just put something in, we might have a good cartilaginous envelope and a good dorsal definition at the end of 3 months. But then at the end of 6 months to 2 years, you will either have some amount of warping or have some amount of movement or have some amount of sliding or exposure sometimes. So with these few points in mind, I end my talk, and I welcome you to my course that we run in Bangalore, and we have eminent faculty visiting us. This is a hands-on cadaveric dissection course where the participants get to dissect and operate and learn from each faculty. And for further details, you could please contact our secretary, Mr. Vikas, on this number. And thank you so much for patient listening. And it's been productive 2 days here. A wonderful time here. Thank you, Dr. Sun. Yes, sir. Hi, Jay.
Augmentation
what material do you prefer? What cartilage, septal, conchal, rib?
Yeah, as I mentioned, if you have enough of septal cartilage, that would be the primary preference. But then the next thing is, if you do not have septal cartilage, conchal doesn't stay much longer. Rather, if you dice it, it's not going to stay much longer. If you can double it and get a 2-layer augmentation, that is good enough. But if you need very gross augmentation, at least 3-4 layers, then rib would be the better choice. So what I do is I consent my patients for all 3.
Yes.
Because when you go in, you do not know what has actually happened to the septal cartilage. And some of them are revision, some of them are post-septoplasty. So it's always better to consent them for all 3 and go inside.
And for standing nose, would you prefer an en bloc or a DCF?
I don't use a DCF. I don't use a DCF very conventionally. The reason being, one is in tight skin and in thick skin, what happens, it dissolves or rather absorbs. I would prefer a solid rib graft over a DCF. My first preference would be a layered rib graft rather than a solid rib graft. So that's the sequence I use.
Thank you, sir.
Thank you.
Presentation showing different scenarios and how to go along with it. Thank you, Dr.
Thank you. Thank you, sir.
Thank you, sir. Thank you so much. And now I would like to request on stage, would like to request Dr. Amit Goyal, sir, along with Dr. Tarun and Dr. Sunil, sir, to facilitate to our speaker. Ladies and gentlemen, please use a round of applause. Thank you, sir. And now, would like to request to our next speaker, Dr. S. Gambhir sir, please एक बार आपको पधारना है on stage, आप सभी की जोरदार वाली तालियों के साथ. Come on.
Good morning, everybody. I think everybody's awake now. Secondary cleft lip rose rhinoplasty, not the primary one. As we all know, the cleft lip nose deformity, it involves, there's a downward displacement of the alar cartilage. The deformity that we see in cleft lip rose is that there's a downward displacement of the alar cartilage on the cleft side. There's a decreased columnar height on the cleft side. There's a wide alar base. The septum is caudally deviated and anteriorly, and also anteriorly. There's a tip deviation is there towards the non-cleft side. The alar base is depressed. The tip is broad, and there's a webbing in the mucosa. As we वीडियो नहीं चलेगा फिर ना कैसे दिक्कत करेगा ये तो ओरिजिनल लिखा है ये क्या है पूरा हट रहा है मिरर डिस्प्ले पीपीटी में की नोट है ना तो कैसे चलेगा पीपीटी मैंने ओरिजिनल लेके आया था नहीं सर ये तो डी है सी पोर्ट वाला है कॉलम तो सारी यही हो गई है फिट करें ये क्या है? इससे आगे क्या गायब हो गया? फिर गायब हो गया? गायब हो गया था? चलो आगे बढ़ो. Okay, fine, good. Let's hope so. It works now. That we encounter here also is that these patients, whatever the patient they come to us, they are not treated orthodontically. They are very malformed, just simple, just not deformity of the nose, but there are other associated deformities also. The maxilla is detruded, and the arches are not defined. So there are other deformities which these patients normally don't go before and don't want to go again further. So we have to see the results they get is adequate after the surgery. So what happens during development is these, because of the these abnormal insertion of the orbicularis oris to the columella base, this pulls the septum towards itself. So the septum at the caudal posterior end gets deviated towards the non-cleft side, and on the top, that is on the anterior part, it is deviated towards the cleft side. The tip deviates towards the non-cleft side, and there's a gross deviated septum is there. These rest the ala on the cleft side because the maxilla is underdeveloped and it's not been treated orthodontically also. So these the ala base is very much depressed. The bone growth is retarded because of the cleft, and nasal bone also is underdeveloped on the cleft side. Now, what are the goals for cleft lip rhinoplasty? First is always the creation of a symmetry. There should be a definition of nasal base and a tip. There should be patient always complain of obstruction most of the time. So there's a relief of obstruction, and there is webbing as well as nasal scarring that has to be corrected. So this is a deformity you see in these patients. And what we do, we normally prefer doing giving the incision at the base of the columella. Okay. So as standard open rhinoplasty approach, we are opening these noses. But what I prefer doing, starting it from the rim, that is from the rim incision or the cephalic end of the lateral crust. I normally start from that area, give on bilateral side. And if you see the lateral crust in this cleft patient is also cranially rotated, means it is more displaced cranially, and it is more vertically oriented, like a parenthesis deformity that we get. So during the surgery, we have to bring it forward. You can clearly see this, the rim is, the lateral crust is cranially rotated, and then we give the incision on the column on either side, raise the flap, taking care not to injure the medial crust, lateral crust, and the middle crust, and proper exposure is being done. As discussed yesterday, giving traction and gently cutting the soft tissue. The exposure is done to the tip, to the dorsum, whatever deformities that we are correcting. Normally, I do a slightly just supraperichondral approach, not going under the perichondrium. Now this the tip of these cleft patients, they are slightly broader and tip is not defined. So this the Pitanga ligament that you see, we normally cut on towards the tip side, looking at to thin the tip, and you can just see that we'll be coagulating on the tip side, leaving it on the columnar end and then discarding it. So that just to decrease the thickness of the tip. Now we have done the exposure to the septum. And this patient, the caudal end of the septum, you can clearly see is deviated, but on the dorsum is nearly straight. We are taking a septal graft from it. Like already been, you have seen yesterday and will be discussed today also. We give an incision just giving a caudal and dorsal strut about 1 centimeter. Normally, in Indian patient, I like to give it around 11 mm, not slightly more than 1 centimeter to be on the safer side. Now, if you see this tip is deviated and there's a slight long, then we just take out the excess of the posterior nasal septum, posterior septal angle area, so that the length is maintained. And then we prepare the septal extension graft and place on the tip. It gives us two purposes. One purpose is it straightens the caudal end, as well as it provides support to the tip, because we need the tip to be more sturdy and raised up. And then we fix it with the anterior nasal spine. This we are doing with fixation with the anterior nasal spine. This is the 40 PDS. Sometimes we will be using 30 Purine also if we need a very strong support. And in these patients, most of the time, the spine is displaced also towards the non-cleft side. So we are fixing it on the lateral edge of the spine to make it in the midline. So now coming to the next part is that as we already discussed, that this lateral crus is displaced cranially. So we have to bring it towards the caudal end. So we do a VY advancement of the lateral crus to bring it into the caudally to form the tip definition. And then we fix it with this septal extension graft, doing all these intradermal stitches. As you can see the video, we are just doing the VY advancement. The cephalic end of the incision is towards the between the intercartilage area, and the lateral part we cut as laterally as possible. This is together with the nasal mucosa. The whole part is then caudally displaced, moved. You can clearly see we have moved the lateral crust caudally towards the tip. And then once we have done that, to support this, we are using a lateral crural strut graft. This gives us two things. One, because this lateral crust is malformed and it is under-rotated, horizontally placed, that gives a support to that, as well as it gives support to the lateral crust by placing it into the lateral part of the ala. We create a space towards the alar base and then insert this lateral crural strut graft into that part. You have to take two things into consideration when placing this lateral crural strut graft, that it has to start from the tip area and goes to the lateral part. Now this is being placed into the space that we have created in the lateral towards the alar base. Before we do that, we also do a debulking of this area because there's a lot of thick skin is there. Now, after we have closed this down, we have got the problem of webbing is there in the lateral in the ala. So what we are doing is we are creating a lateral blazed Tajima flap or inverted U flap. This is laterally blazed. Now, once this flap is cut, we are cutting it from the columnar end, going up to the lateral edge of the ala. The circulation of the flap is laterally from the lateral side, and this flap is then transposed cranially into the defect that has been created because of the VY advancement. And this the alar skin is directly sutured to the lateral crust mucosal skin. This is then transposed lateral cranially into the defect. This is the flap that we have raised, and there's a defect is there in the, you can see the place where we have advanced the lateral crust. This flap is then placed there. This is a result that you see immediately. Now, there are two things that are left now is because there's a widening of the alar base. So we do a YV advancement of the alar base, and also there is a depressed maxilla. So we have to augment that part also. This is YV advancement being done for the alar. This maxillary augmentation is done with the alar crushed bone graft. This is the patient immediately post-op. This is after a few months, is maintaining. There's another patient. The patient combined with the binder syndrome. We have used a rib graft in him. Another patient, the cleft lip. Same procedure has been done. Another patient. Thank you.
Thank you, Dr. Sir. Thanks for excellent presentation. It was very informative. Thank you.
All right, thank you, sir. Let's head into ladies and gentlemen. और यहाँ से मैं अब रिक्वेस्ट करना चाहूँगा to our chairpersons. सर आप एक बार प्लीज स्टेज पे पधारें. To felicitate our chairpersons, I would like to request on stage Dr. Alok Agrawal sir, along with Dr. Tarun and Sunil sir. सर मैं चाहूंगा प्लीज एक बार आप स्टेज ज्वाइन करें. Please, ladies and gentlemen, use round of applause. थैंक यू सर, थैंक यू सो मच. ऑलराइट, बढ़ते हैं हमारे नेक्स्ट सेशन की ओर और उसके लिए वुड लाइक टू रिक्वेस्ट लेडीज एंड जेंटलमैन टू आवर चेयरपर्सन्स, प्लीज वेलकम डॉक्टर अरुण माथुर सर, सीनियर प्लास्टिक सर्जन जयपुर. To our next chairperson, I would like to request Mushfiqur Rahman sir, Assistant Professor, Medical College Hospital, Dhaka from Bangladesh. Sir, से मैं request करना चाहूँगा कि sir please आप हमें join करें for the next chairperson. Ladies and gentlemen, huge round of applause for our chairpersons. Thank you. So please welcome to our next speaker, Dr. Sunil Tawar sir on stage, please.
अभी आगे
Thank you, sir. Good morning, everyone. So we learn about a very difficult topic, really, osteotomy. How we can simplifying this osteotomy? We just try. Really, first, sorry. Yeah, first we learn then what is osteotomy. Because any term, first we understand behind the what actually meaning of the term. So osteotomy really a control fracture of the nasal bone and adjacent maxillary process to correct asymmetrically nasal bony vault. And really, friends, the osteotomy a essential component of the bony vault correction. We have only one option for the correct the bony vault deformity, that we have the osteotomy. But really we have the challenges in the osteotomy. What challenges we have in osteotomy? Because throughout, when we do the procedure, then we couldn't see while performing. It's really a challenge. We do in the tunnel, we can feel it only. We cannot see the procedure. And the second, the bone thickness changes in the most of the patient, because the nasal bone have really the thickness from the top to the bottom. In the nasofrontal area, the nasal bone have around the 7 millimeter thickness. But if you come on the lower side, then gradually, and the same side, the nasal bone have the different thickness. So really, due to the variation of the thickness, and the bony thickness is not similar along pathway in the same patient also. So these are the common challenging factor in the osteotomy. So before to the osteotomy, we need some building blocks. So you have to know about the morphology of the bony nasal vault, need of the osteotomy or not, type and location of the osteotomy, decide by your aesthetic goal and understanding geometric proportion of the bony nasal vault. And you have to know the pattern and sequence of the osteotomy. And you have to know knowledge about the different osteotomes and marking and infiltrations. So these are the common building blocks. So you have to, before to start your osteotomy, then you have to know in your mind, especially for my beginner friends, you have to knowledge all these things. Now, for understanding the morphology of the bony nasal vault, this bony nasal vault basically consists by the 6 attachments. Centrally, we have the paired nasal bone,
And on either side, inferolaterally, we have the ascending process of maxilla, superolateral bone, and under surface in the midline, the bony septum, upper and nasal process of the frontal bone, and lower end with the upper lateral cartilage. So we have to know the different attachment of this bony nasal vault for proper understanding of the osteotomy. Now, the assessment and analysis, if we look the shape of this nasal bone, then the shape of the nasal bone in the nasofrontal, basically in the suture area, the size of the nasal bone is around the 14 millimeter. But if you come gradually down, that is around the 10 millimeter, and then again wide it. So the variation in the size, it provides a shape, hourglass shape, that is responsible for the dorsal aesthetic line. So this dorsal aesthetic line, that is, so this dorsal aesthetic line is the curved and broken line from the medial part of this medial eyebrow and the ipsilateral tip defining point. So the dorsal aesthetic line indicate the key, basically the contour irregularity of your dorsum. So the size and the shape of the nasal bone you assess, and dorsal aesthetic line basically responsible for the different type of the contour irregularities, and length and thickness of the nasal bone, dorsal nasal width. And you also yesterday also see that this bony base width have the two types of the width. One is dorsal nasal width and another is the bony base width. Actually, the bony base width, the distance between the two ascending process of the maxilla, and the dorsum width, the actually width between the nasal bone. So you have to know about the difference between the dorsal nasal width and the bony base width, and you have to assess your the keystone area also, because in the keystone area, this upper lateral and the nasal bone have the maximum overlapping. So this upper lateral cartilage get the maximum support from the keystone area. Now, you have to knowledge about the osteotome also. Osteotome, when we do the lateral osteotomy, then we usually use 2 mm or 3 mm osteotome. And the another osteotome is the straight or the curved osteotome, guarded or unguarded osteotome. All depend on the surgeon preference. Like for the medial osteotomy, we use the 3 mm osteotome. For intermediate osteotomy, we use 2 mm. When you use the guarding osteotome, then your pathway to easy is doing the osteotomy. But when you do the osteotomy with the guarded osteotome, then you have the more damage of the periosteal attachment. Then post-operative, you have the little bit more edema. And if you use the straight osteotomy, then you have the less edema. So this is the difference according to the literature. But in the clinical practice, I think this hardly doesn't matter. You have to, whatever you do, use the guarded or unguarded, you use judiciously. Then the indication of the osteotome, these are the different type of the indication of the osteotome. When you wide the bony before the narrowing, for the straightening, and sometimes when you have a open roof deformity also, then there you have a indication also, and you widen a nasal base also. Goal of the osteotomy, we reposition of the bony nasal wall while maintain their stability and obtaining the desirable width of the bony base and maintenance of the dorsal aesthetic lines. These are the different goal of the osteotomy. And really, with indication, we have the certain contraindication also. So when the nasal bone is very short, then you have a contraindication of the osteotomy. But what happened when nasal bone is very short, then obviously the upper lateral cartilage is long. So in that case, when you do the osteotomy, then the nasal bone is fragmented, and he lost the support of the upper lateral. So the upper lateral cartilage, that is the inferior-medially collapse. So consequently, the patient developed the inverted V deformity. And sometimes when a patient have a history of the hypertrophic scar or wear the eyeglasses, so these are the contraindication of the osteotomy. Now, the type of the osteotomy, we have the different type of the osteotomy, and the name given according to the site. When we deal the lateral most part of the nasal bone, then that is the lateral osteotomy. And when we do the median, then is the median osteotomy. And between lateral and the median, that is the intermediate osteotomy. And sometimes when the root of the nose is deviated, then you use the transverse osteotomy. So we have the different type of the osteotomy, but ultimate the goal of the all osteotomy, that is the same. We reposition of the nasal bone for, and while maintain their stability of bone, and we need the desirable width of the dorsum bony vault. So for the lateral osteotomy, we commonly use in each case, then there is two aspects that we learn for the lateral osteotomy. First is the pattern, and second is the approach. So it's a very confusing, just low to low, high to low. So for you have to know which pattern you use in your patient and about the approach. So first is the low to low approach. Initially, when first you learn the low, that means refer towards the maxilla, and high, that means towards the dorsum. Low to low, that means the pathway of the osteotomy from the lowest part of the piriform aperture to the upper end, that is the same. That is the low to low. Definitely, we have the more medial movement of the nasal bone when we use this low to low. But we have the disadvantage because we damage our Webster triangle area, and we damage or thicken when we enter in the thick part of the nasal bone, then you create the rocker deformity post-operatively. So we have these two disadvantages when you low to low. But definitely when a patient have a excessive bony widening, then we use the low to low pattern. So for avoid the two deformity, then we change our pathway. High, low, high. We engage our osteotome then little bit higher, and when we turn, when we reach at the medial canthus, then we change again direction of your osteotome, so we can preserve our Webster triangle area and the rocker deformity. And definitely the indication is the same. When we need to mobilize the wide nasal bone, and when we correct the small open deformity, then we use the high, low, high pattern. So you judge your patient, then either you need the high, low, high, or low to low. It's depend on the case to case, what deformity your patient and which pattern you need for your patient. And then approach for the osteotomy, really we have the two type of the approach. One is the external method, and other is the internal. In external, we do the percutaneously, and the internal by the transnasally. So when you use the external approach, then you use your osteotome in a postage stamp fashions. And ideally, the site of the engagement of your osteotome along the nasofacial line, and you finally create a multiple 2 mm osteotomies with 2 mm normal bone thickness between the each perforation. That means you have the 2 millimeter thickness, 2 millimeter distance between the two perforations, so that easy to the do the green stick fractures. And after completion of osteotomy, you create the green stick fracture along each osteotomy site. So the engagement of the osteotome, that is important. You engage it at the 70 degree, not exactly the 90 degree, so you can preserve your bony septum. So this is the external approach of the osteotomy, lateral osteotomy. So look that in the video. Because when we performing the osteotomy, then we cannot see. But actually this is the pathway of the osteotomy. So the osteotomy, for my beginner friends, not we fracture the nasal bone, we fracture the ascending process of maxilla. While performing that, we cannot see this step. So this is the external methods. So you appreciate that where we exact engage your osteotome, and we complete free over nasal bone. if we cover it by the skin flap, then we working in the nasofacial groove. So you can appreciate that. On another side, and you usually use the 2 mm Medicon osteotome. That is, you have to have your instrument is good. The Medicon osteotome, 2 mm osteotome, is really very good for the external osteotome. So look that how your nasal bone is completely free. Now the internal approach. In internal approach, we usually use the 3 mm osteotome, and I usually use the guarded osteotome. But the important thing in internal method, we use the continuous lateral technique, lateral osteotomy technique. But ideally the incision, the site of the incision, because if your site of the incision is wrong, then your pathway of the osteotomy is wrong. So the exact site of the your incision is first you identify, you develop the habit of the infant turbinate. For the ENT colleagues, it's hardly matter because they usually do the septal work, but for the plastic surgeon, because they are not usually do the septal work. So first you identify your infant turbinate, and then your anterior end of the infant turbinate, you make a 3 mm stab incision for engagement of your osteotome. And osteotome engage perpendicular on piriform aperture. And you use 2-tap technique. Ask your assistant for the 2-tap technique. And control the cutting edge by palpation with the thumb or the finger by a non-dominant angle throughout the pathway of the osteotome. And the guarding end, that is outside, and the cutting end, that is the inside. So for the adequate mobilization of the osteomized segment, you rotate on the left side clockwise. So this is about the internal osteotomy. And so first you look at where we exact engage your osteotome. Because if your engagement of the osteotome is wrong, then it's really very difficult to do the osteotomy. So this is the standard high, low, high pattern, because we first above the attachment of the inferior turbinate, and then we low again, and once we reach at the level of the medial canthus, then we change the direction of the osteotome. And throughout the osteotomy, then we feel this guarding end by your non-dominant hand finger. So the guarded osteotome, curved osteotome, that is the good for my beginner friends, I think, rather than straight osteotome. So look that you appreciate how the attachment of the nasal bone is free. So attachment of the ascending process of the maxilla is free. And really, it's a big matter of the discussion that which one is good or which one is bad, either the internal or the external is good. Definitely, when you use the continuous, then it have the increased mobility of the bony nasal vault, and you have the consistent narrowing of the nasal pyramid, but you have the disadvantage that you have the significant soft tissue displacement. So post-operative, you have the little bit more edema. But on the other hand, when you have the external, then definitely it's the precise, but the precise due to the preservation of the periosteal attachment to stabilize the osteotome. Because when you do the external, then the periosteal attachment of the osteomized segment you preserve. So the post-operatively you have the little edema, but the patient have some scar problem. But if we discuss the practical aspect, I never seen in my practice scar in by the external methods. So either you use the internal or the external. The most important thing, your patient deformity should be correct. And how you are the more confident, that is the best. How your boss is doing, how your professor is doing, and you are the more comfort ultimate your patient deformity that is should correct either you, and sometimes we need either the combo of the osteotomy, in some case external and the internal lateral osteotomy, we need the both. Then the medial osteotomy. So basically in the medial osteotomy, we separate the nasal bone and the bony septum, and the engagement of the osteotomy is another the important thing. You engage between the junction of the nasal bone and the bony septum, and should slightly fat 15 to 20 degree of midline to avoid cutting into the thick nasofrontal bone. And the indication is almost the same. When bony dorsum is excessive wide, nasal bone is deviated, and bony dorsum excessively narrow and need to widen with the spreader graft. Or you can do in the two way, either in the paramedian when you go straight, and either in the superior oblique manner. The superior oblique manner, that is the good. So in superior oblique manner, when you do, then no need to do the transverse osteotomy. So you engage exactly in the parasagittal manner, and look that. So we separate this nasal bone from the bony septum. So this is the pathway, and throughout the pathway we feel this osteotome on skin, undermine the skin. And then intermediate osteotomy. When you need the external lateral or the median osteotomy, it's hardly matter either you first the median or the lateral osteotomy. But if you need the intermediate osteotomy, then definitely the sequences matter. So intermediate osteotomy we do along the mid portion of the nasal side wall by the 2 mm osteotome, and perform before lateral osteotomy in a straight continuous line. Why? Because if you do the lateral osteotomy first, then the in a stabilized bony segment, it's very difficult to do the osteotomy. So first you do the intermediate osteotomy, then lateral osteotomy, and then the medial osteotomy. It's hardly matter, but first you do the intermediate osteotomy. And these are the different type of the indication when one side of the nasal bone is longer than other, one side of the nasal bone is the concave and other is the convex. Then for correction we need the intermediate osteotomy. So this is the different type of the intermediate osteotomy. I am not usually do by this method, but just for the showing because it's difficult to expose. So in the mid portion of the lateral nasal wall, and you use this 2 mm osteotome. Whenever we need the intermediate osteotomy, then definitely we need the sequence. And if your patient have one side is the concave and other is the concave, then definitely you do the first osteotomy on the concave side, because once you do the concave side first, then this bone allow the convex side. When you do the convex side, if you do first the convex side and then you concave side, then it's very difficult to correct the deformity. So first you do correction on the concave side. Transverse osteotomy, there are certain indication. Then when you use the cross root or transverse osteotomy, then central root of the nose is deviated. This osteotomy have a series of the percutaneous perforating osteotomy horizontally across the nasal root. And this osteotomy performed just inferior to the nasion. So the nasion is the upper limit for the transverse osteotomy. And this osteotomy you need when some patient have a crooked nose, that have a deviated root of the nose. Because sometimes you do the medial, intermediate, and the lateral osteotomy, but once you remove your spleen, then it's very frustrating. Then your root of the nose is deviated. So when your root of the nose is deviated, then definitely you do the transverse osteotomy, just like the intermediate osteotomy. So like in a crooked nose patient, when you do the lateral osteotomy, median osteotomy, intermediate osteotomy, and all these combo of osteotomy, then you should be used in the sequential manner. And When the nose is asymmetrical, then we already discussed, then concave side you address first. These are the some important aspect that you infiltrate properly. You should wait, and incision and the engagement of the or your osteotome should be properly. Otherwise, you cannot do the properly the osteotomy. And you always use the sharp 2 mm osteotome to reduce visible scarring by cleaning the osteotome. Cleaning of osteotome is also a important thing. Osteotomy should be used in the sequential manner in asymmetrical bony vault, and we already discussed then concave side you address first. So these are the important things that you always keep in your mind when you do the osteotomy. Complication of the osteotomy, that some immediate complications or the late complications, some that due to the operative trauma like the bleeding, hematoma, infections, and due to the malunion and subsequent deformity. Cosmetic problem, we already discussed that rocker deformity, stair step deformity, and callus formation, scar formations. But there are a lot of deformity, then you can avoid all structural abnormality as technique dependent. So if your technique is good, if your technique is proper, then definitely you can avoid lot of complications. Either you have the functional complications, either you have the cosmetic complications. So finally, the take-home message, a complete understanding of the nasal anatomy and its variation is essential for optimize outcome of the nasal osteotome. And osteotomies really are an extremely useful technique that can be performed in both cosmetic and the functional nasal surgery. Thank you.
Thank you, sir. Thank you so much. Let's heading toward the ladies and gentlemen. And now I would like to request on stage to our next speaker. Please welcome Dr. Kapil Agarwal, sir.
Good morning, everyone. First, I would like to thank Dr. Sunil Tawar for inviting me here and giving me this opportunity to talk about this technique. And I must appreciate him for his passion, enthusiasm, and most of that, the enterprise to organize these mega events for rhinoplasty teaching is doing very good job. So I will be presenting LR-based management, my technique, which is skin-only excision and LR-rimmed triangular flap, preserving the natural LR contour and design. LR-based modification is very tricky and a scary step in rhinoplasty. And my own fears of producing deformity that led me to develop this technique. The fear of losing convexity of LR, making it straight, losing or compromising the blood supply while I'm performing this procedure with open rhinoplasty, cutting the supply from both sides, from columella as well as from the LR side. So it may endanger the blood supply of tip. And the other fear of failing or going wrong when either I plan this as wrongly or execute wrongly, asymmetry or producing some deformity. So would I be able to correct, or would I be able to reverse the procedure if I go wrong without much scarring and deformity? I went to literature with extensive search. I found all the answers. Those actually alleviated my all fears. If you look at the anatomy, the lobule contains no cartilage, consists of a skeletal muscle and fibrofatty areolar tissue, and that enveloped by dermis and epidermis on both the sides. If you see here, this is the epidermis here, then this fibrofatty areolar tissue, and this is the lining. And the blood vessels, they run over the muscle or inside the muscle layer. And the most important thing which I used to worry about, the flattening of the ala, that this is the forces for responsible for the conversative ala that lie in fibrofatty tissue and the vestibular lining. So whenever we cut it through and through, we are negating the forces, we are neutralizing the forces, so it becomes straight. So it gave me all ideas how to actually prevent this problems, all three problems. So based on this information, I modified my technique. The first change I made in the depth of the excision, instead of cutting full thickness or through and through ala, I chose to excise only skin graft from the marked area, which avoided loss of convexity of ala by preserving the forces lying in the fibrofatty tissue and the vestibular lining. It preserved the blood supply of the ala because I'm not going deep. And in an worst case scenario where I would go wrong in cutting the ala, I could reverse the procedure by just simply putting the excised skin as a full thickness graft. And the second change I made in the design of the excision, instead of cutting straight, I designed a triangular flap at the rim of the ala and limited my excision to the sill only. So this, when this triangular flap is fed into the inverted V at sill, it recreates normal LR base and deepens the LR facial groove. It prevents Q deformity of nostril because it is meeting the sill and it's not a straight scar, but it's breaking the scar with be triangular flap and inverted triangle. So it decreases the chances of scar contraction and stretch. If you look at this is the standard technique, cutting through and through ala. So one thing is first thing, the person has to suture inside the nostril as well as the floor. It becomes difficult to suture it. And then second thing, now this LR rim, which is thinner than the normal base, which is very wide here. So this becomes a base. So it looks a natural base. And this LR rim meets the sill in an end-to-side manner. So the more chances of developing Q deformity. This is the operative video. The first marking right in the LR facial groove. Second marking follows a semilunar pattern. This is a triangular flap over the LR rim and inverted V over the sill. Infiltrating, creating one triangular flap over the rim, excising the skin. You can excise with this the pair of scissors or a blade, whichever is feasible. And now this triangular flap is being fed into the inverted V over the sill, and the incision can be closed with single layer 6-0 interrupted sutures. To simplify this, I've got this animation video. So I make one temporary horizontal line here. So it helps in making this isosceles triangle. And this is the inverted V here, and the lower marking and upper marking meet here. Now excising the skin. And feeding this triangular flap into the inverted V of the sill. So it maintains the continuity of the sill and widens the base, so it looks natural. This elliptical incision, if you see here, in first few cases I did that, and this is the wrong technique. Whenever you excise something elliptical and suture it, it becomes a straight line. So it looks unnatural. So we have to follow this, the design of the LR facial groove, which is convex there, concave there. So we have to make this a semi-lunar design. So when it sits into this, it creates a normal LR facial groove. These are the two clinical examples. These two patients, they approached me for correction. If you see here, this is excessive LR excision and a straight line closure. Here you see this, the incision was taken 2 millimeter above the LR facial groove. And somehow I have seen that it doesn't work in Indian patients. I never advise any patient to do a scar massage in this area forever. So strictly no massage should be advised. Overzealous massage in this LR facial groove after doing LR reduction widens this scar, and a well-hidden scar will be evident. Few clinical cases. This is a boxy tip, frontal view, and this is the oblique view. If you see here, this is the scar. This is a very early photograph, because she was from some other country, so you went in just 2 weeks. In 2 weeks time only, if you see the scar, it looks like just shadow of the normal nose, normal LR facial groove. And this is the basal view, which shows everything. If you see this LR base, the LR base is normal. The LR facial groove is recreated, and the continuity of sill doesn't show any scar, and the normal teardrop shape nostril is maintained, and the convexity of LI is maintained. The broad base, broad nose, frontal view, and the scar is well hidden into the LR facial groove. Basal view shows the same thing. LR facial angle, LR facial groove, nicely recreated base, as well as the nostril shape. And in any case, whether it is augmentation or any aesthetic rhinoplasty, you may need to perform this procedure. You can use the same. Again, if you see this scar, it looks like a shadow of the normal face. From basal view, again, this LR facial groove, the angle, the base, and the nostril shape, everything is maintained. Another case with LR axis. See the scar looks only the shadow of the normal nose. And the base becomes, if you see here, this sill as well as the base is too elevated. Actually, it looks very dirty. So you can reduce the LR size, as well as you can reduce the elevation of the base, and it looks completely normal. This guy got very big LR. The same here. You can't see the scar. The one thing we have to take in, we have to consider when we excise this, our upper part of the excision should not go beyond the LR groove here. It should remain always below this. So I would like to share a few key points of wisdom, which I've learned actually after doing plenty of mistakes. As this step is not an essential step of rhinoplasty, so it should be done for strong or specific indications only. And the only the desires of the patient should not be taken into consideration unless as rhinoplasty surgeon, you are actually convinced that. And whenever in doubt on table, it's better to postpone the step for a later date because it can be done under local anesthesia at any time. And if you are not comfortable, can call any senior colleague or your contemporary who may do this procedure precisely. And better safe than sorry. So always err on lesser side, cut less, and be happy. I conclude here. The skin-only excision and triangular flap techniques has made this one of the trickiest step of rhinoplasty, a simpler one. Very easy to understand. I think most of the person sitting here might have got the idea how to do that. It's very simple. Just two marking has to be done and cut along that. And very preserve the natural LR convexity, LR facial groove, and LR facial angle, and recreates normal LR base. That is the most important thing. The LR base looks completely normal. And continuity of sill, because this triangular flap is sitting into the inverted V of the sill, so it maintains the continuity of sill, so there won't be any Q deformity, and the shape of the nostril remains normal. And there will be a well-concealed scars. And reversal of procedure, anytime if you go wrong, it becomes very easy and very, very minimal deform. You can say the scarring, because one scar will be concealed in the LR facial groove, only the upper scar where you take a suture of the full thickness graft, that will be there. And nowadays so many machines and lasers have come, so you can make it fading away by using those things. As this is a procedure of millimeters, subtlety and conservatism are paramount. This is my publication. Thank you and namaste.
Thank you, sir. Thank you so much. Or let's heading toward, ladies and gentlemen. Or would like to request Dr. Sunil Samdani, sir, head of ENT department, SMS Medical College, along with Dr. Sunil sir and Pradeep sir, please join the stage. Please use round of applause, ladies and gentlemen. Let's welcome to our next speaker. Please welcome Dr. Lokesh Kumar sir on stage. Thank you.
Pointer. Thank you, chairpersons. At the outset, I must congratulate Dr. Sunil and team, including Dr. Pradeep Goyal, to organize this wonderful meeting, which is fifth in line. This has become a prestigious meeting in rhinoplasty surgery. And I must appreciate the enthusiasm with which Dr. Sunil works to organize this meeting and bring everybody together. So without wasting much time, I'll proceed on to this important topic in rhinoplasty. And I consider this most important because it is most poorly understood by many ENT colleagues as well as plastic surgeons. So, which is correction of septum, and especially the difficult septum in rhinoplasty. These are my disclosures. Can we have the lights dimmed here? So rhinoplasty is not confined to the surgery of the external nasal pyramid. The septum is
It's centralizing support, supporting strut. Thus, every rhinoplasty must take supporting role of the septum into account. And all people who are aspiring to become rhinoplasty surgeons should learn this technique. And it is pointless to rely on colleagues to do this job for you, whether you are an ENT surgeon or whether you are a plastic surgeon. If you are a rhinoplasty surgeon, you must learn intricacies of this, these techniques involved in septal correction. As the septum goes, so goes the nose. These are the famous saying by famous people. Form and function should be one and joined in a spiritual union. And if you see most of these Indian noses here, most of these noses require some form of septal correction of the other in almost all the cases. So summarizing the role of septal surgery, it can be used as a support to the nasal dorsum. It is needed for correction of deviated nose, needed for reduction rhinoplasty. It is needed for source of, as a source of graft material. A structural support in augmentation rhinoplasty, as we saw yesterday. And the possibility of an unrelated septal problem requiring correction treatment. Now I'll elaborate this on one of the cases. A few more indications like correction of crooked nose, deep projection of the nasal dorsum, which I've already said, providing structural support in augmentation cases. And the last but not the least, it provides greater manipulation to the tip for deep projection or rotation in any of the direction. These are the basic principles of septal surgery. First step is skeletonizing as for proper visualization of the septum. Second step is mobilization. Third step is correction of angulations, and then complete stabilization of the septum. Now, the patient examination is crucial in these cases. It should be examined for collapse of the external nasal wall on deep inspiration. Cottle maneuver is to recognize the internal valve stenosis, and internal nasal examination should all be performed to see the hypertrophy of the inferior turbinate, which is there in most of the cases on the concave side of the septal deformity. And then the presence of nasal polyps and small tumors, all these things should be examined beforehand. Now, endoscope and CT scan are two indispensable tool in the hand of rhinoplasty surgeons. And they give us a great information about the internal anatomy of the nasal cavity. And we can also do minor corrective procedures using endoscope, as is done in this case. All these polyps are being removed preoperatively by our ENT colleagues using a debrider. Now, CT scan also has become indispensable tool for diagnosis and correction of the septal deformity in rhinoplasty. And I would especially go for cone beam CT, which gives a valuable information, especially about the posterior part of the septum. Anterior part is mostly visible through endoscope or visible from outside inspection, but internal part, CT scan gives a very good information and helps us in planning. Now, the biggest criticism of open rhinoplasty, if we see in cases, most of my septal correction is done through open approach, even though there are few isolated cases of septal correction where I would do closed rhinoplasty and closed correction through Kilner's incision. But most of my cases, because they are difficult cases, are done through external rhinoplasty approach. And the criticism of showing the scar does not hold water, because all these cases are post-op cases and scar is hardly visible. If you do a careful, judicious closure in your rhinoplasty cases. Exposure to the septum is first paramount step, which is helpful in predicting the future outcome of your surgery. Now, this is done through open rhinoplasty approach, as I said, and these are the various steps which we saw yesterday in various surgeries. We go through the midline and expose the distal end of the septum. Then we dissect this densely adherent mucoperichondrium on both sides for about 3 or 4 millimeters. We create these flaps at this stage of mucoperichondrium in continuity with the periosteum on the nasal bones, as I shown yesterday. And then we direct our attention towards exposure of the septum. The first step is to scrape the mucoperiosteum using a fine scissor. And once we get into the correct plane, it becomes very, very easy to undermine the mucoperichondrium all the way to the bony septum. We go in the dorsum at the junction of lateral, upper lateral cartilages with the septum, and gradually, in a gradual manner, we expose the entire septum as far as going back to the bony septum and below in the region of turbinates. So after exposure, what we see, we encounter either a hypoplastic septum, which can be straight or it can be deviated, or a large overgrown septum, which is mostly deviated or crooked in many directions. So this is the diagram which typically depicts a large overgrown septum where it can be deviated, displaced from the vomerine groove, or curved in multiplanes or a single plane. Now the next step at this stage is to do the dorsal reduction if it is needed before we embark on any further procedure. The next step is to remove the portion of the septum which is needed, much needed for the graft purposes. And this becomes very easy. We go all the way down to the vomerine groove, displace it from the vomerine groove, and depending on the need and depending on the case, we can detach it from the distal portion of the bony septum, or we can also include the bony septum in the graft which we have removed by using an osteotome in the same line as the cut in the cartilaginous septum. Now it is needless to emphasize again and again that we have to leave sufficient L strut, and that L strut also should be strengthened by using various grafts. Now the endoscopy at this stage again is a very useful tool to check the spurs and many deformities which you may have left behind, and then you remove them under vision by using various tools in your hand. The next step is exposure of the nasal spine, which I used to do subperiosteal, but I don't do it anymore. I go over the periosteum. And with that over the periosteum approach, sometimes you may not have to drill hole through the nasal spine to fix the distal end of the septum. You may take a bite through the periosteum, which is as strong as going through a hole in the septum, as we had seen yesterday in the surgery which I performed. Now, this overgrown septum is like crooked or deviated or curved because of its size. So we have to reduce it. Even if we don't need graft, we have to reduce it so that it fits comfortably. And then we have to make various minor cuts on the concave side. And then we use a batten graft to strengthen the L strut which we have left behind. Now this batten graft is used flush with the distal margin of the cartilage if we don't want to use any septal extension graft. If we want to use it as septal extension graft, we can bring it out as needed. We saw it in surgery yesterday. This is fixed using few furrow PDS sutures. And then these are more sutures going in. And then this reconstituted septum, which is now very strong and stable, is fixed to the nasal spine in the manner shown here. Yes, this is the bite, which is taken through the periosteum or through a hole in the nasal spine, and then take a bite through the septum. Now, this is not fixed at the distal edge of the septum. You have to offset it, because if you see the normal septum, it projects from the point where it is fixed to the nasal spine. It takes off from there anteriorly, and then it forms and supports the columella. So you have to offset this point of fixation, not fixate at the distal point. Then spreader grafts can be used in cases where it is desirable. This is a binder case where we have used long spreader grafts to make our septal extension graft more stable and to provide the stability to the reconstructed septum. This is how these spreader grafts can be fixed, both to the septum as well as to your extension graft. It becomes a very solid foundation for your augmentation procedure, which you undertake in the binder syndrome cases. The upper lateral cartilages are fixed before you proceed to do any tip work or any other work, and this is how it is done. You can use these sutures, which are mattress sutures, taking all 5 layers, or you can put these knots in between, which I do now mostly. Now, these spreader grafts can be fixed, may not be flush with the dorsum. If you need to augment the dorsum, you can actually provide a base for your augmentation graft material a little higher by putting these grafts a little higher than flush with the dorsum. So you can actually use different combinations to suit your need. A differential spreader grafts can also be used where the septum is having curvature in 2 places. Now, distal part here was convex on left nostril, and proximal part was curved in the right nostril. So we used 2 differential spreader grafts to make the septum straight. So these are the various tools in your armamentarium which you can use in a given case, and one should keep them handy with the knowledge so that they can be used judiciously. Now, last step after closure is that I put lot of sutures, to and fro sutures or multiple sutures through to minimize the dead space between these mucoperichondrial flaps and the reconstructed septum. So now I've taken this algorithm from the chapter in this book, which I was one of the editors of this volume of aesthetic surgery, or in a textbook of plastic surgery by Theme publisher. And this is from the chapter. And I devised this algorithm, which one can use as a ready reference for correction of the septum. There's no need to take photographs. If you want, I can give you. I have it ready. This chapter can be taken from me. Anyone who wants, I have a soft copy of this chapter. So I can give anybody who wants it if you give me a pen drive. So difficult septum is a septum which is crooked in multiplanes. It has history of previous septal surgery or trauma. There are high deviation with the pyramid tilt. Septum is in cleft rhinoplasty is also considered as difficult septum. Septum associated with binder deformity. These are all very, very difficult septum correction cases. And these are the typical cases which you see. Can we switch this on, please? How do we switch on? So you can see the representative cases. Switch this on, please. So representative cases here, you see here, there is a deviated nose, and this is crooked nose, this is crooked nose, and this is the most difficult secondary rhinoplasty. I'll show you a video of one of these cases. And this is again a deviated nose where there is total collapse of external nasal wall. Now, these are the cases which I was talking to, that you need correction somewhere else using septum. So these are the cases where you need to correct. And these are few representative cases in which these surgeries have been used. This is a total collapse of the nasal, external nasal wall. Patient was having difficulty in breathing. And this was the case which I wanted to show you on a video. We exposed the septum utilizing the same method which I elucidated in my previous slide. And once you reach the septum and expose it in toto, you encounter the septum which is weak in all the directions and it is deviated. That's why it is leading to collapse of the nasal tip, leading on to collapse of the external nasal wall. So we expose this in the dorsum. This is the one. Okay. So we expose here. And if you see, this is a little high-speed video. Just for the sake of time, there are 2 minutes left. Sunil will give me extra 2 minutes, I hope, because we saved some time from Kapil's gracious talk. So this is what we expose now. And once we have exposed this, you see there's total buckling of the distal edge of the septum here at this point, and which is leading to the collapse of the external nasal wall. So once we have reached there, now we design a template. So what I use mostly tin foil from the suture material, and I design a template for creation of this template. And then I cut my graft. This is the conchal cartilage graft. I did not need costal cartilage in this case because only septum was to be corrected. So I took a strip and used the concavity in Namaste fashion of Kapil to correct this concavity. And joining these concavities together, I joined this concave the graft. I'll go a little fast here. I think, yeah, the video is mostly done. So this is what you get on the table. This is the total correction, and patient was able to breathe normally. Now, severely deformed septum in all planes. Now, this is the most difficult septum which I have encountered. And this needs an extracorporeal septoplasty. And the representative case is here. This girl was operated thrice before she landed up with me. And she had severe septal deformity in all planes. So we dissected the septum and we saw that this septum is not correctable in situ. So we undermined it from all angles, expose it thoroughly, and then we detach it from the vomerine groove and we detach it from this is the septum which has been removed completely. Now we create hole and we create, you see this slot here in between the nasal bone. We use Fisher bar to create this slot and this septum which is corrected on the bench. Now we fix it in the key spine area using these drill hole sutures and taking 3/0 strong suture. And then we can use our spreader grafts and other grafts onto this to further strengthen this septum, which has been straightened on the table. So if we see, this video is almost finished. So now this is the result. If you see, this is the post-op result of this girl. So you can actually correct with the septum correction. You can correct a lot of deformities. And these are few representative cases which you saw earlier. Another case, one more case. So these are very difficult septum corrections. But if you have all these techniques in your armamentarium, you can actually This is the girl which I showed in tertiary rhinoplasty in the video. And we were able to correct the entire thing using this extracorporeal technique. So the take-home message from this talk is that septal correction is an important step in most rhinoplasties. All surgeons aiming to become rhinoplasty surgeons should train themselves in intricacies involved in correction of the septum. Difficult septum require extra skills and experience and should be attempted by experienced surgeons. So I leave you with these before and after pictures of some of these patients which were corrected using septal surgeries. And thank you very much for kind attention. If there are any questions, I can answer them now. Thank you.
Any questions, please?
So these are some cases in which all the cases required some sort of septal manipulation. Yeah.
Any questions, please?
अच्छा कितने बजे शुरू करना है?
10 मिनट का टाइम मान लिया।
अच्छा 10 मिनट का टाइम। So you want me to show something else? देखें एक मिनट कुछ और दिखा देते हैं।
बोल देता हूँ जब वो रेडी हो जाएगा तो फिर उसको ले लेंगे है ना। मैंने आपको जूम का लिंक शेयर कर दिया।
7 मिनट का एक वीडियो दिखा देते हैं टिप प्लास्टिक का if you want, हाँ, बिकॉज वो शाम के बजाय अभी दिखा देते हैं। From Dr. Sunil that our foreign faculty is just coming on the line and they are preparing for it, and we have 5 minutes. So I would like to share a video of tip plasty. Now this is again a most difficult aspect of rhinoplasty, and there are various techniques which are involved. Can we have the lights off, please? In the tip surgery. And this is a small video, which is, again, this is the same slide which I showed earlier. Most of the rhinoplasties need some kind of tip correction in one form or the other. And exposure, again, is a very crucial. Can we have the lights off, please? Lights off. So so exposure is very, very important, again, for proper tip correction. And how I go about it, that I give this incision and I use this columella first approach, because this patient I use is not an ideal Indian rhinoplasty case, but I use it for demonstration purpose because the cartilage is very strong. The incision the vertical incision has to be a little far behind onto the surface of the medial crus, so that it leaves enough space for any suture which you want to apply. And then you scrape through this subperichondrially or over the perichondrium, and you avulse all the soft tissue till you reach and expose the dorsum. Now this lateral incision is given under vision, and you join these two incisions into the dorsum, and then you again dissect, hugging the cartilage into the supraperichondrial plane using your converse scissor, which is very good. This is the technique in this case where we use columellar strut, which is indispensable in all rhinoplasty cases, because you have deconstructed the support mechanisms of the tip. So you have to use columnar strut in most of the cases, unless the medial crura is very strong. We have to use this. And here we have used the cartilage which we have removed from the cephalic trim in this case as columnar support. So you see the importance of giving this incision little far behind the vertical incision. You leave enough surface of the medial crust for sutures to pass through. The knot is kept in between so that it does not show on the surface while closer. Now these are the sutures which are used for domal creation. So these are domal creation sutures I showed yesterday in the surgery. You take these sutures little obliquely at the cranial end of the dome so that when you close them, it leaves a V-shaped dome, which is an ideal dome. It should not pinch. If you take the suture distally, it will pinch the dome and it will create the pinch deformity into the reconstructed tip. So you go little obliquely. And nowadays, as I showed yesterday, I leave one end of the suture long and tie them together in order to create a dome, equal dome, which is called domal equalization suture. Here, I think I'm taking, no, I think I'm doing it again for some reason. But anyway, so what I do is I leave one end of the suture long and tie them together so that the dome are approximated without taking any extra suture in that. Because if you take extra suture into the dome like this is the technique which I used to do earlier. It creates a depression in the lateral crust when you tie this suture, which is not a desirable thing in most of the cases. In this cases, it is straight. Now, after applying this suture, your lateral crust should be straight. It should not be curved, either down or up. It should not be concave or convex. So you have to put these sutures in such a manner that lateral crust becomes straight and flat. So closure is now carefully done. And most crucial point to close is the dome. Now, this is what I was talking to you about, that some of these techniques you can use in closed rhinoplasty also. If you are familiar about these techniques in your open rhinoplasty approach, because it is very, very difficult to understand initially as closed rhinoplasty surgeon to understand this technique, very, very difficult. But once you do them as open, it is easier to understand and you can execute them in a closed manner using the bipedicle, raising the bipedicle flap with two incisions. One is marginal, another is intercartilaginous incision. You deliver the bipedicle, you deliver the lower lateral cartilages on a bipedicle flap, as a bipedicle flap together with the mucosa, and then you can use these techniques by in this manner, bringing them into the full vision and then taking these sutures in the usual way. This is the cephalic trimming you can do under vision very well. So sometimes this is the patient requires, sometimes you also don't want to violate many supporting structures in the tip. If only you need to correct the lower lateral cartilages and there's nothing else is needed in the rhinoplasty. So these are rare cases, of course, they are not usual cases, but nevertheless, you should know about these cases because you do get requests from the patients. Sometimes they are scared of open rhinoplasty techniques. So this is the measurement. You leave behind at least a centimeter of the lateral crust and you take these sutures, domal creation sutures, in the same way as you take in the open rhinoplasty technique. So knot should always come on the medial side so that it is hidden. These are minor things, but I think we have to take care of these while doing surgery. Knot should always be hidden, either buried in between or it should be inside. So other side, same suture in the closed rhinoplasty. And once you have done this, you can push them back into the place, and then you can bring them together and apply your dermal approximation sutures. Now, as I said again, I don't do these sutures anymore. I just keep the sutures, dermal creation sutures long enough and tie them together. Now, this is the V which I was talking about. You should create this V into the tip, which is very, very important in thin skin individuals. You see this as the post-operative view on the table. So you see this as the isolated tip correction through the closed rhinoplasty. Support graft, yeah, this is another important technique which you saw yesterday, that you don't discard any of these cartilages which you were intended for cephalic trim. You don't throw it away, because more often than not, you will create a notching in the nostril, because most of our cartilages are very, very weak in our Indian rhinoplasty. And if you just invert them and use them as support structure, this is another technique for rhinoplasty, which I showed yesterday in the surgery. You use this ballooning method and hydrodissection by creating under the SMAS flap and excise that in as a sheet. Now, why? Because this tissue which you have removed can be used somewhere else. In this case, it has been used to camouflage on the tip. Another reason is that if you remove it in bits and pieces, you are likely to create irregularities on the dorsum. So if you remove this as a sheet of tissue, it is unlikely that you will create deformity, or you will go in the wrong plane. So you will go in the same plane under the SMAS layer. These are the some of the representative cases which I have found together. So this was a small quick video with the different techniques in the nasal tip, which you could, I hope you appreciated in the small video. Thank you. Sunil, are we ready? So any questions? Any doubts? I think I was very clear in my talk, so nobody has any doubts. Thank you. Sorry, thank you. Thank you. Yeah, you have to have videos very good, and you can have videos very good only if you have totally bloodless surgery. That is important. Yeah, as yesterday I forgot to mention about, I wanted to compliment my Dr. Sunil's anesthetist. Man, a wonderful guy. These guys are doing so good work, I can't tell you. You can't just compare them with any of the anesthetists working in a big hospital. These anesthetists who work in big hospitals, they have infrastructure, they have support, they have so many pair of hands. This guy very coolly working single-handedly, managing 2 theaters. And then I asked him, you know, I always interact. Now, if you want my chapter, there is a full section written on anesthesia part on this chapter. So I'll give you anybody who wants this chapter. So, you know, I made it a point to write about this detail about the anesthesia, because, and then I educate my anesthetists, because most of them, what they do, you ask them for the low blood pressure. They'll say, yeah, it's very easy. I said, what would you do? I'll use propofol, I'll use gas, and I'll use Desmed. Blood pressure will come down. And I said, yes. But what happens when I inject adrenaline? Your heart rate will go up and blood pressure will shoot up. So they give me blank look. This guy, yesterday, young guy, I told him, what do you use? He says, I use Desmed. I said, can you give a beta blocker right in the beginning of the surgery? He says, yeah. What is the problem? I said, what do you use? He said, Esmolol. I said, this is the safest beta blocker you have found. Most of these cases are ESA grade 1. If your anesthetist is good, he will never hesitate in using a beta blocker right in the beginning. What happens with that? You desensitize the heart receptors. So heart does not respond as it would respond otherwise with your stimulus with adrenaline. So using beta blocker is very, very important in rhinoplasty if you want to do this kind of. And then you inject as much as you like. I use 1 in 80,000. For you, it may be sounding dangerous, but I don't use more than 4 or 5 cc. And with beta blocker, heart rate goes down sometimes to 50 or 55. With the use of 180,000, it can at the most come to 60. It doesn't go beyond that. So I think I use that routinely. And then most important part of bloodless surgery is going into the correct plane. If you are in the superficial plane, and if you saw yesterday's surgery Sunil performed and I did, if you are in the right plane, you will not encounter bleeding. If you are in the wrong plane, there are 2 problems. Once you encounter bleeding, and second, you're going into the superficial wrong plane, you are inducing more fibrosis, and fibrosis will adversely affect your long-term results. So fibrosis at all costs should be avoided in rhinoplasty, and this is the way to do it, that you go in proper plane and dissect in proper plane. So these are the few take-home messages, I think, tips and tricks. So you have to find anesthetist like Sunil somehow. I don't know where he found him. Guy is wonderful, wonderful guy. So this is the way. And then he has very good technicians. I don't know how this guy made this diced cartilage. You could inject that diced cartilage through 18 gauge needle. None of my assistants have ever been able to achieve that. The guy was amazing. He just, diced it so well that I could inject with a 16 gauge needle. So yeah, I don't know how they are wonderful guys. So very good, Sunil. Thank you. So I must meet your anesthetist. Yeah, he was a wonderful guy. I must meet him. Wonderful, cool guy. Very cool. Thank you.
Thank you, sir.
Hello.
So, all right, ladies and gentlemen, right now we are just welcoming Dr. Enrico Roberti on screen to our next speaker. Thank you.
I can hear you.
Hi, Enrico, Lokesh here. Welcome.
Hello, Lokesh. How are you?
Yes, great. Thank you very much. Thanks for sparing time for us.
No, don't worry. I had a problem this morning, but I'm here.
Yeah, I heard the tragic news about your dog, Enrico. You are having so many problems in life. First the corona, then
it's been with us for 12 years, and it's a bad thing.
And last time I remember your favorite assistant, who used to do your good work. He also passed away last few years back. This is terrible for you to have such hard time. And anyway, thank you very much for sparing your time in these hard times. And we would have loved to have you physically, but it is not possible. But we will, next time you should make it a point, because we are planning our national meeting now, because Corona is more or less over now, hopefully.
Yeah.
We are planning our national meeting, rhinoplasty meeting. We will invite you for this.
All right, absolutely. If the world will still be in the same.
Yes, absolutely. No, I think we'll be all right.
Yeah.
We are all positive.
Yeah, well, hopefully.
Hopefully, yes. So how is the preparation for Bergamo course?
No, it's going pretty well, actually. It's very complex, as you can imagine. Now we have the Russians who cannot come, probably, but apart from this, it's over 500 attendees, which is a lot, and plus faculty, and it's a complicated meeting. It's very intensive. Have you seen?
Yeah, I know. I've attended 2 of them, so I know that it is like you can't just leave. There are no loo breaks. If you go for loo break, you miss something.
Yeah,
so, you just go for 5 minutes outside, you have just missed so many things.
Yeah, so it's and this year probably it's even more, because I wanted to concentrate on the difference between preservation and structural so much.
Yes, so for audience like Dr. Enrico Robotti is organizing these courses at Bergamo, which is a must-attend meeting in Bergamo. Everybody should go at least once to attend this meeting. It is, you know, you will meet who and who in rhinoplasty from all over the world. This year, unfortunately, I can't come because there is a parallel meeting going on in Goa. We are having our National Society meeting of our aesthetic surgery meeting in Goa starting next week. So we will do. So without wasting much more time, I request Dr. Enrico Robotti, who is a well-known rhinoplasty surgeon from Italy, Milan, Bergamo, to give his lecture. Dr. Enrico Robotti, please.
Right. Let me thank you for this, these kind words and the invitation. And let me share my screen because for some reason, something is happening here. Do you see my screen?
Yes, 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 please.
Perfect. Right. So if you see me and hear me well, over the next about 30 minutes, I will give you my thoughts on what I'm calling kind of hybrid rhinoplasty. Now, this is a complicated game since you know, in 30 minutes, I can just give you some concepts. And the main thing behind it is that I've been a structural surgeon all my life. I still believe in structural concepts. And I was intrigued by preservation concepts because I studied them carefully. And after an initial distrust, now I have come to integrate them in my practice. So it's again a pleasure to be with you. My disclosures are with QMP, from which I derive royalties, and Marina Medical Instruments, from which I derive no royalties. And the concept we have here is this, for me. Structural thinking is not destruction. So I'm a friend of Roland Daniel. I've known Roland Daniel over the years, but his editorial was totally misleading. Structural rhinoplasty is not destructive, unless it's done badly, like anything else in life. Preservation has merit and has a lot of merit. Hybrid combinations, in my head, make sense. So this makes things even more complicated. It's not just choosing between black and white. There are shades of gray. Now, I only do open rhinoplasty, and that's another long story. I've thought of this many times, but I want to see what I do. And to get some certain kind of results, I just want to have a direct view. And then I want to change structures accordingly. And then the skin will redrape, considering the fact that you have to understand the quality of skin that will allow this to more or less degree. I want to control my septum. I want to do it the way I was taught by Wolfgang Gubisch so many years ago. I want to see it. And that's why I open things up. I want a top-down approach. And the scar is not an issue. It's simply not an issue unless you don't do it well. So rhinoplasty has seen over the last maybe now 4 years a significant change. New anatomy findings, a lot of work by Roland Daniel, Peter Palazzi, preservation concepts coming initially with a lot of hype. There's less hype now and more understanding. And this has to be benchmarked against structural reliability. So considering that shape is given by structure and structure is best controlled under direct vision, why should we do something different? Structure does not mean bulk. The grafts are generally small, at least in my hands. Dead space is avoided. I am keen on this. This is something I owe to Rod Roerich. And tip stiffness is totally overstated, and it can be mitigated by some means. So again, why should we change? Structural rhinoplasty does not mean destruction. First part of my talk. And of course, it's a little complex because first you have to expose, then you need a component separation, then a reduction. Then you have to rebuild, not to reconstruct the plateau by spreaders, by spreader flaps, and by individual osteotomy and osteoplasty. And then you need a contour on top, which can be fascia if you want, can be perichondral periosteal flaps, needs new tools, etc. So it's kind of complicated. However, it is the time-proven standard, i.e. the benchmark. The keystone is, again, reconstructed. It's not destroyed. And poor surgery, like happens in preservation, leads to revision. Component separation, incremental reduction, in this case, a spreader graft, and then the apparatus on top of the spreader graft. So it's not a destruction. It's just taking things apart and putting them back in a better way. This is a case from 2012, and you can see that he has multiple irregularities, and you can see that I get patients from really all over the world, especially secondaries. Most of my primaries are Caucasian, obviously, and he just wants to be natural. He just wants to be natural. He wants to breathe because he has a deviated septum, and that's the cone beam story. It's a long thing, but if you read the paper we published on PRS, cone beam is just so essential in rhinoplasty for me. Then the septum is handled. In this case, it's an extracorporeal. It's done on the table. It's placed back. And then we have an ethmoid plate to keep it straight. And then we have a central L-strut plus medial crura transaction overlap plus articulated grafts that will lead me to a good result. And now this is obviously structural. There is essentially no other way save structural thinking in a case like this. And once again, the objectives are giving him a natural nose. That's what he wants. Is it a perfect nose? No, unless you use Photoshop, makeup, different lighting, different perspectives, which I see kind of frequently, unfortunately, nowadays. She is 2013. She's thin skin, elastic, which is a good thing. 8 months post-op here, 8 months. Not a year. And you can see that essentially she got what is a pretty nose, well proportioned. There's a lot of structure below it. Once again, this is extended lateral crus at the turning point. It's a proper proportions. And at 1.5 years, she has a proper look. So once again, if these are kind of things, why should we change? Why? And there is an answer to this, because man has to be curious to progress, and there may be value to change. And some new concepts make a lot of sense. So preservation concepts, part 2 of my talk, have merit and should be applied wherever it is logical to do so, which is not wherever marketing takes you. And the logic is this: instead of doing all these 3 steps, you could simplify. Because sometimes there's reason. You see, I did her, this is 2 years post-op. She has a little inverted V, yes. And this is not okay. The bones are here, and I mean, of course, I reconstructed her keystone, but I didn't do it properly. And the reason I didn't do it properly is shown on the table. I did not close the bones enough. I did my spreaders, and then I left a gap here, which is very unusual, but it happens. So that's why you should think of some other option, which is preserving the dorsal. Now, does this make rhinoplasty easier and faster? No way. Rhinoplasty has become more complex. Algorithms are more articulated. They're still developing. Time and study are needed. And in my opinion, the process is worth it since the results are better. And listen, does preservation reduce the incidence of complex revision of rib work? This is exactly what is unfortunately contained in Rowling's editorial: prevent the use of rib by doing preservation. I'm sorry to tell you, this does not happen. Both surgeries, both techniques depend on doing them right. So I get these mails all the time. Over the last month, I did 2 patients who had that preservation. I needed rib on them. Surgeon completely changed my nose to a ski slope, fear saddling, cookie cutter surgeons, perfect predisposition for saddling, ethnicity gone, these kind of things. This is not what these people want. So preservation concepts have influenced my technique over the last 4 years now, prevalently regarding the dorsum. And I currently apply, this is interesting, preservation principles to different degrees in about 70% of my primaries, which is a lot. How were my techniques influenced? By plane of dissection, by preserving and or reconstructing ligaments. Again, this is not a gospel. This has to be done carefully. And push down, let down variations and hybrids. Now, usually, and you'll see my concept, is I preserve my dorsum and I do a still structural tip. This is the blend I apply more frequently. So, plane of dissection. Plane of dissection, I select my plane, which can be all subpericondral, subperiosteal from the beginning, that's a long story, from the edge of the lower lats, or start supra and then go sub, which is most frequently done. Then I decide what to do on my dorsum, component or preservation. And then I end up with my tip work, which is usually structural, where ligaments matter, but they don't matter so much as to respect them every single time. So this dissection in continuity, what I call my SPP from Baris, from Neves, from Goxel, you can do it starting from the lower edge of the lower laterals, or you can do it starting almost at the scroll, which is a little bit more frequent. I detach and reattach my periseptal cleft. We are submitting a paper regarding this. I call it my 3-point compartmentalization techniques, the other 2 points being the scroll vertical ligaments. I do a subpericondral dissection in the middle vault in a single layer. And the vertical scroll ligament is divided, the scroll cartilages are marked, and this is my SPP plane. So it's a total subpericondral, subperiosteal plane, starting a little bit before or a little bit after at the lower lats. And essentially, you can actually see the two scroll ligaments, the two scroll cartilages here, which will be marked and will be re-approximated by sutures so as to re-establish the vertical scroll ligament. So it's a single plane dissection. And I was using Nazim's pericondral periosteal flap for a long time. Now I've usually stopped using it. This kind of dissection will facilitate your dorsal work by allowing you proper osteotomy, osteoplasty, and mid-vault tuning. And I firmly believe nowadays that this total SPP plane leads to less swelling. It's not only this, it's other things which I have no time to discuss, but this makes a big difference, especially if you resuture it in the correct way. So you see the plane here, it's a completely SPP plane. And then at the end, you will see that I grab my periseptal cleft and I will lead it back to its position. And then I will also suture the vertical scroll ligaments. Now, preserving and reconstructing ligaments. What about the interdomal ligament? Yes, that's one of the main things. It can be often preserved. So I do my tip split less often, and I use this ligament as a sling to the distal septum or to the SEG, to a septal extension graft. I call it my ligament sling. And that helps in flexibility to the tip. So should I use a strut? Yes, but the strut will be a spacer after I have done the ligament sling. It's a spacer. You can see the concept. And then this, you can call it Baris C point, but this is just a variation of what has been described in the diamond tip by Gruber, of course, by Barman, and by so many others. Anyway, and you can see that the way this is done, it's the dome equalization stitch, but essentially I do not have to split my tip unless my tip is so severely deviated distally that I need, obviously, a full tip split. Then the scroll suture, I've been doing this for years before this was kind of described, but essentially I am reestablishing the horizontal, not the vertical scroll ligament, and I am giving my tip cartilages a little bit of eversion. You know, the Toriumi thing, which has also been explained by Milos Kovacevic, etc. So the kind of eversion that you need. Re-establishing the vertical scroll ligament helps in gaining this eversion and kills the dead space. You don't want dead space in rhinoplasty. This concept, this supraalar groove concept. Now, what about Pitanguy, who is probably turning in his grave because he's mentioned so much? Well, I identify the superficial and deep Pitanguy ligament. The superficial I don't really use. Sometimes I do that, but the deep Pitanguy ligament I will reuse as a sling. I cannot suture it back in its original position since I have changed my tip. So I will use it as a sling to define my supratip break. This is not a new idea. This, in a way, is not dissimilar from what Barman Guiron described, although he was essentially using dermis for this. Now we have identified the Pitanguy ligament to do this. So this is what happens at about 1 week. Again, we are talking of dorsum preservation and the structural tip. My tip remains structural with more preservation of ligaments. And frankly, I preserved most of LLC like many others before the preservation wave. Now people are telling everywhere, oh, I preserve all my LLC. Of course you should do that. And this dates much before the preservation concepts. It's a lot of preservation of the native structure of the LLCs. Now let's go to the hybrids because I see I'm getting a little bit late. In selected cases, which does not mean I don't do complete letdown. I do complete letdown quite often, but this is a little bit outside the scope of my talk. Hybrid blending makes sense. Third part. Now, what's a problem with the standard push down, let down technique, like let's say the Saban thing? Limitation number one, the dorsum aesthetic lines have to be ideal from the start. You simply cannot modify bony width, asymmetries at the keystone, and asymmetries at the cartilaginous midvolt. That's as simple as that. And if you are doing this closed, you have another limitation, reshaping your radix. You can't do it. And that's where you get the step off. Of course, there are ways to avoid it, but essentially you are getting it unless you have an open access and you can burr it down. And fixation is far less predictable. Of course, there are sutures, but they don't really work that much. So my question is, can preservation of the crucial keystone central area, the central keystone area, can that be done while at the same time improving asymmetries of the midvolt and addressing issues with the bone width or bone asymmetry? And the answer comes from what I consider my septal T concept. We described this some time ago. And if you think of the anatomy of your septal T, there's an anatomical plane which is not what is described as being flush along the septum. It's an anatomical plane. It looks like an aircraft carrier seen as from below. And I used this for different reasons in my paper, which was reconstructing it as a spacer and a conformer in both a supratip and infratip graft. But now if we consider the same dissection, which has to be done on an anatomical plane, we can simply do a heresy here, which is do a little bit less preservation, but preserving what matters, opening the midvolt. And we published this. Now we have so many changes. I need to publish the new series. We have probably about 300 or 400 cases of this. And we published this in Aesthetic Plastic Surgery some time ago. I called it my modified dorsal split preservation. And the title came from Rowling. He advised me on this. And this is Rowling when he came to Bergamo regarding the cone beam CT scan, which we published, the Bergamo experience, 5-year experience, recently in PRS. Now, looking at the bony cap, when the bony cap is small, like in this instance, if the bony cap is small, 3 millimeters is not correct. It can be even 4 or so. We reduce the bony cap by piezo or by burr. We avoid, listen, avoid full circumferential osteotomies, thus keeping a stable dorsum. we limit the push down to the central keystone area, the septal T, using its elastic hinge. We do any septal work since it's open. We can narrow the bones in the conventional way and fine tune the midvolt. So essentially,
the key elements of the split dorsal preservation.
You see, I've split the septal T. I'm using piezo here, septal strip, high septal strip. You see the elasticity, and you can overlap it.
In this case, the septal T has been anatomically isolated.
So I've taken the strip. You can see the hinge, and then you have it's a flexible chondro-osseous joint, and then you can suture it under direct vision, which will make this thing stable.
It can be seen how the septal T
and overlapping it.
To whichever side of the septum is convenient.
So essentially, we are decapping by piezo or by burr. Now we've taken that bony cap out. This has become weak and flexible.
Obviously, the bony hump must be a
And obviously, the best indications are people with mostly cartilaginous hump, which are common in my practice. Now we do a conventional septoplasty, L-strut septoplasty. So we do it in the usual way. And we can harvest a lot of septum, which does not happen with the Cottle technique. This is end to end, and you can do it end to side. So essentially, we reduce the bony cap, we open the midvolt along the septal T, we excise a high septal strip. It's a high medium, actually. We push down the septal T, preserving the keystone. We fixate by sutures. We do an L-strut septoplasty. We do osteoplasty and osteotomies. We adjust the upper lats. We reapproximate the midvolt by sutures. And then we rebuild back the total SPP plane after the reconstruction by 1 minute it takes to suture everything back by sutures of the midvolt. And then we placed this SPP plane single flap back in its original position. So opening the midvolt is crucial. It should be done according to the septal T anatomy. It's a distinct plane and needs a semi-sharp suction elevator. It's not a sin. And importantly, it allows what conventional pushdown cannot do. You can fine-tune the midvolt. And you can see I'm fine-tuning the upper lats. And so it extends your indications so much. You simply can play with the upper vault excess. And you have spared what really needs to be spared, which is the central keystone area, which is the one being subject to pushdown. So essentially, you can see I am reshaping the midvolt. So that's what it looks like on the table. And this is essentially a straight dorsum, because this is not really okay for those people who want a scoop. I know many Turkish surgeons do that. My kind of population is not, frankly, this Barbie-like noses. So you see the cap here, and you can see the way that the dorsum has been preserved and the tip is still structural. And you can see the anatomical plane. So the distal septum height, importantly, has to be preserved, as well described in preservation concepts, distal to the W point. It works indirectly as a small septal extension graft. That's the concept. Of course, you can add other things. You can add spreaders, you can add conventional SEGs, you can combine with septoplasty. So the L-strut septoplasty is easily possible. And you see, I use a long piezo insert. I think piezo has so much of an indication for the septum. I use currently a mixture of piezo and burrs. Piezo for cutting bone and for septoplasty, and burrs for the rest. They are quicker. This is an ethmoid splint. It's used to straighten my septum. So it's like you do in a conventional structural work. I'm combining with spreaders. And then simply, I am putting everything back. And you see this element here is just the septal T out of the way because it will be repositioned like the lid on a box. Here it's combined with septoplasty, and here it's combined even with extracorporeal. This is the septal T to be pushed down. This is the septal strip. This is the septoplasty. And you can see that everything will be put in its position. So this is a kind of different concept, combined with osteoplasty and osteotomy here. So you do essentially, after you've done the cartilaginous push down, you do your bony work in precisely the same way as you do conventionally, and then you reposition the elements of the mid-vault together. And fixation is made so much easy because once you've pushed this down, then you can fixate under direct vision. And that fixation holds because you are seeing it directly. You have direct access to fixation. I do what Neves described, the Vitruvian Man maneuver. Essentially, I'm splitting this because it's not really a high strip. It's a medium high strip. I leave about 3 or 4 millimeters, more 4 than 5, than 3. And I split it vertically so as to flex, allow a better control of the keystone, and after the vertical split, I will proceed with the suture fixation. I don't do the ballerine. I don't like the ballerine. I think it compromises my stability too much. So she's a Middle Eastern patient. She has problems. She's a primary. She has problem with her pinch tip. She has a high dorsum, doesn't want to reduce it that much. That's cartilaginous push down. And importantly, it's direct dorsum narrowing. If you see this patient, her dorsum is fine. If you see her before, her dorsum was overly wide. And so this dorsum has to be reduced. And I reduce it since I can combine cartilaginous pushdown with conventional bone maneuvers. And you see, even at 6 weeks, she's not really swollen. And at 1 year, you can see that essentially she has that kind of dorsum precisely, which was arranged, and her bones are narrowed and the conventional bony work is done. He has a rather wide dorsum, bulbous tip. His tip is a little bit drooping. He wants to get rid a little bit, I'm keeping my interdomal, of his hump. And essentially, I've rebuilt his mid-vault. I've done a structural tip. You can see that his bones are slightly narrowed. His hump is essentially gone, and his tip has been managed in a structural way. And of course, the scar is negligible. She is too narrow, and the tip is ill-shaped. So why don't we play with both worlds in a way? She has a hump, obviously, and that's the cone beam. And you see she has such a tiny little bony hump. It's mostly cartilaginous. It's a perfect indication. So we'll split along the septal T. I will add some width with some spreaders, and then I will rebuild my dorsum on top. I have done a cartilaginous push down plus spreaders. She's shown here at 4 weeks. She is a little bit swollen, but you can see that the amount of swelling is really negligible. It's not really much. And you can see that at 1 year, she has that exact tip definition we want by structure, and that cartilaginous push down helped, and her width was slightly widened by those hidden spreader grafts, which we mentioned. And she has wide bones. Can she do a conventional push down now? She's not a candidate, but she's a candidate to preserve the beauty of the central keystone area that I have to narrow. And I have to go along my septal T. Look at the bony cap. she is a good candidate. The bony cap is okay. And you see that I'm sorry what happened here. You see that at 1 year, she has that exact control of height and the bones are slightly narrowed. So with progression of the learning curve, this technique helps to extend the indications considerably and the control of the keystone fullness improves. She is a cleft. She is deviated. She has a problem with her tip. She's been operated already, but not appropriately. And you can see that I still preserve the central keystone in this case. And the bony cap is just a little bit, not much. Piezo first, distal septum correction, high septal strip. It's practically a conventional septoplasty, rebuilding my central mid-vault. And then this allows control. You can see her on the view from above. And at 10 months, you can see now, what did I preserve? I preserved my central keystone area by a cartilaginous push down. Obviously, I overlapped this to one side as well. She's not perfect, obviously, because she's a cleft. He's deviated, right? But it's a bony matter. I still can preserve this central keystone. And so I will essentially, I also have some septal work here, little bony cap, not much, as often happens, but a considerable bony and cartilaginous deviation. I've done my cartilaginous work, and you see that it's not perfect, because perfection is, again, Photoshop, but it's okay. And you can see that I took the dorsum exactly to where I needed to take it. She's crooked. So I still can preserve the central area. So the indications change completely. Otherwise, she would not be a candidate for preservation. The problem is her front view, the crookedness. So I do my FPP plane. I do a structural tip. I resuture my septum in the middle. And you see that at 1 year, she is essentially straight. She is wide. So she's not really a candidate for a push down. It would make her even wider. So again, it's a cartilaginous push down together with osteotomy and osteoplasty. I am doing on my bone what I would do naturally. Same thing. She is wide and she can reduce the width of these nasal bones after preserving the central keystone. You see, she's become narrower. I use here Sebastian Haack's and Wolfgang Zgubich's TTC suture. I think it's a huge, huge, wonderful technique. Suturing the nasal bones makes such a difference. Again, she is crooked, but I can preserve this. So I will do my cartilaginous push down, dorsal split cartilaginous push down here. See the CT scan, it really helps you so much. I believe the cone beam is essential, especially in secondary, but also in primary. And I will use an ethmoid splint. And you see she's only at 6 months here, but she is essentially a straight nose with a nice dorsum. Obviously, this is the ideal indication, so we don't have to talk of this. I'm seeing I'm going over time, so I will come to a conclusion rapidly. I would have wanted to talk to you of the full letdown, but I don't really have time. So I believe that total SPP plane, when indicated, will determine less edema. It really will determine less edema. See this case here? She is mostly a tip problem. She has a hump. And again, for me, this is, you see the little bony hump? This is an indication for the technique I have described. And you can see that bone reshaping can be done with finesse together with a structural tip work. I did her chin in this case with an implant. Same thing here. bony asymmetry, tip asymmetry, considerable bony asymmetry. And in this case, this leads me to the full push down, full let down, sorry, of which I don't really have time to talk to you, but what happens is that I do my mid-volt split anyway. It does not really change. And just quickly, in the full push down, let down technique, I can adjust the mid-volt by septal T separation, which allows me better access to the fixation. So essentially, I'm applying the same concept even when the bony cap is a major one, and I do need a full let down procedure. I am still heretically opening the mid-volt. See here, this is a full let down, complete, because she has a considerable bony hump. This is not for cartilaginous pushdown. And so once I've done this, I can, under direct view, opening my mid-volt, I can suture fixate, and I can importantly shape the radix step off by the use of burrs, which is so important. You can only do this in the open approach. So even in the full let down cases, I will split my mid-volt and end up in a reasonably soft tip. All right, so cartilaginous push down, modified dorsal split. I can do it on any bony pyramid which has a small bony hump. I can adjust the mid-volt by separating the septal T, which allows me better access to fixation. And what's the take-home message? Sorry, I went a little bit over time. Think structure, preserve what is compatible, blend both of them. And none of the cases I showed you had any revision, none had any fillers, none had post-op cortisone injections, and all are 1 year unless noted. So rhinoplasty is really complicated. It's becoming more complicated. Let's try and make it easier, although this is not easy. And that's the Bergamo motto, find a way. And that's why we called our kind of motto, finding the way in the maze of current rhinoplasty. And please join Europe Society of Rhinoplasty Surgeons, the RSC. I'm leaving my presidency to the capable hands of Werner Hept in March. And thank you so much. And sorry, I went a little bit over time.
Thanks, Enrico. Wonderful lecture and new concepts. I'm sure the audience will appreciate your new concepts about the hybrid rhinoplasty. There's one question which I wanted to ask you. Hello?
Yes, I'm here. I'm here.
So one question I wanted to ask you, in your hybrid technique, you open the middle vault and then you use the push down technique. Do you are separating the upper lat from the septum, and then are you going all the way into the bone to separate, or?
No.
No.
The difference, let's play it this way. If the bony cap is a small one and the hump is mostly cartilaginous, I can just play with the cartilage, meaning I am splitting my mid-volt in an anatomical way, which is different from doing it straight. Okay. We don't need a blade. You need a blunt instrument because there is a plane. This is what people don't understand and textbooks don't specify. Because if you look at the conventional component separation, they cut it straight. I don't want that. I want to go on the anatomical plane. So once I've done that, if the bone is just a small one, I'm not really needing to do anything else except splitting it, pushing down my central keystone area, which means the septal T, playing with the asymmetries, and then reclosing with a continuous suture 6-0 PDS my mid-volt. If I have to do a conventional letdown, meaning that I decided that the bone cap is so strong that you really need to let it down in a conventional way, I am still splitting my mid-volt until the bone and not any further, because this will allow me so much better control. That's it. So I know it's a heresy because some people say you are not doing preservation, and my answer is I can't care less. I am doing a hybrid.
So if the hump is bony, what do? Do you reduce it with piezo or?
So if the hump is a small bony one, I reduce it most. I've a little bit gone back to the burrs now because I have some wonderful burrs, and taking down the bone by piezo takes a long time. So I will burr it down or piezo it down, and then I will do the cartilaginous push down. Now, if the bony hump is a big one, I go with a conventional let down.
Thank you. Any questions from the audience?
It's not easy, Lokesh. It's not easy for me.
I know. This is a very advanced technique. I must say that it is not for beginners anyway.
No, but the problem is, very frankly, if you do let down, which seems to be nice and easy and simple and smiling for half an hour for beginners, then you go to rib after 6 months.
Yeah, absolutely. Yeah, I agree. So thank you very much, Dr. Robotti. And, we would have liked to have you here for felicitations and all. Unfortunately, that can't be done, but your certificate will be delivered by Dr. Sunil. He is coming to Bergamo to attend the course. And he'll bring your participation certificate. Thank you very much.
Thank you. Thank you very much. I see Dr. Singh as well, and Sandeep and all my other friends. So it's been a pleasure to be with you virtually.
Thanks, right? Enrico. We'll see you sometime. Yeah.
Yes, absolutely.
Maybe in Turkey. Are you coming to Turkey for ISEX?
I will come very briefly, but Lokesh, I will see you in Turkey. Yes. Again, this is in Turkey. It's going to be, I kind of like a balanced view. Right. In Turkey, obviously, the view is going to be preservation. So anyway, I will come to Turkey.
Yeah, sure. Okay.
Thank you.
Thank you. Thank you very much.
Bye-bye. Bye-bye.
Bye-bye.
So, right, ladies and gentlemen, let's welcome our next speaker on stage. Please welcome Dr. Kapil Soni, sir. Would like to request huge round of applause, please.
HDMI 2.
A very warm good afternoon, and I thanks Dr. Sunil Tawar. He was a good friend of mine. I really admire his enthusiasm towards rhinoplasty. And it's always an honor to attend this prestigious meet. What happened? So complications in rhinoplasty, it is as important as rhinoplasty itself, because it's not only to manage this complication, it's always to foresee and prevent the complication. Otherwise, it's always very difficult to manage complication as all. So broadly, it can be divided into intraoperative, immediate postoperative, early postoperative, and late postoperative. So the complication starts if intraoperative complications, excessive bleeding. It may be genetic or drug induced, but the proper infiltration of anesthesia with ADR, it usually prevents this excessive bleeding. And if there is excess bleed happens, what is required is you should stop, try to locate the site of bleeding with a good light. That is what is all required. If there is a tears of flap, it can be resutured at the end of the surgery with absorbable sutures. And if it is on the both sides, a piece of crushed cartilage has to be kept to prevent the perforations. And during the dorsal elevation, there is always, sometimes there is a buttonholing of the skin. So what is required is just a taping at the end of the surgery. We need not suture that part. We need not suture the skin. And as far as possible, cautery burn should be avoided. Actually, this complication of facial swelling, ecchymosis, and subconjunctival hemorrhages, especially ecchymosis, we should foretold the patient that it is not a complication, it is usually part of the procedure because it is so common. And usually it subsides within 2 weeks, and patient should be reassured. He should be advised that yes, you have to do the ice pack, you have to apply it till 1 day. And what I do is, immediately after the osteotomy, if you keep a pressure for a few minutes over the osteotomy site and injection dexamethasone 10 milligram at the end of the surgery, they are really helpful. And if it persists for more than 2 months, we can apply the hydroxyquinone, but that is very rare. Usually almost all of this patient, this complication subsides by itself after 2 weeks, maximum 2 weeks. You can see this patient first day, immediately after surgery, after 10 days, after 1 month. Then a patient comes to you that rhinoplasty has been done, results are wonderful, but doctor, I can't breathe. So there is a persistence of intranasal mucosal swelling. So there is some tendency sometimes that yes, there might be some deviation and we need to reoperate. No, we should not reoperate and should be reassured, because these are the patient who has a history of allergic rhinitis, and you should foresee this and ask the patient to continue on antihistaminics, and usually they subside by 6 to 12 months. And as far as possible, repeat surgery should be avoided. Mucosal dryness, it is very common in Rajasthan because we have a dry atmosphere. What is required is moisturizing solutions. Hematoma, as per the guidelines for hematomas. Infections, toxic shock syndrome. This is very, very rare. But sometimes below the packing, there is a oozing of pus from the skin. It should be foreseen. Immediately pack should be removed, and broad spectrum antibiotics and hydration should be given. Epistaxis, it usually happens after 7 to 10 days. We have to see the site of the bleeding. Then there is a graft infection, rejection, and potential exclusion. We'll see this in our next slides. Intracranial is very rare. So this is the most potentially, and actually what I say is not noticeable disruptive postoperative complication. That is the depressive rejection of the image change. What happens is, at the time of the dressing removal, doctor is not there and the relatives are not there to reassure the patient, yes, your nose is looking good. So some patient, they went to depression. They go to depression because they can't cope up with the change in their self-image. They would say that, yes, doctor, the result is good, but I can't cope up with my new image. So what is required is psychotherapy, and we have to reassure calmly that, yes, it is nice and you will be better. But that is a very depressing thing. So if we divide the complication according to the site of the nose, in the upper third of the nose, ovary section of the nasal bone, you have to be very judicious in taking out the nasal bone from the door. If there is a hump, we need to know how much hump has to be removed. So what we can do is, earlier there was if you use a rasp, it is a more gradual thing to take out the bone. That is more safer than instead of taking out in toto. So if there is a bone is removed, excess removed, we need to put a dorsal only graft, and believe me, it is a more challenging than keeping the precaution in the first place. Open roof deformity. Open roof deformity has so many reasons. One of the most common reason is there's a flat top appearance after a proper, because of the failure to close an open roof with an appropriate osteotomy. It is a flat top appearance of the bony pyramid. So what is required is, medial and lateral osteotomy to close this. That is what we know. But there are other things also which lead to this open roof deformity. The first is green stick. Some surgeons, they prefer green stick fractures. It's a nice thing, but sometimes they return back to their original position. This is the one thing. Excessive nasal packing. We should be very judicious in keeping a nasal. It should not be too much, like not the bulky nasal packing should be done. And one of the other thing is uncorrected deviated perpendicular plate of the ethmoid. There is a bony deviation and we didn't correct that deviation. And this because even though you have done the osteotomy, even then it is not able to close the gap that has been formed because of the hump removal. So we need to look after this. So these are the 3-4 things. Rocker deformity. So what is rocker? Rocker is because the osteotomy, usually we do osteotomy till the middle canthus, at the level of middle canthus. If you have gone too far superiorly into the frontal bone, what happens is when you try to medialize the nasal bone, that bony part, the upper part, they rock laterally, that comes laterally. So what is required is we need to do the appropriate back fracture with the transverse osteotomy, percutaneous transverse osteotomy. That is all is required. In the first instance, we need to plan our osteotomy. We need to put a marking. We do the osteotomy accordingly. And if it happens, what is required is transverse osteotomy. So this is a rocker deformity. Other thing is stair-step deformity. In the rhinoplasty surgery, what is required is during the surgery, we need to palpate all the time where we are. Because of the soft tissue edema, we may misjudge the situation. That is more appropriate in stair-step deformity. So what happens is at the lateral osteotomy, in these cases, lateral osteotomy is anterior to the ascending process of maxilla. And if we do not palpate at that time, we may think that yes, we have done a good osteotomy because there is a soft tissue edema, only to reveal this problem after the edema subsides after 1 month, 3 months. And so here it requires the proper planning, proper marking, proper proceeding. So what is required is, we do 2 types of osteotomy, internal and external. Internal osteotomy, there is a guard. We need to palpate that guard at all the time while proceeding with the osteotomy. Otherwise, there are very high chances that we may deviate from our path and we land up with this problem. Percutaneous perforating lateral osteotomy, they lend a degree of safety because we are doing everything under our vision, where we are going. So we have to manage, and it is really difficult to manage stair-step deformity. Middle third, that was about the upper third. Middle third is polybic deformity. So what is polybic? It results when the lower third of the nose is more projected than the tip. So why does it happen? Polybic deformity post-operatively can be happen due to 3 reasons, primarily 2 reasons. There is a true polybic and then is a false polybic. So what happens is in true polybic, there is inadequate resection of the caudal dorsum septum and upper cartilages. While in false polybic, you have done everything right at the time of surgery, but there is a over resection. You have taken out some extra things, and then there is subsequent scar formation. So what is required is we need to palpate while at the time of surgery. That's how much do you have to take it out. It has to be appropriate because we all know that tip is 2 mm, 1 to 2 mm higher than the dorsum of the nose. So we need to do that thing. But if there is a false polyp, there is a scar formation. What is required is we need to appropriately, patient should be counseled that he needs to apply taping. What is taping? That he needs to do this. There's a micropore. Patient need to apply over supratip region for at least 1 to 2 months. And even then, if the problem persists, steroid injections, that 0.2 to 0.4 cc of 20 microgram or per cc of injection triamcinolone should be given deep to dermis. This is the most important part, that is has to be given deep to dermis. And even if problem persists after 1 year, there is nothing than to do the revision surgery. Then comes the inverted V deformity. You can see this inverted V form. Why does inverted V deformity happens? It is because the inverted V means that there is an accentuated visibility of the caudal margin of the nasal bone after the dorsal reduction. As we just seen that in an earlier presentation by Dr. Robotti, that there is a T-shaped septum at the junction of nasal bone. So if we do the dorsal reduction, there is a thinning of that area. And if we don't stitch back the lateral upper lateral cartilages, so what happens is that the upper lateral cartilage, they displaced inferiorly and posteriorly, thereby accentuating the caudal margin of the nasal bone. So this leads to a formation of inverted V. So what is required is we need to repair the upper lateral cartilages to the dorsal septum, and the use of spreader graft, usually they help prevent this complication. So it is so mandatory that we need to reapply the sutures after taking out everything to prevent this complication. This is a post-operative patient. Why does this happen? Because of the over-resection of the quadrangular cartilage is with insufficient dorsal strut. So we need to foresee this problem. There comes the insignificance of palpation. Because of edema on table, it looks very nice. But after the edema subsides, this is the result. And there is one more thing. While if there is during the surgery, if you find that the keystone area there is a problem in the keystone area, we need to reconstruct that area with the help of rib cartilages, preferably, or if they have sufficient septum, you can do it. That was about the middle third. Then comes the tip. This is a complication that actually usually comes after months to years. BOSA. These are the results of visible flexing and buckling of the alar cartilages. Why does it happen? Because of the over-aggressive cephalic trimming of the lower lateral cartilage. We need to keep at least 7 to 10 mm of, minimum 7 mm of cartilage should be preserved if we are doing cephalic trimming. It may not be obvious at the time of the surgery. It may not be obvious after months, but after years, you will find this thing. So what are the risk factors? Risk factors because of the thin skin, strong alar cartilages. They have a strong alar cartilage. What has remained is they are strong. So they buckle themselves. And the tip bifurcating. Precaution is same, maintaining the strength and integrity of the alar cartilages, using structural grafting whenever necessary, and symmetric reconstitution of the dermal subunit. And we may camouflage this problem with this irregularities with the temporalis fascia or crushed cartilages, dice cartilages. Visible graft. I never use allografts because of this problem. Patient comes to you with this problem months to years. Initially, the results are very nice because of edema, but then it happens sometimes. And it is more problematic in those patients who have a thin skin. So what we can do is, this can happen even to allograft, autografts. So what we can do is we should camouflage with the temporalis fascia. Yesterday we saw the demonstration, very nice demonstration by Dr. Lokesh sir. He used rectus abdominis sheet, that fascia. So we need to cover up this everything with some sort of fascia or some cartilages to camouflage it. In case of graft, the problem is that graft may extrude sometimes. They may extrude at the time of, not at the time of surgery, they may extrude even after 7 days, after 10 days, that you may see the part of the graft is coming out through the incision site. So what you have to do, if it is an autograft, you need to trim it and then resuture the skin back. But if it is an allograft, there is no point in keeping that allograft back into the skin. You should take it out. And personally, allograft should not be used because of the potential for extrusion. Pinch tip. If the alar cartilages are, we have taken out the cephalic, they may result from the over-aggressive cephalic resection of the lateral crura, which results in weakening of the remaining stem strip. And the precautions is we need to preserve the 7 mm of minimum cephalic after doing the cephalic trimming. Nostril asymmetries, they can occur from unmasked septal deviation after caudal septal resection, placement of a septal extension graft, or asymmetric tip modification. So it is very important to recognize the preoperative nostril asymmetries and counsel patients appropriately in this regards. This happens because we routinely apply septal extension graft. So the judicious use of this is very important because this may lead to either retraction or more excessive columnar show. So overly tight closure of the margin incision, overly aggressive resection during cephalic trim, lateral crural spanning suture, wound contracture. This may lead to the alar columnar disproportion. For example, in this patient, retraction may be corrected with the use of alar rim graft. In minor cases, with placement of ear composite graft, including skin, in more severe cases. We can see in this patient colon retraction has happened because of the inappropriate use of the inappropriate septal extension graft. It may result from either over-excessive resection, middle crura, or excessive setback of the middle crura after placement tongue in groove sutures. So columnar strut or plumping graft. Plumping graft, we keep it at the base of the columna. They may be helpful to just to correct this deformity. Then comes the columnar alar base. Scar formation. Patient should be counseled about the potential for scar formation from the columnar incision in external rhinoplasty. But believe me, they are very nicely healed. Most of these patients, they usually do not complain of the incision at the columnar site, incision sites. But yes, they should be counseled. There will be a scar. Alar base excision puts the patient at risk for a visible scar formation. The columnar incision is performed using inverted V so as to prevent the scar formation. It is not straight, because the inverted V, and some surgeons, they prefer stair step. It decreases the formation of scar, visible scar. Meticulous attention to closure. Yes, it is very important that meticulous attention to closure will help prevent the scar formation. Airway. Airway, it can occur as a result of external nasal wall collapse, internal nasal wall collapse, septal deviation, intranasal synechia formation. Weak lateral crura can be reinforced with lateral crural strut graft. Spreader graft may be used to widen the peduncle of internal nasal valve. If there is a synechia formation, it has to be corrected surgically. There's no other way. Then comes the septal perforation. What to do with septal perforation? First is to prevent it. If there is a tear on the one side, or there may be tear on the both sides. So if there is a tear on the one side and the other side is okay, then there is no point in worrying. There won't be any septal perforation. But what happens is when there is a tear on both the sides and there is we need to repair at the time of surgery with the absorbable grafts. And we need to put some sort of crushed cartilages in between that flap. And first and foremost, there should be a meticulous dissection of the flap, and to avoid this problem to ever happen. Hematoma, as we all know, we have to take out the hematoma, put some pressure. It should be drained immediately. Otherwise, it may lead to the other complication. It may lead to there is infection, there is epilepsy, then there is a saddle nose deformity postoperatively, as we all know. Then costal cartilages. It is so many patients we use costal cartilages, and the problem is warping. I don't go into the warping. So we need to do the concentric carving, and it's a separate topic basically, how to prevent warping. But yes, you should be very cautious and taking out the cartilage and putting it into the nose. And although you have done everything, but it's still important to counsel the patient regarding the risk of cartilage warping and subsequent irregularities or visibility of the graft. Although we apply temporalis fascia, we put diced cartilage to camouflage all these irregularities, but still patient should be well aware that yes, this thing can happen even months to years after the surgery. While taking out the cartilage, pneumothorax is a rare complication from autologous cartilage harvest. The risk is roughly 1%. So this patient should receive a postoperative chest radiograph and admitted for observation with a repeat chest radiograph on the morning of post-op day 1. Usually, if there is a rent in the pleura, we may suture it. And in the other case, we might need to put a intercostal drainage tube. While taking out the cartilage, what we do is we preserve the posterior part of the perichondrium, and we put a saline over that area, and we ask our anesthetist to do Valsalva maneuver to increase the pressure in the intrathoracic cavity. And if there is no bubbling of the air, bubbling of the air through this saline, we may be well assured that yes, there is no problem going to happen in this patient. This is what happens. This is if we use a synthetic graft. There was one photograph where this becomes visible to the patient over the skin. And the other problem is, this is the patient who comes to me after 2 years with this problem. Patient was put on a synthetic graft, and after 2 years, this problem because of the constant rubbing over the nose. So this happens in a patient. So at the end, in the summary, the dynamics of nasal aesthetics and function are very complex, and therefore the potential for the complications are myriad. The thorough understanding of the nasal anatomy and how various surgical maneuvers affect both form and function is imperative. Some complications are within surgeon's control, but those related to techniques, yes, it is under surgeon control, but those related to a patient wound healing are out of surgeon's control. So careful patient selection, history, physical examination, photo documentation, patient counseling, which is most important beforehand, are very important aspects of the surgery and should not be underestimated. Thank you very much for the patience listening. Any questions? I will be very happy to answer. Thank you very much. Thank you.
Thank you, sir. All right. So in this queue, I would like to request on stage Dr. Mahendra Hada, sir. Sir, आपको join करके रखना है, please एक बार. आपको join करके रखना है. Would like to request Dr. Mahendra Hada, sir, on stage. Huge round of applause, ladies and gentlemen, please. And now I would like to request to our chairpersons, sir, please join the stage. It's a beautiful memento. Thank you, sir. Thank you to our chairpersons. And finally, thank yous to our speakers. So now, ladies and gentlemen, lunch is ready. और इसके बाद हम जो हमारा next session है उसमें आप सभी को join करेंगे. Thank you so much for the wonderful speakers, wonderful chairperson, wonderful guests over here. Thank you.
Check. So good afternoon, everyone. After lunch, once again, welcome all. So finally, I'll request to now Dr. Anita Kothari, ma'am, Senior Consultant, ENT Jaipur. I'll request to ma'am, please grace the rise as a moderator of this session. And I'll request to Dr. S. Gambhir, sir, please join us. Please grace the rise. And now I'll request to Dr. Amar Singh, sir, speaker of this session. Please come here and give your session on challenges in management of crooked nose deformity. Thank you so much. So over to Dr. Amar Singh, sir, and requested to moderators. Thank you.
Okay.
Oman. Dr. Amar Singh has special interest in being trained in facial plastic surgery, especially functional and aesthetic surgery of nose. He has many publications in local and international journal and has authored a book, Basic Septal Rhinoplasty, Practical Steps to Step Approach. He has been regular in coming to India for teaching rhinoplasty. He has been to various conferences in India and he's a very good teacher. I have personally gone to Oman for his conference and loved his work there. And now I introduce Dr. Amar Singh. Sir, can you hear me?
Yes, Dr. Gambhir. Am I audible?
Yes, sir. You're audible, sir.
Okay. Can I start?
Yes, sir. You can start, sir.
His first slide is on?
Yeah, we can see that, sir.
Okay. First of all, let me congratulate and thank Dr. Sunil for organizing this excellent workshop. I'm sorry this time I could not come because I was traveling. So maybe next time, definitely I will make it a point to attend your such excellent course, as well as then share my experience in rhinoplasty. The topic which I selected today is the rhinoplasty in crooked nose. I think crooked nose, it is one of the most difficult surgery in rhinoplasty. I think there's no challenge greater in rhinoplasty other than correcting crooked nose deformities. Why? We will see the reasons. Now, crooked nose is, what is the definition is when we say the nose does not follow a straight line from the central facial axis, which is bent or it is twisted. And crooked nose is not just only bent, but it is a spectrum of multiple type of deformities. And most commonly, it is due to traumatic cause. This is typical, the pathological anatomy, the different type of the anatomy, what we see. There's not a single type of the deformity. There can be mainly cartilaginous, there can be linear, there can be really reverse C type of deformity. On upper, you can see in here, upper 1/3, there is a convexity, then is a concavity, and tip is one to other side. And this is typical S type of deformity. Now, along with this, the basic is what you will see from outside is visible to the patient, and it creates a stigma for the patient. As a result, patient is having a lot of along with the psychological issues. But not only the aesthetic, but patient also has got severe obstruction, aesthetic, and functional problem. Now, challenges occur because the deformity is contributed by all components of the nasal pyramid. That means the bony pyramid, the mid-dorsal cartilaginous, lower lateral cartilages, septum, and also the external covering of the soft tissues. All these anatomical regions contribute for the deformity. So this is the typical kind of the cases what you find. Very asymmetric type of the bones, and you can find patient has severe nasal obstruction, twisted kind of bent septum, and you can, along with that, there is a lower lateral cartilage deformity. Mind you, I was practicing in Oman. I think the patients of Omani are not much different from the subcontinent patient. And our patients also have the thick soft tissues. So this causes more problem for our post-operative results. Now, today's, with the modern social media, the challenge comes additional to the surgeon. The patient, what you used to read in our textbook in early 80s, 90s was, you cannot make ugly nose beautiful. You can make ugly nose to pleasing, attractive, beautiful. But today, the patient wants ugly nose to be the most beautiful one. That is the biggest challenge to the rhinoplasty surgeon in correcting this twisted nose deformity. Another challenge is doing it right first time. Nobody wants to have the revision surgeries, certainly. So objectives of the surgery is basic. First is we must restore the function. That is a nasal airway. We must restore the patient who has severe nasal obstructions. Then is symmetry, that we need to have the smooth dorsal contour. Tip should be well projected, unbroken brow tip aesthetic line, and nose that is harmony with the rest of the face. So the basics of the surgery is basically starts with your clinical evaluation. You must listen to the patient medical history, what patient has concerns, and then detailed functional aesthetic analysis. And you must have the detailed inspection, not only of the nose central third, but also the overall face. Look for any facial asymmetry. Must palpate the nose, special cartilages, and caudal septum. At times you find patient, they hide from you that patient, they had some previous septal surgery. And this will, your palpation will let you know that patient, whether septum, condition of septum is there or not. Then endoscopy is must every patient should have. Sometimes you might find some surprises within the nasal cavity. Then clinical photograph. I don't do CT scan for each and every patient of crooked nose deformity unless it is revision or patient has got other problem suggestive of sinus inflammation or sinusitis. This is typically, if you do a cone beam CT scan, what you find, asymmetry of the bones. At times it will tell you that the patient has got fracture during childhood trauma. You can see in this patient. And also you can see other surprises, severe septal deformity, concha bullosa. But this, you don't need to diagnose with the CT scan this one. You should, your endoscopic examination should reveal you. And just this is, you can, plus if you do a thorough analysis, you can see this kind of patient at times. You can see the frontonasal suture line here, which is usually 5 to 6 millimeters cephalic to your middle canthus region. So the management principle of crooked nose deviation is, first of all, is you should have the maximal surgical exposure. That is possible only with your external rhinoplasty approach, not with the closed technique. And you must eliminate all the extrinsic and intrinsic factor deforming forces which are acting on the septum, soft tissues, as well as on the upper lateral and the cartilage dorsum. Then you must align the external bony cartilage alignment. Of course, this will require structural support. So this is typical of what we need. You need to create a very solid, stable midline, stable axis. Around that, you must create your rest of the structures. So open approach gives you a lot of advantages. It tells you the underlying deformity. You can plan your surgery and reconstruction, a very technique, you can do it. The key maneuver for the crooked nose correction is straightening the septum, as we mentioned, and then complete osteotomy and mobilization, and reconstruction with sporograft with this modification. Then when some patient may need dorsal camouflage augmentation, and then terminate management. These are basic things. However, the proper septal reconstruction is the foundation of the deviated nose deformity. There are various techniques. There may be in situ technique, extracorporeal, and one must prepare the patient preoperatively that in case I don't find you in your good cartilage, you must do take consent for conchal or costal cartilage in this kind of cases. I burnt my finger in early part of my practice. You can see this young lady. She has a very twisted deformity. Almost all components of nasal pyramid is having twist. And I opened the approach and I put some graph. What you find is result after 1 month, she was quite happy. 3 months, not very, but after 1 year, you can see slight there is a twist again. In this, because I did not take, probably the cartilage has caused, again, memory, cartilage has got memory, soft tissue memory, and it causes a twist and recurrence of deformity. So she was not very happy. Even I was not very happy. I offered for surgery and she declined. This is the oblique view. Tip is well projected, except for mid deviation. After 1 month, she was happy, but after about a year, because there's a recurrence of deviation, so it was not really a good result from my side. So good judgment comes from experience. Now, experience sometimes comes from bad judgment. This typically example, similar type of very severe scoliotic nose. And this time I was better prepared that we must prepare the patient. Probably you may need a structural reconstruction with possibly the costal cartilage graft. So this is typical. I'll show you how we did now the fixation of the. This is typical of what Gubish has mentioned. TTC suture in the morning. I think Roberti was talking about. This graft must be securely fixed to the drill bone, to the lower end of the nasal bones, and then obliquely passing from other side, come to upper lateral. We are passing the suture, the 30 PDS suture. This kind of reconstruction gives a very solid foundation for the rest of the nasal midline structure you can build up. This is what you find after about 7 years. Patient has got very straight nasal profile. You can see nasal dorsum. You can see there is dorsal aesthetic line is straight. You can see in the basal view, the asymmetry of nostril. However, it is very difficult to achieve complete equalization of the nostril, but tip is well projected up. You can see on the profile view, dorsum is straight, nasal tip is well projected up. There's a hump, it was there, hardly you can see now. So this is what we get with the proper structural reconstruction. Other problem sometimes comes is the problem of thick skin and soft tissue. Sometimes, howsoever you may do the good reconstruction, because in these crooked nose deformity, the thick skin tends to be inelastic and it possesses memory. And thick skin usually associated with greater scar tissue formation, there recurrence of deformity comes. This was the case. I did surgery first in the closed technique in 1999. He had come back again with recurrence of deformity, similar type of deviation. In 2006, we did open technique. Again, we did a spreader graft, bilateral, septum is straight, again caused recurrence of deviation. Again, we had to do third operation in 2014, June. At this time, we had to do a camouflaging of this external depression there and putting this graft, conchal cartilage graft, subperiosteally along this depression. So just a camouflaging. Otherwise, it does not have rest of the problem. So with this, there is an acceptable outcome. Now, nose is straight. The depression has now got corrected. I think now for last 2 or 3 years, he is doing very well. Now, this is a tie again very severe kind of crooked nose deformity, post-traumatic. You can see the really twisted nose. There's a huge hump, tip is depressed. This requires a complete, again, reconstruction of the nasal pyramid, including the tip, osteotomy, mobilization completely. So this is open approach. I just skipped the videos. And smoothing of the dorsum with the power instruments, removal of hump. You can see the severity of the septal deformity. And the bony part of the, you can see septum also is very twisted there. Release of the upper laterals. You can see the, now you can see here again, thick septum, sharp angulation. So we had to correct, remove this part of septum, do a spreader grafting. This is the example again. Idea is to create a very stable mid septum, mid dorsum and septum. And in this, not only the spreader graft causes a mid dorsal correction, but also the caudal septum. I don't say this is a septal extension graft. This is the septal reinforcement graft and fixation of this caudal septum to the spine. And this kind of bilateral spreader graft and caudal septal reinforcement graft creates a very stable fixation. And this is what you get. This patient was studying in UK, so I could not get his prolonged long-term follow-up result. So after 1 month, he still does edema, but nose looks straight, and patient is quite happy with his both functional and aesthetic. Spreader graft, as I said, it is indication are many. I don't want to repeat again the same thing. At time, this kind of what you get is septum deformities are very severe and they are very weak. So we need to reconstruct firmly. There's no question of just using a fractured kind of septum. If the septum is not strong, probably our long-term result may not be adequate. So this kind of, you should be a very stable fixation. Sometimes you don't get the straight piece of septal cartilage. If you get a little angulated, you must also use it because the convexity of this one, you can use it. It can help the convexity of the curvature of the dorsal deviation. So it counteracts the convex deviation. Again, the bilateral spreader graft, you can see now very weak caudal septum. This will not support itself. So after releasing from the spine, we have to reinforce it additionally with the septal reinforcement graft. This kind of the result. So this is what you get. Again, very severe scoliotic nose, asymmetry of the lateral walls, very bulbous tip. In these kind of cases, sometimes you might have to use a double spreader graft or asymmetric type of graft. And again, a very stable caudal septal fixation here. If cartilage is not enough, we can use ethmoid splints. They give a very solid support. So this is what we get result. In difficult cases, especially this kind of the patient, if we don't get the good amount of cartilage, there is a choice to do a extracorporeal septal reconstruction. And in this kind of extracorporeal reconstruction, we must do a 3-point fixation to the nasal bone, upper lateral, and caudal septum. This is what you get result. Of course, she has little facial asymmetry, as she has macrognathia, but she was not willing to get orthognathic surgery. So she preferred to force us to do a rhinoplasty first. So best results in rhinoplasty, especially in the corrective surgery of the twisted nose, are in the primary surgery. In revision is always a compromise, especially more so in deviated nose deformity. One should avoid temptation of doing septoplasty alone, because the septoplasty in long term, it fails in relieving obstruction, because the septum and external pyramid functionally and aesthetically, they are interrelated. So one should not do septoplasty in crooked nose deformity. Rather, it should be a single stage surgery, septum as well as the external nose deformity correction at the same time. This is a typical young lady. She had undergone septoplasty surgery. After about 2-3 years, she came back again because she did not have relief in obstruction. You can see there is a severe scarring of the nose, their septum, residual septal cartilage. And what we find here is somebody has done crisscrossing, and that also on the wrong side, that is on the convex side he has done. So there is again furthermore deviation of the septum causing functional problem to the patient. So we had to take ethmoid splint as well as the wormrine cartilages, residual septal cartilages, and refashion it, make a good graft, and reconstruct the rest of dorsum. So it is difficult because the outcome in revision cases are not promising compared to the primary surgery. So one should avoid temptation of doing septoplasty alone in twisted nose deformities. This is another patient. This young man, he traveled abroad, probably came to India for his crooked nose deformity because he could not wait for our long waiting period in our hospital. When he came back, after about 6 months, he had again problem with recurrent epistaxis. And on examination, what we find is a very severe, there's a large septal perforation, you can see here. And that was causing his epistaxis. Also, there's a persistent obstruction, and you can see they did not do any external nasal correction. So he had problem of, again, persistent deformity, additional problem, septal perforation. Again, we had to harvest temporal fascia, conchal cartilage graft, and do a revision and septal perforation closure. It was a difficult surgery. And this was after 1 year. What we find, nose is straight now. He is quite happy with the outcome. Somehow, it was difficult to close this large 2 centimeter perforation. There is a small posterior septal perforation residual is there, but that isn't causing no symptom to patient. It's asymptomatic as far as this perforation is concerned. So one should avoid doing septoplasty alone in this kind of cases. Again, you can see this is the outcome. Again, this twice earlier operated. You can see there's hardly any evidence of the previous surgery except that very severe twisted asymmetric walls and nasal obstruction, TPs collapsing down. And what we find, to my surprise, the surgeon has only removed the only caudal part of the septum, and he left the remaining part of the septum intact posteriorly. So it was advantageous to us because we could harvest enough graft and then could reconstruct with the bilateral spreader graft using then septal extension graft in type of the spreader type of extension graft. And this is the result after 6 months. Tip is well projected. The dorsum is straight now. You can see dorsum is straight. Again, dorsum is straight. He is quite happy. Again, 2 years later, same patient. So it is not, whatever we do, it is not a short-term outcome. It's a long-term outcome we must try to give to the patient. Because once you do surgery for a patient, it is your patient for lifelong. So best thing would be in rhinoplasty, unlike any other surgery, we have to make our concepts very clear and there's no shortcuts. It is the lifelong learning. For each case is different. You can see here again. So the message to my to everyone would be that in the rhinoplasty, septum is the most important part, especially when we are doing in the crooked nose deformity. We must try to stabilize the septum, giving a best kind of the strong support, giving bilateral spreader graft, extension graft, and caudal septal reinforcement graft. You can see here, and fixed to the, never try to shorten this caudal septum. If it is a fragile septum, whether we are doing endonasal ENT surgeon, caudal septal correction, we must try to reinforce with the straight piece of cartilage and fix it with the 40 PDS suture. Now again, see, typical example, this young lady, she underwent septoplasty about 6-7 years ago because she had obstruction, but somehow her obstruction did not get any relief, and she developed again external, you can see lower 1/3 is deviated to one side and a bulbous tip, typical kind of patient. I'll show the typical this endoscopic picture. Caudal septal dislocation, which is not corrected in the first surgery. This is a deviation of the, again, mid septum touching the lateral wall, terminate, you can see here. This is nasopharynx. So again, the procedure is open approach, removal of the hump, cartilaginous hump, and little bit of bony cap. This caudal septum must be reconstructed by the residual septal cartilage and ethmoid plate. I think with the, I'll just show you short video. The diamond burr gives a very nice smoothing of the nasal dorsum, especially even cartilage and some minor kind of the bony deformity. It helps to avoid rasping. Now in my practice, I have stopped using rasp completely because rasp to me, it gives more, causes more soft tissue trauma. And remaining part of the ethmoid plate and more warmer bone, we want to fashion it and make a small drill hole. Then join with the rest of the residual septal cartilage and reconstruct bilateral spreader graft. Again, caudal septal reinforcement graft. This must be strengthened. And joining with the upper laterals. This is what you get. Preoperative after 6 months, after 2 years. Post-op, same thing. Preoperative, you can see the result. This is long-term result. Preoperative basal view, profile view, preoperative 6 months after 2 years. Again, preoperative 6 months, 2 years. Again, after 2 years, oblique view. She's very happy with the outcome. So the message is always create a very stable foundation, central foundation with the very bilateral or unilateral spreader graft and caudal septum reconstruction, especially in this kind of cases, what I call I-beam technique. Bilateral extended spreader graft, joining with the caudal septal reinforcement graft. Here, typical example. And you get this long-term result. This is after many, many years, this patient came to me again, post-operative. is very happy. Next step is important is complete mobilization. Avoid giving the green stick fracture. In these kind of cases, I always prefer to do a complete mobilization with the intermediate or paramedian osteotomy, then transfers, low to low, lateral osteotomy, low to low, no low to high. I don't think the Webster triangle, what has been taught, it is a myth nowadays. I have never seen, I have done thousands of rhinoplasty surgery. I did not come across any of the patient having nasal obstruction because of the Webster triangle, what is written in the textbooks. I think we need to really rationalize our thinking. And then these kind of patients, they require intermediate osteotomies. Yes, root osteotomy, this central bony axis deviation because of the nasal bone attached to the bony septum. Yesterday, Dr. Sunil was mentioning. I think again, the same thing. You need to think about that, how we do it. Only by doing transverse osteotomy, you will not correct this bony deviation. So you need to do root osteotomy here complete. You need to fracture the bony septum along with the this radix around this here. Now we know by anatomy, our frontonasal suture about 5 or 6 millimeters cephalic to this one. So one should not get worried about, unless avoid, you will do a lot of rocking movement of the bony septum. There's no question of going to the causing CSF or anterocranial fossa. So in this kind of the bony root axis, we must think of doing root osteotomy. Our transverse and lateral parameter not going to correct. So these are decisions for osteotomy should be done preoperatively, not on table. What you have decided on the preoperatively, we must perform on the table, because on the table, so many things change, dynamics change. So we have to, that is very important concept we have to keep in mind. Again, similar type of patient. You can see complete mobilization osteotomy. Again, doing a root osteotomy. You can see now here, it's straight. Next, last step is after completing the mobilization and reconstruction, at the end, we must think of whether patient needs some depressions, augmentation, and correct those irregularities with the soft tissue or maybe the soft cartilage graft. Like this typical patient, severe twisted nose deformity, we had planned mobilization and maybe we will do some augmentation here. So again, after doing, so our Dice cartilage gives a very nice filler to reduce these deformities or depressions. This is what we get post-operative. After 4 years, you can see his midline axis is very straight, stable. All the depression has gone and tip is vertebral projected. Profile is great. Other side. So in conclusion, the managing twisted node deformity is the most challenging for rhinoplasty surgeon. And you need to be familiar with the different principles, and we must have different armamentarium in our with us. And open structure rhinoplasty gives the best answer instead of closed technique, because it provides anatomic reconstruction for both functional and aesthetic outcome. Thank you very much for your kind attention.
Thank you, sir. Thank you very much for your excellent talk. And it was a really great insight in learning about the crooked noses. Any question from the audience? So there's one question from my side. Can you hear me, sir?
Yes, sir. Yeah.
Okay, sir. Yeah, so because in crooked noses, there is a difference in the length of the upper lateral cartilages also. How do you take care of that?
I think very important question what you asked, Dr. Gambhir. I think upper lateral cartilage, yeah, there is a difference in the length, not only in the length, but in the strength of upper lateral, which one side of the, because most of the time these cases are childhood trauma. And one side of the cartilage, you can find atrophic, and there is this is causing imbalance in the forces. So what I do in this kind of cases, if there is a lengthening and shortening, I try to give a spreader graft, double spreader graft on the shortened side. I do not try to reduce the longer side upper lateral. The upper lateral, it has underneath, it has got a nasal valve, intranasal valve. So if you try to resect the upper lateral caudal end, you are trying to compromise the intranasal valve. So I will try to do in this kind of cases a double spreader graft, maybe on the opposite side. I will like to strengthen the opposite side of upper lateral.
Okay.
So that is, I think that that what I will do in this kind of cases.
Thank you, sir.
Yeah.
Thank you very much. Thank you, sir. We conclude your lecture, sir, and like to meet you next time in the meeting.
Oh, sure, definitely. And I'm sorry this time I could not because I was traveling. So I was having jet lag after coming from US. So that's what made me to change to next time. Certainly I will be coming to.
Thank you, sir. So there's a question from the audience. They're asking this, what is your experience regarding large septal perforation?
Yes.
Closure regarding for that.
Yes. I have closed perforation as large as up to 3 centimeters. But you cannot close the 3 centimeter size perforation completely. This is a very difficult problem. Best thing would be to prevent, as morning, I think one of the speakers was talking about how you can put a small piece of crushed cartilage and fascia and repossess the flap very nicely. But for large perforation, correction would be with the open approach. I do open approach. I take a temporal fascia graft. I take some conchal cartilage graft, and I take a lot of tissue glue along with when you correct this one. But these are very difficult problem. And mind you, to correct a large perforation, you can reduce the size of the perforation. Try to close the anterior or mid part of the perforation. If the posterior part perforation remains there, it does not cause any symptom. It remains asymptomatic. So that's how we do it. So never give 100% result outcome for the large septal perforation. It's a very difficult problem. And the best thing would be to prevent. But yes, open approach is the one I find in my hand. It gives excellent results. I've done quite a good number of perforation cases with open approach, but it is a very tedious procedure.
Okay. Thank you, sir. Thank you very much.
Thank you.
Thank you. Thank you so much, sir. And now I'll request to Dr. Lokesh Kumar, sir. Please, sir, join to Dr. Gambhir as a moderator. And now I'll request to Dr. Sunil Tawar, sir. He's the organizing secretary of this program. He will present here on the topic tip modification. So over to moderators.
Hello. So good afternoon. Tip modification, really, it's very difficult to simplifying the tip because tip really a comprehensive topic. Earlier we have seen the video, Dr. Lokesh sir, that is very good. And in this talk, we have a small, basically for my beginner friends. Then first, really, the tip surgery remain the most discussed but least understood aspect in the rhinoplasty operations. The most difficult aspect in nasal tip surgery is predictable outcome. The reason, because the tip have very endless anatomical variations. So there is no single technique by which you can complete the tip surgery. So surgery of the nasal tip require a comprehensive knowledge of the nasal anatomy. So this is all about the tip. Now, the foundation of the tip surgery. Foundation of the tip surgery is basically depend on the tip anatomy, tip aesthetics, and the tip dynamics. Then you have to thorough knowledge about the normal anatomy. Then you judge about the abnormal anatomy. First, you learn about the normal things, and then you know about the normal parameters, how exact normal parameters of that anatomy. and what important factor that maintain that dynamics and the normal parameters. So these three things, the anatomy, aesthetic analysis, and the dynamics are the interrelated. So if we discuss the anatomy, already we seen in the cadaver dissections and in the live cases also. Basically, the LR cartilage, the tip anatomy is a pair of the LR cartilage that have the three part, that most lateral part, that the lateral crust, and the most medial part, the medial crust, and the part that connect, that is the intermediate crust. But that is not only anatomy. You learn the each and every part of this LR cartilage, and what is the function of that in the tip, that part, and what type of the deformity that part the patient has, and how you appear on the skin. So you have to develop the habit that how you identify the problems or deformity underlying the skin. Tip dynamics basically that we understood by the Anderson principle, Anderson tripod principle. So according to the Anderson, he imaged that the tip have the three tripod. So the central pod of the tripod, that is by the membranous septum, caudal part of the septum, and the medial crust, and the rest of the two by the lateral crust part of the LR cartilage. But why we know the tip tripod concept? Because when you affect the one pod of the tripod, then you know the another automatically affect. So in my beginners, like when you start in your career by a basic technique, and when you jump from the basic to the other techniques, then definitely behind that you know about that the dynamics. Like if you use the columella assert and suddenly you change the graft, like you use the septal extension graft. So when you use from the tip to the septal extension graft and you change your practice at that time, definitely there is tip dynamics is also changed when you change the graft. So you have to know in your mind that things until unless you change your technique or the procedure. And another important thing, the tip support system, because the tip have basically two. One is the major support and one is the minor. In the major support, the size, shape, and the resilience of the entire LR cartilage, and the second is the connective tissue overlapping between the lower part of the upper lateral cartilage and the upper part of the lower lateral cartilage, that we call the scroll area. And the third, the medial crust attachment with the caudal septum. So these are the major tip support mechanism, and another the minor tip support mechanism also that we mentioned. But when you do the surgery, then all these things you keep in your mind, and whenever you do the surgery, then when you correct the abnormal thing, and then never disturb the normal anatomy. You try to maintain the normal anatomy. This is the basic principle of the rhinoplasty. So if we discuss about the tip deformity, then tip have the different type of the deformity. But if you go behind that all deformity have regarding these six tip characteristics. Either what the tip characteristics, the volume of the tip, volume of the tip, that means the size of the lateral crust. Either the patient have the big volumetric tip, so the size of the lateral crust is bigger, and the width of the tip. Width of the tip, the patient maybe have the more than normal the tip width, the distance between the tip defining point. And the definition of the tip, the convexity of the dome. We refer to the definition, that means the convexity of the dome, either or angulation of the dome. And the projection of the tip, the patient, the projection, that means basically projection is a distance by which the notch project from your face. So maybe patient have the projection deformity on the rotation. So what is that rotation? Rotation is the inclination of your tip from upward or the downwards from the facial plane. So we measure that rotation in the nasolabial angle, and the position and the shape of the tip. Either in the different type of the shape, the tip have either the broad tip, that means broad, that means the tip have the more than usual width, the 6 to 8 millimeter distance between the tip defining point between the female patient and 8 to 10 in the male. So if more than that millimeter, then the patient have a broad tip. And sometimes the patient have a bulbous tip or the boxy tip. That means the angle of the dome divergence is more than 30 degree, then that is a boxy tip. And bulbous tip, that is when a patient have a more than 0.6 index between the ratio of the tip defining point and the ala base width. So you have to know, you judge about the deformity of the patient, but when you know the normal things, then you judge about the abnormal things. Now, by this 5-step tip modification technique, for my beginners, then it's my advice, then 95% primary deformity you can correct by these 5-tip modification technique, like the columella strut, like the dome creation suture, interdomal suture, and the cephalic trimming, and the different type of the tip positioning suture. In a simple case, when you start your rhinoplasty career, then you can do the 95%, and you leave it the rest of the 5% cases in your beginning time, because once you do the case and if your case is good, then you create a confidence. And once if your case is not good, then the patient create nuisance and it's very difficult. So leave it the rest of the 5% cases, because in that case you need different types like the septal extension graft, ala crura graft, and the tongue in groove techniques, lateral crura flyover. So there are so many things. So you just focus your career on the 95% primary cases, not on the secondary cases. Sorry. I just little bit change. So first, that is the columella strut. So when you use like any technique, like when you use the columella strut, then first you learn then why we use the columella strut. What is the purpose of the use of the columella strut? So when you use the columella strut, then the goal of the columella strut for the tip stability, for the tip projections, and for the columella shape. So it creates a unified tip to improve the tip asymmetry. And ideally, the size of the columella strut is the 20 millimeter long and the 2 millimeter width and 1.5 mm the thickness, and all the criteria match with the warmer part of the septal cartilage. That is the best source of the columella strut. And the technique by which we put the columella strut, we can, for simplifying for the learning, we can divide in the three. The first part, the ideal shaping, and the second part, the insertion. You first create a pocket on the antenasal spine area, and then you fixation. So first, by the septal cartilage, you make ideal the shaping. In the beginning, once you measure it, but once you do more and more cases, there's no need to exact the measuring of some things. By idea, you can judge. So look that you hold by the two artery cartilage holding forceps, and you make a groove for the columella strut. This is the second part. And in the beginning, you can mark the mid of your columella strut, and you insert till your marking in your groove. You ask your assistant, then so you give the counter traction on the both sides, and you put it, and you left little bit tissues on the antenasal spines just to prevent the clicking of the columella strut. And the lower margin of this columella strut, that not oblique, that should be straight, otherwise it's very difficult to stabilize it. So once you insert it, then the third part, how you fix it. So for the fixation, you use the needle. And when you put the needle, the important thing, your needle, that knot should be oblique, that should be straight. Because unedited video, so I just a little bit. So look that the needle initial is this oblique manner. So when your needle is oblique, then that is the not a right way to fix your columella strut. So the entry and exit of your needle, that should be same. Once you do the more and more cases, that these all things are not big for you, but in the initial, in the rhinoplasty, the each and everything is important. I'm not edit this video because in edited video, we skip the things, especially for my beginner friends, where we do the mistake. So the entry of your needle and the exit of your needle, that is the same. So this is the right way to fix your by your needle. And the same manner when you pass a needle from one side to the other, and you use the 50 PDS. I always use the 50 PDS suture for the fixation of the strut. But sometimes if your strut by a rib cartilage, then you can use the 40 PDS. So you should at least you have the 3 fixation point. And the other important thing, the knot after the fixation. So the knot ideally that should be subcutaneous. Some person fix from the one side, from the skin to skin. But when you fix from the skin to skin, then the knot by the patient that feel the letter that create the nuisance. So it's a better you fix it in the subcutaneous manner. So the knot is hid by the transcolumella flap. You do it 2 or 3 times or the 4 times, but not in the wrong way you fix. Because time is not concerns. Otherwise, your patient develop the etiogenic deformity. So by the columella strut, basically all the primary cases, when you start the career in your rhinoplasty, then 95% cases, almost all cases you can correct until unless the patient have a secondary case or some asymmetry. So you fix 2 or 3 sutures. So the concern of the time, we skip it next in the next slide. Then the DOM sutures. Usually we use the 2 DOM sutures. One is the intradermal suture and other is the interdermal suture. So the intradermal suture basically is a horizontal mattress sutures, and just to create the convex DOM segment, and we place the suture from the medial to lateral with the knot tied medially. This is the usual manner. And the intradermal suture is a simple vertical suture, just we control the tip width. So the entry and the exit, when you place a interdermal suture, that is also same. And the things that you keep in your mind, then if you too tight a knot, then produce the pointy tip, and if you the too loose of the knot, then produce the wide tip. So by a cartilage holding forceps, you hold your the dome, and like from the medial to lateral, and then again from the lateral to the medial. So this is the intradermal suture, or the other name, that is the dome creating suture. So never confuse my beginner friends. Intradermal suture, we increase the convexity of the, we increase the angulation of the dome just to create the more definition. So you appreciate the difference after the dome creation suture in the left or right side. So this is the dome creating suture. Now the interdermal suture. In interdermal suture, you pass I use the 50 PDS suture, and from one side then you can pass from this septum also, and then another side. Interdermal suture that always connect the two dome, and intradermal is the same, just like intercity express that connect the two dome. So never confuse between the intradermal and interdermal suture. By interdermal suture, we decrease the width of the tip. And when you make a knot, then not too tight or the too loose. Once you do more and more cases, then you develop things in your hand, then what exact when you tie your knot. So you can appreciate the difference after the suture. Now, the cephalic trimming, basically when the purpose of the cephalic trim, then just to reduce the size of lateral crust and increase the malleability of the cartilage for the suturing. And technique, the most important thing, how much part you remove, that is not important. The important how much you preserve. So in Indian scenario, at least 6 to 8 mm, I think 8 to 10 mm, that is good. In the Western scenario, the Western book, Roland Daniel book, they mention the 6 mm, but the scenario in the Western is different because they have a thin skin patient. So in thick skin patients, I think you should at least 8 to 10 millimeters you should. And if there is a significant concavity found in the LR cartilage, then Curra 4 rather than excision. Like the yesterday, Dr. Lokesh also told that rather than you excise, you flip it under surface on the rest of the lateral crust. So we get the more strength of your lateral crust. So initially in the beginning, you measure for preserving at least 8 to 10 mm. And you mark and you preserve the dome notch area always. Marking is really very good a bit, but when you do more and more cases, then I think it's no need each and every case. But if you you develop the initial your practice, the marking, then is your incision that should be precise. So you develop the marking habit really. When you start your career, then you start by the basic steps. You never skip the basic steps. So look that this piece, excise piece is also a good source of the tip defining graft. So you keep it after the excision. So we reduce the size of the lateral crust by this cephalic trimming. In the Western patients, they frequently do this cephalic trimming for reduce the size of the lateral crust. And the last step, that is the tip refining grafts. Basically, these 4 steps, that is the basic step, but the tip refining graft just used to enhancement of the tip definitions. And different type of the tip refining grafts like that, tip refining grafts like the shield graft, diamond graft, cap graft. So one graft that this shield graft we usually use for the in thick skin patient for enhancement of the tip definitions. So this is the way by which you prepare. Just like a sap of a shield. In beginning, it's little bit tricky to put it. So look at how we fix it. The important thing that we suture it with the shoulder part of this tip refining graft with the dome area. And the minimum width in the dome area at the shoulder, that is around the 6 millimeter, and little bit in few millimeters above the dome for getting the definition. Not too much, otherwise the later the patient develop that deformity. So you use the 3 needle for the fixation, 2 needle on the shoulder area and 1 on the base, and you suture it with the medial crus and the middle crus. When a patient have a thick skin, then in that case for enhancement of your first you put the suture on the shoulder area, 2 sutures, and then in the base. So finally, the take-home message, then pre-operative evaluation of the nasal tip is critical in the choosing the correct tip procedure, and during the operating on the nasal tip surgery, best to follow a graduated approach with the constant reassessment before each maneuver, not jump from the one procedure to another procedure. Thank you.
Thank you so much, sir. Now, Dr. Sandeep sir will connect us by online platform on the topic of management strategies in revision rhinoplasty. Thank you so much.
Hello.
Dr. Sandeep sir, are you hearing me?
Yes, I'm hearing you. Just give me 1 second.
Thank you so much, sir. Welcome, sir. Over to you.
Thank you. Just give me 1 second. So good morning from London, and good afternoon to you there. I've been listening into some of the talks this morning, slightly sleepily because it's a Sunday morning, but I've been enjoying it very much. And my apologies again that I could not come to India. I would have loved to have been there with you, but obviously with all the visa problems that we have at the moment, hopefully I can join you there later in the year or next year for sure. Many thanks, Sunil, for the invitation as always, and to RSE and Dr. Lokesh and everyone else involved in RSE for the invite. I thought I'd talk to you today on revision rhinoplasty and some of the issues that I found, and hopefully share some experiences with some of my cases. So let me share my screen, hopefully, with you. Can you see that?
Yes, yes.
You're seeing that? Okay, you're seeing my screen. Fantastic, thank you. So, Lokesh, thank you again for being there and for moderating this. I hope this will be helpful.
Yeah.
So, for those of you who are thinking about doing revision rhinoplasty, I appreciate this course has largely been about primary, but obviously there are some more complicated techniques, and Enrico earlier, who I did manage to listen to, gave a wonderful talk on some of the issues behind revision rhinoplasty, and this is really into the more complex arena. But how do these patients differ from my point of view? Well, certainly the evaluation, including the detail of the prior operative that they've had, is important. We'll talk about whether you should try and get hold of the op notes of the previous surgeon if you can. But I think it's the other bits really, which is the key here, because these patients have often been through pretty traumatic experiences, having had poor or difficult surgery previously. And they often come to you with a heightened emotional state, heightened expectations, because a lot of patients don't really spend enough time looking for their primary surgeon. They just go to whoever they are either referred to, or they do very little due diligence. But when they come to doing the revision, they spend a lot of time trying to find you, and hence by the time they found you, you are the expert, and they have a heightened expectation. So you have to adapt accordingly, and certainly your surgical principles have to adapt. And there's a lot of hand-holding going on here. So if you're not very good at these things, I would suggest you steer away from these patients, because it can be very problematic. And you need to learn a whole host of adjunctive procedures as well. We looked at our cases. These are my personal cases that I did between really during that lockdown period, bearing in mind that we had no operating during the first lockdown, like most people. So I was pretty much not doing much at all, except learning to cook for about 5 months, from about March to about August of 2020. And so I looked at 144 cases and looked at what things had gone wrong. And I think the main complaints from the patients, at least, was poor communication with the first surgeon, the lack of written information, and the lack of clarity of the expected result. Because often patients have in their own mind eye what they expect, and you have in your own mind what you expect. And we'll talk about how you can square that circle. Objectively, I found that the majority of patients, really, it was a lot about poor tip projection and support. There was a lot of patients having over resection, less with under resection, poor definition, more problems with deviation, some are functional issues, and we'll talk about some of those as well, and skin and soft tissue issues. And that's quite important, because skin and soft tissue issues are often not correctable. So you have to be careful and cognizant of that skin and soft tissue. Now, less problematic, certainly in India, where you have a thicker skin type, but much more problematic in the thin skin type, where if you damage that skin and soft tissue envelope, it's very difficult to correct these things. We all go through this learning process of how to treat patients, and this is even more acute when you're doing revision surgery. I thought I'd divide this into tips. So first tip is really important to pick the patient who not to treat. I mean, we all proverbially or metaphorically reach out for this pot of gold when we're operating on patients, because there's a financial remuneration, certainly if you're in private practice with this. But you've got to be careful, because there's a piano waiting to hit you at any point in time. And these patients can be very problematic. And certainly when you're a young surgeon looking to, and this isn't just for revision, even for primary rhinoplasty, be careful who you're picking. And body dysmorphia is a huge problem, but it becomes acutely more problematic when you're doing revision cases. And be careful, because there is a very fine line that we all tread upon. This is actually a patient, an Indian patient, who wrote to me about his nose. And he wrote, this was one of 4 pages of an email he sent with a flow diagram about his various aspects of his nose. And he did this, and he sent about 40 pictures of himself, normally with a background of some famous Bollywood star behind him, or various Bollywood star behind him, and how his nose did not look like that Bollywood star's nose. Now, this patient is obviously very easy. You're not going to go anywhere near this patient. I hope none of you would do that. But it can be very difficult, and you can get, and this was another Indian patient just by chance, who was a university student in London, very articulate, had done a lot of background reading, and had sought multiple opinions, but then he'd found the expert. And you've got to be careful with these sort of patients, because he said to me that he'd read 4 of my book chapters, and he particularly related with thoughts on complex tip surgery. And then this was some time ago, and then he'd written about how he was looking forward to my new chapter in the Scott Brown book being published. And the Scott Brown book hadn't even been published at that point. So how he managed to get hold of these things is very difficult. So be careful of these patients. And if needs be, reconsider doing it, refuse them. And certainly if you're in a position to be able to do so, refer them on to somebody else, and probably your worst enemy, because you don't really want your friends to get these patients. We have a changing practice, the unfortunate selfie, which has completely changed how we look at things. This patient actually wrote to me in the middle of lockdown. She was a Scandinavian patient, wanted to fly over from, I can't remember which country it was. I think it was Sweden, maybe it was Finland. Desperate to have a rhinoplasty revision. And I'm looking at her nose, and she sent me, again, 12 photographs of herself taken with a selfie camera in various angles. And when I asked her, I said, well, because I mean, even if you look at that front profile, and I didn't show the rest of it, it looks pretty reasonable. And I asked her, so what's wrong with your nose? And she said, well, actually, there's not much. She said, I don't see it, but I put my nose on Instagram and I've had so many comments saying it still looks too wide. And so she's not worried about it, but she's worried about what everyone else thinks about it. And social media has completely revolutionized how people talk about surgery. And is it cool? Well, it can be cool if you use it in the right way. And, a lot of people are using various forms, TikTok, Instagram, you name it, to promote themselves, but it can certainly be a curse. And when when patients are not happy, they can be very, very destructive as well. So be careful if you use social media to enhance your practice, because it can come back and bite you. Be empathetic with these patients. These are difficult patients. They sometimes often don't want to hear the solution, and be reassuring and often the multiple visits, and certainly manage their expectations. And this is important. And again, going back to just reflecting on all the cases I've done over the last 2 years or so, the majority of them just did not feel that they were talked to enough by the patient. So we spend a lot of time, I see them at least twice, normally 3 times ahead of the surgery, and make sure they get plenty of written information to back that up. I also use digital imaging. I find this useful. This is a 2D program that I used to use, which was very helpful, but I've really moved now onto 3-dimensional imaging. And there's various, this is a program by, it's called Vectra by Canfield, and gives you a 3D image, and you can play with those images. And I find that extremely helpful in communication with the patient. Don't use it as a marketing tool, but do use it to help communicate. And it's quite useful as you can look through these cases and with the patients and just show them what they can look like in 3 dimensions. And I think that's very useful. It also helps you if you want to look at ratios, etc. And again, as a young surgeon, this can be helpful, looking at all the angles. It helps formulate all those angles and measure everything. For example, the alar base width, is it wide compared to the medial crury, etc., and can be very useful as well. So that's another thing which I tend to use. Now, let's move on to the crux of the talks then. So expect the unexpected. Now, when you open that can, when you do, and I do all my revisions, pretty much all of them under as an open approach, only because I really want to see what's going on there, because it's very difficult, and you often make very, very specific plans on how you're going to treat each nose. But then when you actually come to it, you find something completely different. And so having the ability to see all those structures can be very helpful. Now, I talked about, do I try and get hold of old notes or not? I think there's pros and cons to this. I think it's useful if I can get hold. I like as much information as I can. So I always ask patients to try and source their old notes, their old operative notes from their previous surgeon. In the UK, that's pretty easy, as long as it's done within the first 8 years or so, because we're obliged to keep notes. More difficult when patients have had surgery abroad, because often they aren't able to or refuse the old notes for whatever reason. Why I think it's very useful is really when it comes to predicting septal cartilage availability. Now, it is difficult because septal cartilage, there's no real good way of knowing how much septal cartilage is going to be left behind. And you often just have to make alternative cartilage sources available. So if the old notes do not mention anything about septal cartilage, then I tend to not necessarily consent them for needing rib or ear cartilage. And I have to say, majority of times I don't now use ear, I tend to use rib. And hence you have to be aware of that. Sadly, where the cons of having old notes is sometimes you rely on them and they don't really always reflect reality. And I have a patient who I operated on very recently who had a set of notes sent to him from his surgeon in Turkey. And when I opened them up, it was completely nothing like that had been written. I mean, there was cartilage taken away from his septum. There's all sorts of various things that done. Now, fortunately for him, I had pretty much consented him for rib, which we ended up having to take, even though I hadn't expected to because of what the surgeon had written. And so now I'm pretty much always consenting patients for rib, but it does make it a little bit more tricky when you're planning surgeries, of course, because from a time perspective, this will always take longer. We also use donated rib cartilage. I'm not going to talk about this. Those of you who might be coming to Bergamo, I'm going to present some of my findings there with use of donated rib cartilage. We use frozen donated rib cartilage that's sourced, I think it actually comes from the USA. It's an excellent product, and I use it interchangeably now compared to the patient's own rib. We give patients a choice. In summary, looking at all of our cases over the last 6 years, I've been using it. We found no problems with it whatsoever. I've only had one patient where there's been perhaps a little absorption, which we had to go back and revise. But apart from that, it's done very, very well, and I use it now interchangeably. I tend to use the rib in a split manner to avoid warping, although what we found with these frozen rib cartilages is the warping is far, far problematic, and really I've not seen any issues with warping whatsoever. The only issue perhaps has been, let's say, absorption in one particular case, but cutting an oblique rib, as you see here, can be very useful. And you can cut this in various thin slices, depending on what you need to use the cartilage for. So this is one of the patients where we didn't have the old notes, and this is where you've got to expect the unexpected. Here she has a typical inverted V, really what looked to me as if she had a over resection of the dorsum with a polybeak. But actually when I went in there, that's not what we found at all. What we found was she'd had a push down or a high strip type surgery. Now, this to me was my first complications that I've seen with preservation rhinoplasty. I do some preservation. I'm mainly a structural rhinoplasty surgeon. And this is the first time I'd seen this high strip, and I was completely thrown by it. And you had to think on your feet with this because she'd completely lost a lot of this cartilage here. And so you have to be able to adapt your principles based on what you find. And with her, we had to reconstruct the whole missing cartilage, adding rib graft spreaders, and managed to get her much better. Again, I used ice cartilage for her, wrapped in some fascia, and we've got her to a much better position overall. With the nose, getting rid of this very unsightly appearance to the dorsum. But that took some doing, and a lot of this pinching and everything here was really because of lack of cartilage left behind from the first operation. Again, you're very lucky in India. You will see very few thin skin noses. These can be very problematic from our point of view. This lady had a previous surgery, irregularity here, as you can see through this. And you can see the wafer thin nature of the skin, which really accentuates all this thing. This was actually a free floating piece of cartilage. I have no idea why the surgeon had left it in there. Again, old notes, we had it, and there was no mention made of this at all. So I was really not sure what had caused this, but we found literally a free floating piece of cartilage underneath there. Notching of the nasal tip accentuated by the thin skin. We had to reconstruct all of that, remove the graft and reconstruct the nasal tip area. But what we did with her was added a layer of tissue. Now, I think it was, I did tune in earlier, and I think it was Dr. Kapil who mentioned about using temporalis fascia, and that's a very useful thing. I sometimes find temporalis fascia a little too thin. with some of these patients, and hence I often use this thing called Permacol. Permacol is porcine cross-linked product, which is a slightly thicker product. And again, with this patient, really thin skin, awful looking tip of the nose. But the biggest problem with her was this sort of micron layer of skin, particularly the columella area, which I had to lift. And I was very, very worried about that. She had buckled and a lack of cartilage that had to be reconstructed with lateral crural strut grafts and a septal extension graft. And this is Permacol. Permacol is this sort of porcine cartilage, as I say, porcine small intestine, and it's cross-linked and it's used, and it can be very useful. And we just slide it along using sutures to support it and put it underneath the skin, and it acts as a lovely layer. Now it's slightly thicker, or there are varying thicknesses of it available, but I use the slightly thicker version, particularly in the very thin skin patients. And I think that's better than using temporalis fascia, which I sometimes find just a little too thin. Here she is now at about 4 or 5 months post-op, and she's doing much improved, and she's got a much improved nasal tip area that's been reconstructed, but also has had that Permacol to help with the, my apologies, she's actually at 8 months here. I just saw her fairly recently. This was my concern, this columella skin with her, which became very congested immediately post-op, and I was very, very worried. This is after the plaster was removed. In fact, at the time of surgery, it looked even darker, and I was extremely worried that this was just going to necrose because it was so thin. I didn't put Permacol here because I was worried about the vascularity here, so I left this just to heal. Unfortunately, with time, it's healed very well. Narrowing, yes, but much better than before. Of course, in India, you have the opposite. You have thick skin. Importantly, with thick skin, be counterintuitive with this. You want to add cartilage rather than taking cartilage away. The thought of this is if you take lots of cartilage away, you're going to end up with a much better definition of the skin. I mean, the reality is that's just not the case. If you reduce volume in the very thick patient, you end up with a floppy bag of skin, a bit like this patient here. Real lack of support. I apologize, I wish I'd done a video, but if you pressed on this, it just went completely flat. Previous surgeon had removed all the cartilage pretty much underneath here. Now, the hope would be that you get a smaller, thinner looking nose, but the reality is you don't. All you end up with is the skin, and you don't get definition because you ultimately, there's nothing holding this skin, and you end up with this just floppy bag without actually giving any improvement to the patient at all. You want to really create a strong profile with them. There's been much talk about using columella struts. I've really abandoned using columella struts, particularly in my thick skin patients. I think you need to get much better long-term projection. And I tend to use tongue and groove with septal extension grafts, and septal extension grafts to me just give that extra rigidity. And it does mean they get a little bit more of a rigid tip, but it's a small price to pay for long-term stability in that tip region. You may need to tension the lateral crura with these patients as well. Often that creates too much projection, but then you can de-project them back down again in other ways. And I think Sunil mentioned about using various tip grafts, and that can be helpful. I would only ever use tip grafts. I rarely use tip grafts other than just a little cap graft. But if you're going to use shield grafts and the like, only use them in thick skin patients. The risk being that as skin shrinks, you might begin to see those. A patient, a fairly recent patient who had surgery previously and really complete lack of support of that tip. And with her in particular, this had caused quite a significant drooping over the years, really because that thick skin envelope, she's Mediterranean, I think she was Greek, and that Mediterranean skin needs support. So here she is post-operatively having a septal extension graft and improving that profile by projecting and rotating the tip, but importantly, keeping it projected and rotated, not with a columella strut alone, but using a septal extension graft to hold it into that position, which is critically important. Septal extension grafts can be anchored in various ways. I often use a side-to-side septal extension graft. The advantage of that is it really does give stability as opposed to an end-to-end where you're always worried about it moving slightly. But I tend to prefer this the side to side. One of the issues with that is it can make the tip rotate a little, and you've got to be sure that that's not going to be the case. And often using a extended spreader graft in addition to this can pull that across into the midline if it is deviating one way or the other. The other risk of using a side septal extension graft is it can cause nasal obstruction, although generally if you place it without too much bulk, that tends not to be the case, but this is how I tend to use septal extension grafts. This is a shoelace type reconstruction for an end-to-end. You can use, literally, you can crisscross the suture across and use that. I tend to use a permanent suture here because I'm worried about if you use PDS and that PDS loses tension, then that septal extension graft can then move as an end-to-end. And often what I will do now, I tend to use, I often used to use that alone, but now what I tend to do, I do get worried about this moving. And so I put 2 bits of cartilage, or ideally perpendicular to the ethmoid, across this area here to hold these septal extension grafts in the correct position. Using a septal extension graft, this is an on-the-table photograph, can really give you excellent projection and rotation and hold that in the long term. And for somebody with this sort of, again, thick skin type Asian patient, Indian patient, you need this, and this is her 1-year result. So even though she was a lot more rotated to begin with time, that thick skin envelope is always going to pull down, and you need that stability of that septal extension graft to keep it in that position into long term. Another little tip for thick skin patients, there's lots of ways of defatting or removing the soft tissue in this region. I've seen patients with necrosis sent to me, unfortunately, where patients have had this bit of fat removed using scissors. I would warn you against that. I just use these sort of Brown Adson multi-tooth type forceps and just pull that tissue away until you see the just underneath the subdermis. You don't want to go into the subdermal region because of the risk of damage to the subdermal plexus where necrosis can occur. You can actually, some people use a knife and then just find a plane, but I think this works very well. You just pull out as much fat as is easily removed. You don't want to pull it hard. You literally just take out what comes away very easily, and you're left with a lovely plane, and that can work very, very well. So just using these tissue forceps in this way can be very helpful. When you've got these thick skin patients, be careful, and this is often what causes polybeak problems. Surgeons do not appreciate the thicker the skin, the more space you need to leave between the tip and the supratip area. So in a thin skin patient, I may only leave about 3 millimeters or so between the tip and supratip in a patient who wants a supratip break. Obviously, in a male, that's different, but in a female. But in a thick skin patient, we often will leave anything up to 1 centimeter, sometimes even more, between the tip and supratip area, because there's always going to be that soft tissue infill and that thickness of skin, which will essentially hide that supratip area. And so you need to make sure that you create as much supratip distance as you can, defatting the supratip. And if you are able to, there's a lot being talked about with use of the Potengi ligament. I'm not obsessional about it, but wherever I can keep it and reconstruct it, I think that helps as well. And this is always the issue, that you want to not end up with soft tissue polybeak formation rather than true polybeak formation. So again, this is a lady, thicker skin type, and I'd left about 8 millimeters with her between the tip and supratip, which is a huge amount, and yet you see her post-operatively, and she's still not ended up quite with that supratip break that we might have wanted. Now, she was happy with this. She really did not want me. She's happy. I'm thinking I could have just done a little bit more here to give that supratip break, a little bit more femininity. But that's despite leaving 8 millimeters with her, and you have to be cognizant of this. I tend to use a lot of steroid injections post-operatively. I use it pretty liberally. We've used 5-FU. We tape the nose massage. And we often, with the very thick patients, also often discuss about using Roaccutane and various skin treatments as well. When you're injecting these patients, make sure you're injecting into the subdermis, not into the dermis. If you see any blanching of the dermis, stop and go down further. And with some injection, you can get some quite nice definition of these patients, really quite significant improvements overall in terms of narrowing of that supratip region, as you can see with the thicker skin patients here. And with this patient, slightly more unusual deformity. He had a scar taken out from the tip previously due to a chicken pox, and he ended up with this sort of almost concavity of skin there, and we've reconstructed that. A few minutes just on the deviated nose. Using intermediate osteotomies can be helpful in that deviated nose. Again, the deviated nose is one of our other major causes for needing to do revision surgery. And so when you've got a patient who's got a really quite significant deviated nose, you can use an intermediate osteotomy. So we use medial and lateral osteotomies, but an intermediate osteotomy can essentially help these two nasal bones become of equal length. So if this is A and this is B, then A to B does not equal B to C in this as you can see with this deviation. So to create equal bones, you have to create an intermediate osteotomy in between, understanding that when you do the intermediate osteotomy, you have to do that first before you do your lateral osteotomy. Otherwise, you end up with a flailed piece of bone, which is very difficult then to create an intermediate osteotomy, unless you use something like piezo. But if you're using standard osteotomes, it can be very difficult. Your sequence of osteotomies is quite important too. If you've got a deviation of the nose towards one side, you've got to push the contralateral side first out, push the midline, including the nasal septal region across, and then push the other bones across as well. And so the sequence is quite important. But the sequence of doing your lateral and intermediate osteotomy is even more important. As I say, always do your intermediate before you do your lateral. Sometimes you've done all of that and you've done various other things and spreaders, and the nose still looks deviated, and you're thinking, how am I going to get this better? So there is this thing that we call a clocking suture. Essentially, a clocking suture is where you're, if you're looking, and this is a cadaveric, this is actually a cadaver from, I think, one we did in Jaipur a few years ago. But your clocking suture is essentially when you're putting a suture in with your spreader grafts. So normally you would put a mattress suture, horizontal mattress suture, right across where your spreader grafts are, but you put it in a slightly oblique way, and this will get your nose straighter. So this is quite a nice demonstration of that. So we're going through the upper lateral cartilage on one side. Here's your spreader graft and the septum. You can see it bending over towards the right-hand side as we look at. So instead of going horizontally across, we've done a step. We've gone horizontally here, but then stepped it across to this area here, go back across there again, and coming back the other way. And what you'll begin to see here now is the movement of that cartilage as it comes across. And so this is quite a nice demonstration of the clocking suture. So as you tie the suture, if you watch shortly, that moves across. So that's a clocking suture, and again, you can use that very usefully. So it's something like this with a slight deviation, that clocking suture just pulls that cartilage across, or in somebody with even more significant, it can be one of the things you can do to improve things as well. I think from time point of view, I can't see the clock here. I probably am going towards the time when we could, so I'll stop fairly shortly. Just a couple more tips. Really just be prepared to vary your usual practice. I mean, those of you who are closed surgeons, sometimes the closed approach just doesn't work and you need to open, because otherwise it just isn't going to be able to do that. And so if you look at patients with this sort of problem, I really defy most closed surgeons to be able to deal with these sort of problems without opening the nose out and getting full access, getting improvements. As you can see here, really complex deformities that you need to open your nose with. And we use a variety of different grafts for that. I'm sure DCI grafts have been talked about, so I'm not going to labor the point. I tend to cut this very fine and then use a mold, and I often use tissue glue as well, and that helps very well. The very final thing I'm going to mention is that if you're going to take these patients on, make sure that you develop thicker skin than your patients. Now, what do I mean by that? And I get a lot of thick skin patients. I mean, these revision patients become your own. So if you see a patient who's had pretty poor surgery and you operate on them and they become better, but you can't really necessarily make them completely fantastic, that patient's going to go out into the community. And when somebody looks at their nose and asks them, who did your operation? She's going to forget, or he or she is going to forget it was the first patient. They'll talk about your name, and people look at it and say, well, that's not a great result. And so even if you make them, you know, in like this case, better, she's still not looking perfect, but she's a difficult problem. We've obviously improved it. You do have to accept the fact that these patients are now your own, and they often forget about the first surgeon completely. So I hope that was a helpful whistle-stop tour through revision surgery. I thank you for your attention, and I hope, as I say, to be able to meet with you all fairly soon. And Sunil, Lokesh, everyone out there, it's been a pleasure being with you, but not being with you as it's such.
Yeah, thanks, Sandeep. Very nice lecture. And we are running over time, and let's see if we have some questions for Sandeep. I think this was a very nice lecture, Sandeep, for difficult problem in rhinoplasty, which is revision rhinoplasty. So I think people who are very well experienced in this subject should venture upon doing these revisions. So any questions for Sandeep? If not, Sandeep, thanks. I think we will meet sometime. We have been
hopefully soon.
Yeah. Thank you very much. Thanks for.
Hi, Sandeep.
Thank you, sir. Thank you. Thank you for giving.
Hassan, how are you?
Hi. Nice to see you.
Absolutely. Hope to meet you in Bergamo, Hassan.
Yeah, we'll be there. We'll be there.
Perfect.
Hopefully. If the war didn't extend to Italy.
Yes, I know. It is a bit worrying, isn't it? The world is a different place. Between COVID and Putin, I think the world is a different place to what we know 2 years ago.
I'm sure none of our Russian friends will come.
No,
there are no flights. No flights.
There are no fly zones.
Yeah.
Aeroflot, I read this morning, have cancelled every single flight.
It was suspended, yeah.
Yeah, every flight other than to Belarus. That's the only place they're flying, which is unbelievable.
Right.
Let's hope for the best.
Our next speaker is Dr. Hossam Foda. You want to talk about him, or can I introduce him?
Thank you so much, sir. Before this, I'll request to
Share
Dr. Sunil Samdani, sir, please come on the stage for the felicitation. And I'll request to Dr. Anita, ma'am, please come on the stage. Anita, ma'am. And thank you so much, Dr. S. Gambhir, sir.
Can you all see my screen?
Yes, Dr. Foda. Yes, they are doing some felicitations. For
Hi, Lokesh.
Yes, Dr. Foda.
Nice to hear from you.
Yes, after long.
Thank you so much.
Yeah.
So
tell me when to start.
I'm introducing here Dr. Hossam Foda, sir. He is the head of the Facial Plastic Surgery Department of Otolaryngology, Alexandria Medical School, Alexandria, Egypt. He is a board member of Rhinoplasty Society of Europe. He is a member of Egyptian Society of Otolaryngology, and he is a member of American Academy of Facial Plastic and Reconstructive Surgery. Dr. Hossam Foda, sir, receives a large number of invitations every year to serve the scientific faculty of the most rhinoplasty meeting and training courses worldwide. Now, I'll request to all clapping, please, for Dr. Hossam Foda, sir, and over to Dr. Lokesh, sir, and I'll request to Dr. Pradeep Goyal, sir. Dr. Pradeep Goyal, sir. Dr. Pradeep Goyal, sir, please grace the rise as a moderator, and Dr. Kapil Soni, sir.
So over to you. Thanks, Dr. Foda, to be with us. Unfortunately, we are missing you physically, but nevertheless, whatever we can make in these difficult times.
We will hopefully meet soon.
But hope this COVID is going to be over this year, and we will physically meet sometime. And I'm thankful to you to spare time for this meeting. Really, people are very kind to spare time for our meetings, and we are really enjoying lectures. So over to you for your talk on ear cartilage in rhinoplasty, Dr. Hosam Foda, sir.
But miss your operative skills.
Thank you, sir.
We missed, yes.
Thank you, Lokesh, and thanks, Sunil, for the invitation. And as you know, I come from Egypt, and ancient Egyptians were obsessed by structure. Everywhere you go, you find pyramids, you find temples, and all what they used to build that civilization was mud brick and stone and granite. These were the three options they had. Well, in the nose, to build the noses, we have another three options, which are septal cartilage, ear cartilage, or rib cartilage. These are the main things we can build the noses with. So septal cartilage is easily available in the surgical field, and you can take as much as you want, provided that you will leave a caudal and dorsal 1 centimeter. Everything else can go, whether bone or cartilage. The piece I look for is the piece sitting on the crest. This is the most ventral part of the septal cartilage, sitting on the crest, because this piece is the thickest piece in the nasal septum. When you go to the center of the septum, the cartilage gets more thin and flimsy. When you go to ear cartilage is again in the field because you don't need to scrub another region, and you can approach the ear anteriorly through a curvilinear incision along the antihelical fold. And then you raise the skin, you cut the cartilage, and you raise the posterior surface of the cartilage. And then you will get this piece through the anterior approach. And as you see, I leave the perichondrium intact on the posterior surface of my conchal cartilage. If I'm going through a posterior approach, I will take an incision 0.5 centimeter above the post-auricular sulcus, and on the back of the cartilage, I will dissect, and then I will cut the cartilage just posterior to the antihelical fold. You always preserve the antihelix, otherwise the ear will get deformed. And you can see my middle finger is in the depth of the concha while I'm cutting. So if I'm cutting the anterior skin, I might as well cut my finger with it. So this gives you the sensation of the number 15 blade without marking or anything. And here is the piece of cartilage you can get, again with the posterior surface with the perichondrium, and these are both ears. Actually, I finished 5 minutes ago doing a second time revision, and I had to take both ears again because she had a very short nose. Now, the third option, if the patient didn't have ears or they were harvested in another surgery, I will go to the rib. So it's always my third option. And of course, you have an unlimited supply of cartilage when it goes to the rib. And the only thing that you will leave a scar on the chest and the possibility of warping. Warping is a phenomena of changing the configuration of the rib, and it only happens with rib cartilage. It doesn't happen with ear or septal cartilage. And of course, the scar sometimes look ugly, but in other patients, they get the rib out of 1 and 2 centimeter length scars. So the scar is never a problem. The areas that you need to structure in the nose in revisions are either the nasal dorsum or the tip or the alar lobule. So if you have a saddle, you can use solid cartilage, but there is always the tendency of mobility of the solid cartilage. So you have to fix it in place by sutures, or diced cartilage, whether wrapped in fascia or free diced cartilage, or using implants and fillers. And I'm mentioning the third option to tell you that this is the most dangerous option. So try to avoid it as much as you can, because it has disastrous complications. I don't know why it's the video disturbed, but this patient had a solid implant, and when I opened up, it was a big met pore, a huge met pore implant. You can see the tissue growth in the met pore. This is another patient with a solid implant that got infected. Another patient with permanent filler that got infected. It was bioalkymide, and bioalkymide causes granulomatous reaction in the tissue. So you can see the granulomatous reaction with the filler. You have to get them out as one piece and then deal with the aftermath. This is hyaluronic acid, which is HA, and I see it at least once a week when I open the noses. And some of the patients tend to forget that they had it injected 2 or 3 years ago, but it still stays in the nose much longer than the rest of the face. And it's well encapsulated, so you can easily suction it out and excise it, but it's not risk-free because this patient got HA injected and he got embolization and skin loss. When it comes to solid rib, you can easily carve the solid piece of rib and through the open approach, fix it in place, and it will stay. If it didn't warp, it gives excellent augmentation. This rib just got displaced from the midline, so it wasn't fixed correctly, as compared to this rib, which was originally in the midline, but got warped. And warping is a deformation of the graft. So in both cases, you have to remove the rib graft and try to look for something else. Now, solid ear cartilage, I can use in dorsal augmentation, but never on the bony dorsum. If you put ear cartilage as a solid piece of ear cartilage on the bony dorsum, there is always a risk that the borders will get visible with time because it tends to curve and it will give demarcation lines, as you see. While if you put solid cartilage in the supratip area, like in this case, it will give excellent augmentation and the borders will blend with the surrounding tissue. And the skin in this area is very thick to start with, so it can easily camouflage any borders of the solid ear cartilage. Now, wrapped diced cartilage, you can dice the cartilage and wrap it in temporalis or rectus abdominis fascia, and that's the end product. And then you can remove the warped rib and replace it by diced cartilage in fascia. And the DCF will never warp. And you don't really need to overcorrect when you use DCFs, because this is a DCF that I had to take out 4 years after surgery. And you can see all the temporalis fascia is viable and vascular, and you open up the DCF, you find every bit of cartilage is viable and holding together with fibrous tissue. So all the diced cartilage will survive, as you see, and the envelope, the temporalis fascia, will also survive. I'm using much more diced cartilage, which is free diced cartilage nowadays. So I can easily use my Aufrecht retractor as a template and fill it out with the diced cartilage and get it compacted. And then I need something to hold these bits and pieces together. I use fresh blood from the same patient and wait for 3 to 5 minutes according to the clotting time of that particular patient. And I will test my graft if it's rare or well done. Once it's well done and coagulated, you have only one chance to put it in. Otherwise, all the pieces will be on the operating table. So you have to slide your Aufrecht all the way to the radix. You will pull your skin flap against the Aufrecht. When it fits in till the radix, you can drop your composite graft, which is blood and diced cartilage, and the offeret will come out without any pieces of cartilage. This is the last step you do before closure, and that's all the augmentation by diced cartilage and blood. And this is a patient at 1 year after using that technique, which is diced cartilage, free diced cartilage and blood. It was multiply operated, of course, and you can see the dorsal lines are very acceptable. It gives excellent augmentation, and there is no chance that these pieces will warp. Another way of using diced cartilage, you can dice it really fine and pack it in an insulin syringe. As you see, I'm using a regular number 20 blade to dice the cartilage. No fancy terch blades or anything. I'm checking the consistency. If I didn't like it, I will go 1 or 2 more passes to get it really finely diced. Once it is finely diced, I will pack it in my insulin syringe, and then I can inject the diced cartilage wherever I want on the nasal dorsum. Here the syringe is introduced till the radix, and then I will inject, pulling out my syringe. And then you can mold the cartilage and then tape it and everything. So this is another way of injecting diced cartilage or using diced cartilage on the nasal dorsum. And that's a revision case with a huge polybeak. But if you concentrate, the bony dorsum is too low. So I had to excise part of the cartilaginous dorsum and inject diced cartilage in the whole bony dorsum. And as you see, the bones were very pinched, and the diced cartilage gave a much better contour to the nasal bones. Another patient where diced cartilage was injected in a revision case, and that's a 3-year follow-up, and you can see the amount of augmentation is very acceptable. The open roof is much better looking after injecting the diced cartilage. And this is a longer follow-up, 6 years post-op, and you can see that the diced cartilage survives very well and provide excellent amount of dorsal augmentation. Now, if you go to the internal nasal valve, it's another area where ear cartilage can help in revisions. So the ear cartilage is naturally convex, so it can keep the internal valve area open by this spring action. So these are the internal nasal valve grafts that I use. I will create a pocket down to the pyriform aperture to the bone, and then 1 stitch medial to hold it in place. And it will correct these kind of deformities. That's on the operating table. You can see how deep the supraalar crease is. And of course, all these patients have functional problems. And the base was totally distorted as well. Another over-resected case with valve problems, internal valve problems. Once you see these deep supraalar pinching, you know that you have functional problems as well as cosmetic ones. And ear cartilage really helps in this area. When you go down to the nasal tip, in a study we did on the multiply operated noses, the commonest was tip contour irregularities, the deformities in revision, followed closely by the depressed droopy nasal tip, which loses projection and rotation. So the cause for that contour irregularities, that the alar cartilages are not supported enough or they're over-resected, so the healing forces will distort them so easily. So it will result in tip contour irregularities, infratip redundancies, alar notching, alar collapse, and all the other kinds of problems. And these are the contour irregularities we're talking about that we see in multiply operated cases. And they are either deep fissure or facets, which happens in the soft tissue triangle area, or a pinch tip, which is over narrowed by vertical dome division, or a bossa formation, which is a sharply angulated dome pulled away from the midline and causing like a knob on one side. This is a patient after 2 rhinoplasties. She doesn't like the unnatural look of the nasal tip simply because she has a couple of facets in the soft tissue triangle which are retracted and the hanging infratip lobule. So we use ear cartilage and we use perichondrium as well from the ear cartilage, as you see. So it's a camouflage layer over the ear cartilage, and it will give her a more rounded contour of her nasal tip, which looks much more natural than her original nose. Another totally deformed alar cartilages after multiple surgeries, and ear cartilage again can give her a smoother and more natural contour of her nasal tip and a more central columella. Now the soft tissue triangle area is a problematic thing in revisions. So it all relates to the vertical domal angle. On the left, this is the vertical domal angle. On the right, you can see the horizontal domal angle. So when the vertical domal angle gets wider, it puts the soft tissue triangle at a big risk. It can get wider either by a malpositioned lateral crus, which is more vertically oriented, or by a hanging infratip lobule. The intermediate crus is convex and hanging down. Both will widen the vertical domal angle and will result in soft tissue triangle retraction. We described a couple of grafts for that, a simple and an extended one. And you can see the soft tissue triangle retraction in a revision case. You mark the retracted area and you open up, and it's an area with cartilage missing. So simply you put a simple soft tissue triangle graft, hold it in place with a 6-0 Vicryl rapide, and that's the patient at 1 year. The retraction in the soft triangle will be gone. Another case with the same problem, but in this case, I will use diced cartilage. So after closing the incisions, you can easily introduce the tip of your insulin syringe and inject both soft tissue triangle areas. And you can see I have holes in my syringe, so any fluid will be squeezed out of the holes that I drilled in the insulin syringe. But it will fill these triangles beautifully. And we can see the patient at 1 year with the soft tissue triangle well effaced and look more rounded and more natural. Now the bossa formation, when you have a sharply angulated dome pulled away from the midline, you have to free that cartilage from the overlying skin and from the vestibular skin. And then you have to put a strong midline structure to suture the cartilage too. And then I like to use this camouflage graft. I leave part 1/3 of the graft non-crushed, and then the middle third will be semi-crushed, and the upper third will be fully crushed. So I have part which is totally uncrushed, it is solid cartilage, and part which is medium crushing, and the tip, the upper third, will be fully crushed. And the stoke of this graft, which is not crushed, make fixation of the graft very easy to the underlying strut and medial crura complex. So I can easily suture my solid cartilage. And then this is the medium, and the fully crushed part can easily turn over the domes. So even if I have a little asymmetry in the domes, this cartilage graft can provide excellent camouflage. So it extends all this area, and again from the side above the tip a little bit. And this is the patient after suturing techniques and camouflage grafts. Again, she came from Hamburg after 2 closed rhinoplasty with this big bossa, and we did the same. And if you concentrate, she has a wider tip than before surgery. And the patient has to understand having a wider and stronger and more stable tip is much better than having a very narrow and weak tip that will get deformed with time. You have to make the patient understand that. Again, a big bossa before and after correction using the same technique. If you failed in the suturing and camouflage way, then you will have to amputate this tip and start from scratch. This patient had a couple of surgeries and every time the tip goes to the right. So I had to excise everything and put a totally new ear cartilage cap graft with a double layer ear cartilage, and the patient will remain in the midline at 1 year. Now the alar cartilage, when it's over resected, it may cause supraalar pinching, alar collapse, or alar notching. So I'm opening the case in one of the meetings. That was the first Bergamo meeting, I guess. And it was a multiply operated case. And the minute I opened the nose with the first snip of my scissor, I find that the cartilage is gone. So she has like a 1 to 2 millimeter wet of lateral crust. This will never give enough support to your ala, and the patient will collapse like this, whether they have thick or thin skin, and this patient will collapse on the left side. This patient will again collapse when she comes to breathe on the left side. So in these cases, you use lateral crural strut grafts, which was described by Jack Gunter. And I use them again using ear cartilage because they are naturally convex. You can fix it as an onlay or underlay. She had 2 surgeries and you can see the collapse on the right ala. And after placing a lateral crural strut graft made out of ear cartilage. And the nose will be much more symmetric. Again, same problem, different patient, corrected with ear cartilage. Now, another advantage, it can easily bridge this gap between the alar lobule and the tip lobule. When you have this demarcation, it doesn't look natural. So just by using ear cartilage, you can get a smooth transition between the alar lobule and the tip lobule. So the nose will look much more natural than the pinched look that you have in multiply operated cases. When you have notching, you can use an alar notching graft, but in that you need septal cartilage, not ear cartilage. It's very difficult to use. And this is an example of an alar notching graft. And in moderate cases, even you can use alar notching graft and a tongue and groove at the same time to close up this notching. Very rarely when a patient refuses to have surgery, you can put a drop of hyaluronic acid at the apex of the alar notching, and it will improve it on the spot, as you see, as you withdraw the needle. But this is, again, very risky maneuver because these patients are multiply operated and you're injecting under severe tension. So if you find tension, don't try to inject because that's how it will end. It will end up with necrosis of the whole ala, with embolization. I see that a lot. Patient who had hyaluronic acid injected. So this is a very risky area. So if you have severe notching, the alar rim graft will not help you. You need to use a composite graft. So the area where I get the composite graft is right under the inferior crust of my antihelix. It's an excellent area to camouflage because that's the part I take, and that's closure using 5-0 Vicryl Rapide, and that's at 3 months. You can see that the scar is almost invisible, and it is camouflaged in the shadow of the antihelical fold. And that's the amount of improvement you can get with the composite skin and cartilage graft to bring down the severe degrees of notching. Again, a severe degree of notching on the left side, you can see after a composite graft. I never promised the patient they will be identical, but I tell them that the difference would be much less if we use a composite graft. If you test the nose and you don't find any support in the revision cases, you look at the medial crura, they are totally buckled, and you look at the septum inside, it's flimsy and buckled as well. So you have to replace everything with a caudal septum replacement graft, which is a huge graft. It's not a strut. It's a huge graft replacing the whole caudal septum. You use it in secondary cases with excised caudal septum when you find it missing, or even in primary cases when the caudal septum is very high and receding, or in primary cases following trauma or septal abscesses. So here is the missing caudal septal segment, and here is the caudal septum replacement graft with the remnants of cartilage sutured to it, and that's the amount of improvement that you will get out of this graft. The nasolabial angle will get wider, the tip will get more supported, well projected and rotated. If you have enough septum, you can use it. If not, I go to ear, and I never use it as a single layer. You have to double layer the ear cartilage in order to change the curved ear cartilage into a double layer straight piece of cartilage. The perichondrium is intact on one side, as I said, and you throw in a few sutures, PDS sutures, to hold this, and this can easily replace and provide support to your nasal tip. That's the patient with this technique at 1 year, and that's the same patient at 16 years post-op. So the polybeak didn't come back, and the depressed tip is well projected and maintained in position. This guy had a septal abscess. He came from Zurich. He had the same reconstruction technique with a double layer ear cartilage graft. It gave him well support and projection. It helps in the Miss Peggy nose, which is very short. But in these cases, I don't just double layer my cartilage. I will double layer my cartilage and leave the rest of the concha to give me more length for the nose. So it's like an extension graft, but it's an ear cartilage extension graft. You can fold it on each other. You will double layer the distal part of the graft only, but the rest will be a single layer conchal cartilage that you can easily fix to the remnants of your caudal septum. And that's the amount of length that you will gain in the very short over-rotated noses. You can see the amount of length which is like a centimeter or a centimeter and a half. And to fix it, you will fix it to one side of the nasal septum. It doesn't matter if you fix it to the right or to the left, because the distal part, which is double layered, will always be central and in the same line of your nasal septum. So this is the caudal septal extension graft. I usually fix it by 3 sutures, not 2, as you see, to the caudal septum, and that's the amount of lengthening you can get using this kind of graft. Again, very short noses, over-rotated, and it can significantly lengthen your nose and maintain the degree of projection you want. This with very thick skin. Again, he had the same technique with the caudal septal extension ear cartilage graft, and you can see the degree of support that he has. I will conclude with this quote of our Hypatia of Alexandria: reserve your right to think, for even to think wrongly is better than not to think at all. This is my life surgery fellowship, and the next is the 18th life surgery fellowship. It's the only hands-on surgical fellowship where the fellows can scrub and do all the techniques themselves. And these are batches from different previous fellowships. Thank you very much.
Thank you, Dr. Foda. Wonderful lecture on ear cartilage and many other uses of it. So, any questions from the audience? I would like to ask you.
Yes, sir.
The ear cartilage, can it be diced so well as we can do with the rib cartilage, or?
Yeah, actually, it is much easier to dice the ear cartilage, much easier than the rib cartilage. But the key thing is to remove the perichondrium when you dice the ear cartilage. You don't dice it with perichondrium. You have to remove the perichondrium and then dice everything. And you can easily mix it with the remnants of septal cartilage or cephalic trims or whatever. You can combine everything and dice them together.
So do you cut those cartilages in pieces first and then dice, or straight away go just hit it with a knife? How do you do it?
I don't really bother. I have a nurse that can dice anything. Right. You just give her the thing and she dice it.
Good, thank you. Yeah, I understand that.
Yeah.
So any more questions? Wonderful lecture, and you
Thank
have
you,
shown very new techniques about using ear cartilage as a septal extension graft. That was wonderful. I've never seen that before.
I didn't publish it yet, but anybody else will publish it before I do, I know.
I think so. Yeah, this is novel idea. This is a really novel idea. So, well, thank you very much. So,
thank you, sir.
We should meet sometime in future physically, and
maybe in Bergamo.
We should put an end to these virtual meetings now. I think Corona is long gone, and virtual meetings should be stopped now. There should be physical meetings now. Dr. Sunil, over to you.
Hassan, can I just ask one question? Sandeep.
Yeah, sure. There's a question from audience. Yeah.
A quick question. You use blood for your diced cartilage. That's just pure blood. You're not doing PRF or anything like that. You just literally
no.
blood.
Just pure blood. I wanted to hold it together for a few minutes till I introduce my graft.
But is that enough to hold it?
Yeah. After that, it will solidify. Actually,
okay.
It's like a solid piece. When I see the
I've never
patient
tried
at
pure
6
blood.
months,
I've just never. Yeah.
No. The key thing, I want something to hold the pieces together till I introduce them on the nasal dorsum. After that, everything will get resolved.
Sure.
And what will remain is the diced cartilage piece. It will
so
hold
the blood
together
will
with
not
tissue.
Blood will not cause any reaction, as it is known to cause.
No.
Why would it cause reaction? It's fresh blood.
Sure no.
Yes, it's nothing.
Okay. Good. Actually, this was good technique. Yeah, I think I've seen it before.
Instead of a glue.
Yeah.
Instead of the glue, I mean it's an
autogenous
autogenous
glue. Yeah.
Yeah.
So wonderful discussion, Dr. Sunil. I think thank you, Dr. Foda, again.
Thank you, sir. Thank you, Foda,
Thanks,
sir.
Lokesh.
Clapping,
Thanks,
please.
Sunil. Thank you very much.
Thank you so much. And Dr. Sunil, sir.
Yeah,
yes, over to you. Sir, just switch on the mic, please.
I think due to the time restrictions, I think we should skip the panel, and we have our only video sessions. So I think in the next half hour, we all are free for that. So we start with the video sessions. You start.
If are you agree with the sir, then clapping, please. Feeling comfortable now. So thank you so much, Dr. Pradeep sir and Dr. Lokesh sir. So I would like to invite here Dr. Kapil Agrawal sir for the video presentation. Thank you so much.
दिखा दो ना सर, जितने हैं दिखा दो। 5 मिनट का होगा तो वीडियो में बस सही ओहो 15 मिनट क्लोजिंग में भी तो लगेंगे। हाँ तो बस
show the counterbalancing or Namaste technique to overcome warping in costal cartilage. Operative video harvesting the cartilage. Hi, this is Dr. Kapil S. Agrawal presenting a short operative video and an animation video to show the counterbalancing or Namaste technique to overcome warping in costal cartilage. Operative video harvesting the cartilage, taking 2 parallel incisions. Hi, this is Dr. Kapil S. Agrawal presenting a short operative video and an animation video to show the counterbalancing or Namaste technique to overcome warping in costal cartilage. Operative video harvesting the cartilage, taking 2 parallel incisions to harvest pericondial strip. Pericondium is being harvested, marking in midline, dividing into 2 equal pieces. Again, marked and dividing into 2 equal pieces, reversed, suturing in midline, carving it from all sides without cutting the sutures, covering it with pericondial strip, filling the dice cartilage in between the pericondium and cartilage sheet. Final shape like an photographed compact implant. Animation video.
Marking done in inframammary crease. Incision is being taken. Showing 6th rib cartilage. Harvesting the perichondrium by taking 2 parallel incisions. Perichondrium is being taken out. Cartilage graft is separated and is being taken out. Marked in middle line along the long axis and cut into 2 equal pieces. Reversed and sutured in midline either side by side. Or it can be sutured as in stack, suturing similarly in midline. Graft is being carved without cutting the sutures, covered with perichondrial strip and filled with diced cartilage in between to make DCUP dorsal strut. To prepare other struts, you can take multiple chips in the same direction and suture similarly in midline to make straight struts. Incision is being taken to open the nose. Two curved cartilages kept alongside the curved septum and sutured together to make the septum straight.
Advantages of counterbalancing technique. There is no wastage of cartilage. All pieces can be used. Whole available length of the graft can be used. No intra-op waiting is required. As you cut, they start bending. All the grafts can be prepared. The outcome is pleasing and predictable. Advantage of DCUP dorsal strut. You get best of the both worlds. Solid counterbalance base plate checks early postoperative contraction forces, while dice cartilage on top, covered with pericondium, gives smooth, rounded, soft and natural looking dorsum. Clinical examples. Crooked nose correction with the counterbalancing technique. You see the absolutely straight nose. Same here. Augmentation nanoplasty. Absolutely straight nose with natural dorsum. Results are long lasting. Conclude here with counterbalancing technique. The warping seems to be a complication of past. The concept of DCUP has brought new dimension to dorsal augmentation. It works like a custom-made implant, gives flexibility in designing the dorsum, producing very aesthetic, softer, and natural-looking dorsum, which can withstand early post-operative contraction forces. Namaste.
Audience, any question from your side? No one? Thank you so much, Dr. Kapil. Now I'll request to Dr. Rakesh Kumar sir, please come on the stage. Achha, sorry. Dr. S. Gambhir sir for the video presentation. अभी तो एनर्जी वाली क्लैपिंग मिलनी चाहिए ना थोड़ी सी. बिल्कुल. और अभी लास्ट में तो मैं बहुत अच्छी वाली क्लैपिंग करवाने वाली हूँ. 2 days जो इतने अच्छे रहे हैं आप सबके एक साथ, कहीं ना कहीं एक नॉलेज भी आपस में एक्सचेंज हुई है और एक गेट टुगेदर भी रहा है. सो उससे पहले मैं आगे बढ़ती हूँ और डॉक्टर एस गंभीर सर को इनवाइट कर रही हूँ वीडियो प्रेजेंटेशन के लिए. प्लीज कम ऑन द स्टेज सर. थैंक यू सो मच.
The other thing is, if there are multiple fracture lines in the septum which are deviated due to the trauma, then you have to get off the septum, make it straight. and then do the 3-month fixation. The last one is in secondary rhinoplasty. This fine, there's something which is there, which is ingredient. Then you use the cartesian arm, make it straight, and then put it down.
This is a patient with severe deformity of the septum following trauma. As you can see in the video, there is severe deviation both in the cephalopolytic direction as well as the superior inferior direction. You take out the septum in this patient and make it straight. Either take 2 pieces and make them straight by sutures, or you can find some straight segment. Most of the time in the cephalo-inferior part, you can find it straight along with the ethmoid, which you can use. Once you put this in place, then you have to fix in 3 points, which are very important. And for the 3-point fixation in extracorporeal septoplasty. The first point is the nasal bone. You make holes in the nasal bone on both the sides. What we're using is a drill. Isotone, if you have got, the drill is more than sufficient. You make hole on both the sides and then pass the suture. What suture we are using in this patient is basically 40, but you can use 4040 also. First, the suture is passed from the nasal bone on one side through the septum and coming out of the nasal bone. Once it is done, then in the form of horizontal mattress, the next point of suture is taking it from the upper level cartilage, septum, and then upper level and then tangent. After passing the suture, normally we do the osteotomies before we tie the sutures. So tying should be done after the osteotomy. So once we are done with the fixation of the first point, that is the distal area, then we move to the fixation, that is the fixation of the spine to the infracephalic end, infracaudal end of the spine. First, we make holes in the spine, then we fix it with previous 40 or 4030 if you want. This is a very important feature to provide support to the table. Now, on the third part of the fixation, that is fixation with the septum. This will be in the form of this upper level cartilage, septum, and then again to the upper cartilage, septum. This 3-point of fixation is very important to prevent the collapse of the septum. Now, once this session is done, then we move to the tip area as condition of the straight septum is clear and plastic. Without straight septum, the favorable result there and not get you see this patient with a crooked nose, which we have done for more videos, you can subscribe to my channel.
Thank you so much. Now I'll request to Dr. Lokesh Kumar, sir.
Again, thank you, Sunil, for this opportunity to be with you and participate in this conference. There are 2-3 small videos just to elucidate some of the techniques which are used, tips and tricks. So this is 1 minute. Yeah. Okay. So this is the preparation of the graft. I think you saw Dr. Kapil could not show yesterday. I think there was no video for graft preparation. Yeah. क्या हिल रहा है? छोड़ दे भाई, अब नहीं जाएगा. अरे फिर चला गया. हाँ क्या करें? फुल स्क्रीन ये ले. क्यों जा रहा बार बार? नहीं लो फिर गया. कुछ तो गड़बड़ है. वहां पे लगा दे. वहां लगाओ जहां मर्जी लगाओ. पीपीटी में ऑडियो नहीं है।
And we should, I think, have a common group photo, na? And my heartfelt thanks to join this delegates this program, especially the people come from the Bangladesh also. So thank you, doctor, for the joining. And soon, after 1 year, we meet for a new program again. And I think if you have any query regarding the your patients or rhinoplasty, you can contact any time too. And I think one more good suggestion for you, I think you become a member of the Rhinoplasty Society of India. So the Rhinoplasty Society of India, all the past lectures, webinars, lectures, they archive in the Meditube. So you can access there all type of the Dr. Dean and Dr. Osam Foda, Sandeep, around I think the 40 lectures there. So you can access there. So you should become a member of the society. That is good for you. And again, yeah. And thank you again. Thank you so much, Dr. Kapil, Dr. Lokesh sir, Dr. Gambhir, Dr. Vishwas, especially. Thank you so much. So I think we should have a group photo. So you all of you come forward.
I'll request to all, please come on the stage for the group picture. और ग्रुप पिक्चर के साथ ना एक एनर्जी वाला सॉन्ग भी होना चाहिए। बिल्कुल, कोई भी एक सॉन्ग आपको जो भी लगता है कि हाँ पैट्रियोटिक सॉन्ग या कुछ भी, चैंपियंस सॉन्ग।
My special thank to Dr. Sunil Samdani sir. Dr. Sunil Samdani is a present head of department ENT SMS Medical College. Sir कल से पूरा सेशन अटेंड किया है. Thank you sir.
एक म्यूजिक चलवा रही थी मैं, थोड़ी सी एनर्जी होनी चाहिए। कल से सब इतने सीरियसली बैठे हुए हैं। आई रिक्वेस्ट टू ऑल प्लीज कम अगेन एवरीवन। एक बार सभी लोग एक बार फिर से आ जाएं। यस, एक वीडियो के लिए लिटिल बिट प्लीज कम। सभी से रिक्वेस्ट एक बार प्लीज आ जाइए। सॉरी, म्यूजिक प्लीज। प्लीज सभी आ जाइए। विदिति आप भी आ जाओ सब। All are champions. Seriously, you all are the champions. Really, salute you all. एक साथ, come on. थोड़ा सा little bit. Sushila ma'am, please join. Viditi, come. Everyone, please come. You also join. Everyone. Sir, please आइए. आप दोनों भी आ जाइए. Please आइए. सभी आइए. Sir, please एक मिनट के लिए आ जाओ मैम. Come on, everyone. Sunil sir. Yes. Everybody, fly your hands. Come on. Show the sign of the victory, please. Sir, you come here, please. And thank you so much, everyone. Thank you. Thank you. Yes, 3 cheers for Sunil sir and Pradeep sir, Tarun sir, and entire team. Hip hip! Hip hip! Hip hip! Thank you so much. Thank you each and everyone for giving your valuable time to us and making this rhinoplasty conference very, very successful. Thank you so much again. Very, very thanks to all. Thank you. And thank you, audiovisual team. Yes, seriously. Kuch nahi tha. Same production, right? Thank you so much. And entire camera team, thank you. And thank you, hotel staff. Sabhi ka bahut bahut dhanyawad. Thank you. And photography team also.